Oh, hi, Dennis. How are you? I don't think I'm able to hear you, Dennis.
Now?
Oh, that's better. Yeah. Good to see you.
Come on a Sunday morning.
Oh, your volume's very low, I think.
Hi, I'm Ruhi.
Hey, Ruby, how are you?
Can you hear me?
Yeah, it's good. Can you hear me?
Yep, loud and clear.
Great. No, it's good to have you on board. How are you?
I'm good.
Good, good.
And where are you calling from?
I'm from Melbourne.
Oh, okay. So
Yeah,
you're pretty close by.
not far away. Yeah, better time zone. We had a meeting in the morning with Europe. It was
Oh,
like 6 o'clock in the morning here in Melbourne, so it was early. So
okay.
yeah.
So I noticed we have quite a long session, from 10:30 to around 1, almost 2 o'clock.
Yeah, they're long sessions. We gave people half an hour. They used to find that 15 or 20 minutes wasn't long enough. So we're experimenting with half an hour slots, which means that it just takes a little bit longer to get through the individual sessions.
Right. I
Yeah,
presume we can like switch off our video for a while and nip over to, you know, do some urgent things and come back, like 2 minutes or
uh,
3 minutes.
yeah, sure. Yeah, absolutely. So the moderators sometimes throw questions around to the panelists as well. But yeah, if you have something urgent to do, if you switch it off and go and get it done, that's fine. Yeah, sure.
Okay.
We have some interesting talk. So
Oh, yes. I was just
where are you
going.
from? Where are you from, Ruhi?
Uh, I'm from Malaysia. I was born here.
Okay, great, good.
Um, it's a very diverse country. We've got
Yes. Oh,
people from all over.
yeah, it seems to be a big melting pot of populations in Malaysia. So it's
That's right.
it's one of these ongoing, if you like, transformations in culture. A number of cultures coming together and people, and so it'll be interesting, I think, in the next 15 to 20 years as to what Malaysia
maybe for especially India, no, it's 8 a.m. in the morning. So people will be a little late to join. They'll prefer to join at 8:20 exactly.
Okay.
So Marini, I'll be doing the basic case to little complex so that we have all clarity about the head radius, everything. So it's not just all difficult cases which I have picked up.
Yeah, I think that's good because it gives the often the participants have a very wide skill set.
Yeah.
So therefore, having some cases which may demonstrate the principle, and then having some more complex cases that demonstrate the application of the principle to complex cases. That's a nice way of sort of teaching as well as sharing.
Dennis, where are you from?
Me? I'm from
Yeah.
Hong Kong. Yes, Hong
Okay.
Kong. I worked with
Awesome.
Christian Fang, who is the secretary of this meeting previously. Yes.
Okay.
Nice to meet you.
Good to meet you. One of our favorite places to visit, Hong Kong.
Yeah, just now we have COVID,
Actually,
so we can't go anywhere.
Well, everybody has COVID.
You know,
I would be visiting Malaysia. I mean, originally because of the APOA, but we cannot.
Right.
Sorry.
That's right. That's right.
Yeah, so we need to wait till end of next year.
I came to
Or
Hong
is it-
Kong last year. You know, I was there last year, June 2019, and the protests were going on. So we could see 1 million people outside our hotel window.
That's not something you could see every day.
Well, if you want to
The
look out,
light-
if you want to look out of your hotel window and see 1 million people, you can come to India anytime you want.
Yeah. So those protests have died down now, Dennis, or is it still?
Yes, it's kind of died down because of the COVID policy and because of some very strict legislation. So
Of course.
to this second day of the APOA's web-based Trauma Congress for 2020. I am Marini Papyrus, the president of the Asia Pacific Trauma Society, which is a subspecialty society for those that did not hear the introduction yesterday of the APOA. As we're all aware, 2020 has had its challenges, and we've had a year of intermittent social isolation, quarantine, personal protective equipment, and it's all due to the coronavirus. So I think it's important we take a few moments just to reflect on everyone who has been affected, who has suffered or succumbed from the effects of the pandemic. During this time, the APOA has chosen to remain active and to provide formats where the membership may remain connected, because we're a socially driven species, and as human beings, we enjoy interaction. We aren't going to allow a small virus to become a significant obstacle to our humanity. And I've been inspired by all our members, particularly our trauma members and emergency surgeons, who have had little choice but to stand up during this great time of uncertainty, in these unprecedented times, and provide surgery and care to the best of their ability, often placing their own health at stake. And it's with this commitment and passion that we present this Congress to once again give us a great opportunity to exchange ideas, share concepts, and describe our tips and tricks in the management of musculoskeletal conditions. I'd like to personally thank the executive team. This year, we've expanded the trauma executive to include a member from each of the chapters, and I say welcome to all our new executive members. I'd also like to thank the APOA Council for all their support. Yesterday, we were very fortunate to have our president, Mahmoud Nadim Doral, welcome everyone to this meeting. I'd also like to pay my gratitude and respect to Jamal Ashraf, a good friend and colleague, the APOA General Secretary, who has done a mountain of the heavy lifting behind the scenes, and Christian Fang for putting together a wonderful meeting that we enjoyed yesterday and will enjoy today. I'd like to thank the Executive Committee, including Anup Agarwal, our President-elect from India, Wael Taha, our Vice President from Saudi Arabia, Hakan Klinik, our immediate past President, and of course, Christian Fang, who I've just mentioned. And I'd also like to welcome the National Trauma Delegates. We're a society that's growing, and is growing not only in terms of the delivery of information, but also educational resources. We have a number of people joining us: Dr. Abdullah Al-Zarani from Saudi Arabia, Apipop Kritsani Falbun from Thailand, Changwon Oh from Korea, David Jua from Australia, Dennis Yi from Hong Kong, Guverneur Oksu from Turkey, Harpal Singh Seli from India, Israr Ahmed from Pakistan, JP Leong from the Philippines, Leah Maliana from Indonesia, Mernkung Wong from Singapore, Quasi Shahidul Alam from Bangladesh, Saeed Al Thani from the UAE, Sankara Kumar from Malaysia, Sudeep Man Vaidya from Nepal, Yoshinobu Watanabe from Japan, and Yuping Su from Thailand. So we can see from this that it's a very diverse and inclusive group, including people from all our chapters. The other theme of the meeting is really a theme of introducing and welcoming all our female trauma surgeons and highlighting their importance to our increasingly diverse and inclusive membership. I'd like to particularly welcome today Professor Sharifa Ruhi, who is the current president of the Malaysian Orthopaedic Association for the 2021 annual year. So welcome to our meeting, and we look forward to your thoughts. I'd like to welcome all our female panelists today and presenters, and I look forward to your contribution as you inspire the next generation of trauma leaders. Yesterday, we enjoyed a series of 18 presenters with a number of case-based scenarios on the femur, humerus and elbow, knee and tibia, and audience Q&A. There were over 62 case-based scenarios that were presented, and I was fascinated by the information and also the quality of the care provided by these surgeons. Today, we have 17 leading trauma experts who will be presenting a series of 17 sessions, starting with the forearm, wrists, followed by the foot and ankle, and finally the pelvis and acetabulum. Please engage, ask as many questions as you like through the Q&A, and help make this meeting a great success. So I would like to now invite our moderators, Abdullah Al-Zarani and Dennis Yee, to take over the first session for the forearm and wrist. Thank you very much and enjoy the day.
Thank you very much, Professor Perinis, for your great introduction. So with no ado, let the first speaker, Professor Anup Agrawal, to talk about isolated radial head fracture. So the stage is yours, Professor.
Okay, thank you, Dennis. Thank you, Manny. So I'll start sharing my screen. So very good morning from India. Thank you, Marini and Jamal Ashraf, for including me in this mega academic show. So my talk of today is head radius fractures. So I'll start with the learning outcome of this talk is to understand the different types of injury of head radius, to classify them, and actually know when to use which approach, and what are the different modalities of management, and what complications we may occur while managing these fractures. So this is the case one, a young male of 44 years of age, history of injury to right elbow and RTA. It's a 5-day-old injury, came to me after 5 days with a plaster slab with no comorbidity. So on examination, what I found was there was a 10 to 10 degree extension loss and almost full but painful flexion. And this is the most important part of the examination when you find that all the movements are almost normal. So you have to look around all around the elbow joint to look for any bruising and the tenderness. In this case, what we found was the tenderness over the head of the radius. We got this X-ray done. So any comment on this X-ray from the panel?
Maybe Professor Randy,
Yeah. Looking at the radial head, there is some irregularity and appears to be a fracture of the radial head on this one. It doesn't look very comminuted, but certainly, now we're used to getting better imaging with digital imaging. So I would try to zoom in on that and see if I see any comminution or any reason for concern. But largely, my assessment at this time would be clinical. Did you want me to carry on how I would manage it, or just X-ray?
No. Just with the comment on this X-ray. So would you like to do anything else after this X-ray? Would you like to investigate further, or you'll be just satisfied with this X-ray?
So, from the history, I'd like to find out if there was any associated dislocation. And then I tend to do a clinical exam after this, and then a CT scan would be based on my clinical exam.
Perfect. So any other panel have a different opinion? No. So I shall go forward. So we got an CT done. So Randy, as you said, the clinical examination in these kind of fractures are very important. As I said, that you have to look around the bruises on both medial and lateral side. And many of head radius fracture, you get the bruising on the medial side of the joint and tenderness over the head of the radius while you're trying to pronate and supinate. So on CT, what we got was an impacted fracture neck of the radius. So how, any panel to comment on the management? How are we going to manage?
So it is relatively undisplaced, and there seems to be no dislocation or subluxation because the radial head and capitulum seems to be articulating well. So I probably would just treat this conservatively. Yeah.
Okay. Okay. Thank you, Dennis. Any other opinion?
To me, the important thing is whether they have a block to forearm rotation. So I tend to aspirate the hematoma from the posterolateral corner of the elbow, and I inject some ropivacaine into the joint, and then I ask them to do an active range of motion. And if they have no block to forearm rotation, I tend to treat this non-op, which is why I usually do my CT after the forearm exam, only if I'm planning surgical intervention. But yeah, I would
Right.
probably do nothing else for them. 1 week in a
Perfectly
sling.
said, Andy. I think this is the, yeah.
I would agree with that. From the x-ray, I was a bit suspicious because the head looked a little depressed on one side. So that may be one reason why I would order a CT, but otherwise I would go with what Randy is saying and only order the CT if I think I'm going to operate on this one.
Yeah, perfect. So the big point which has come up with the discussion is that while clinical examination, if you're suspecting a head radius fracture, you need to look at the range of movement while supination, pronation, whether it is blocking or not. And if you find it is blocking, then CT is must. You have to make sure. If you find it's not blocking, perhaps you can get away with the conservative management. So we really need to classify all these fracture head of the radius, and we need to know that how they can present. They can present with a simple fracture where medial collateral ligament is intact or partially torn, or they can present with all other secondary stabilizers intact. So that's a simple fracture, or they can present you with wide variety of complexities with other fractures like coronoid, olecranon, or proximal ulna, or maybe with dislocations. So this is the most common classification which we all know, that Masson type 1 is non-displaced, type 2 is minimally displaced with depression or angulation or impaction. Masson type 2 is comminuted and displaced, and type 4 is radial head fracture associated with dislocation of elbow. So I would keep it in type 1. So would you agree that we keep it in type 1 or type 2?
Professor Rudy, what do you think?
Yeah, I would say it's type 1 after looking at the CT. Otherwise, from the x-ray, I might go with type 2.
Right. So that there lies the, I think, significance of CT. You know, in today's world where there are so many complexities of medico-legal complications, I think it's better to have a CT done and make sure that what kind of fracture actually you're dealing with. So I went through, as Dr. Andy said, that with conservative management, I gave him a plaster for 3 weeks. And very important is that you do not extend your plaster for more than 3 weeks. And as soon as you remove the plaster, start range of movement exercises. So anybody has a different view or different way of managing these kind of fractures? Or they agree that we need to start range of movement exercises after 3 weeks of the plaster?
Well,
I start, sorry, go ahead, Rudy.
Well, I would put them for minimum at least 2 weeks, but I would also like to know from the patient, some of them want to get back to work almost immediately. So in those instances, then I may not treat it conservatively, even if the imaging is favoring it. So if they are keen to get back to work immediately and do not want to have a cast, then I would probably treat that surgically. I just wanted to say that bit.
Okay.
Anup, hi. Is there a role for just immediate range of motion with a sling for comfort?
See, actually, since this particular fracture was impacted, perhaps one can think about just putting him on the sling. But to initially stabilize all the soft tissue, perhaps you need 2 to 3 weeks of the cast so that all the swelling and all soft tissue stabilizers get healed up. And then you start range of movement exercise so that you get full range of movement. That's what most of the literature says.
Okay.
Nope, I've tended to move these early after a week. So they get a ice sling. They get a splint for wearing at night so they don't roll over in bed and hurt themselves. But I found that if I immobilize them more than a week, their recovery gets prolonged, and my usual concern is a flexion contracture.
Yeah.
So I feel that 3 weeks of immobilization may predispose people to flexion contracture. Now there are differences in different ethnic populations, and I know that Indian patients get stiff less commonly than some Caucasian patients, and certainly I find that 3 weeks of immobilization for a stable distal radius fractures without an elbow dislocation may cause flexion contracture. So I tend to move them early at a week, as I'm sure Marini does.
And I think that was the key, that concept that Randy sort of shared and touched upon earlier, which was the clinical examination and the stability. Because if it's truly isolated and relatively stable, I actually suggest to them that they try and get full extension as early as possible, because that's what they tend to lose. And you've got to tell them straight up that they may lose some of their extension in the healing process.
Yeah, right, Marini and Randy, actually the concern about movement is only the last 10 to 20 degree of the extension, which many of the patients, and the last 10 degree of the supination, which is of concern in these kind of patients. So that's right, that it differs on the ethnicity and the region where I will place. In India, we do have a problem that most of the patient does not follow up properly with the your doctor. So that could be a problem. So the crux of the story is these undisplaced fracture is that as soon as the pain gets over, swelling gets over, maybe 1 or 2 or 3 weeks of the plaster, you'll have to start the early range of movement. And as rightly said by Marini, that to start with getting full extension, because that's the concern. Am I right, Marini?
Oh, yes, sure. Yeah, Nupa, I was just presenting an alternative way of, because in Australia, we're a little bit, sometimes they don't push as hard into extension, so we have to remind them.
Yeah. So this is how at 2 months, the patient could regain full movement. So the learning with this is that you need to do a proper clinical examination. If any doubt, get a CT done. Early range of movement, especially extension, is the key to success to get a good functional movement, painless movement in these kind of patients. So I'll go ahead with the next case. So the next case is a female of 33 years, housewife, fell at home. She's diabetic, she's obese. This is the X-ray. So comments are invited on this X-ray, that which type.
How about Professor Rudy? Can you?
Yes. I think it looks like a type 2. From what we can see on the AP view, there is a bit of compression on the medial side. So, okay, we got a sneak peek there.
Sorry.
So what I can see is the head seems to be intact, but it's the neck that's fractured, and on the medial side, it's compressed a little bit. So yes, I would go ahead and get a CT.
Okay. So this is the CT.
Okay.
So can you see the head?
So
Yeah.
yeah. So the head, can't really see very clearly, but I see the head there, and it does seem to be very compressed. One part here seems to be, there's a little fracture there. Yeah. On this side, there's 3 parts actually, so it's not as straightforward as we thought.
So there lies the importance of CT scan. As initially Randy said, that unless you picking up the patient for operation, so for any patient where you're looking for operating, CT has its own significance, so that you can really plan and tell your patient the prognosis about it. So how are we going to go about this fracture now?
You want me to answer that?
Please go ahead.
Okay.
Okay.
So this is a type 3. I would put it as a type 3. And so what I would now do, obviously, we would need to operate on this fracture. So what I would do is try to convert the 3 pieces of the head into one piece and try and reduce it and then fix it either with a plate or a couple of cannulated screws. Now, one of the things that I would like to have on standby is a head replacement set, just in case I'm not able to put it together, because that's always something that we need to bear in mind.
Right. Randy, your opinion. Do you differ or you have something different opinion about this?
I totally concur. I just wonder if that one fragment that I'm seeing, there is an avulsion of the lateral collateral complex.
Yeah.
Yeah, but I agree with Dr. Ruhi that keeping a radial headset is always a good thing to have available if your fixation doesn't happen.
I think that's the key. No, anywhere if you're planning more than 2 fragments, if you're planning for fixation, always keep the radial head into this. So what will be our approach in this?
And sorry, Anup, one
Yeah.
more thing that I would keep
Please.
handy is bone anchors. So, just in case we need to do lateral collateral reconstruction or just the repair is not possible. So that's the other thing that I would keep handy. Sorry.
Perfect.
Can I ask, how about the age? If the patient, I mean, is there a certain age that you want to really fix the patient? Like 20 years old with this, you definitely don't want to put in a prosthesis, right? You want to fix it as much as you can. So, what are your age consideration in this?
See, if you look at the patient profile and if you find that bones are quite osteoporotic and age is beyond 50, then perhaps you do look at that probably you need to replace. But head of the radius as such is all cancellous bone, and that part of radius, if you look, is compared to the distal radius, doesn't get as osteoporotic as compared to other bones. So, and the results of vis-a-vis fixation versus replacement of the head of the radius, they both are almost same, except that chances of secondary operations after replacements are least. So you need to always explain the patient that this is a kind of thing which we are doing is, and yes, you might require a second operation if it doesn't get united. So on table decision is equally important, that any head of the radius which is not constructible well on the table, you need to replace without any doubt.
Thank you. Please continue. Yes.
Yeah. So which approach will you operate? So there are 3 approaches. That's for all the delegates that commonly you can access through the head of the radius. That's posterolateral, lateral approach, and posterior. So the commonest one is the lateral approach. That's the Cocker approach. I'll just go through few the slide. This is an approach extending from the lateral part of the lateral side of the humerus towards the forearm. You cut the skin and you need to go in between the enconeus and extensor carpi ulnaris. That's the plane. It's absolutely an avascular plane. As soon as you go, you get to see the fascia and the capsule. And as soon as you cut, you have your head of the radius right in front of you fractured. So there are, you do a temporary fixation and then you can go ahead. But there are certain important factors once you're operating fracture head of the radius or opening on those sides. One is that you're worried about the radial nerve, and another is where to put up the plate. So I'll give certain surgical tips that how to avoid injuring your nerve. So how to do that is that you have to keep lateral collateral ligament origin intact. Whenever you are operating and opening, keep the arm fully pronate. That will keep supinator more anteriorly and your radial nerve more anteriorly. So chances to damage will be less. Beware whenever you are trying to incise the capsule, never go anteriorly beyond the midline, because as you go anterior, you might damage the radial nerve. Whenever you are dissecting, try to avoid any dissection beyond the annular ligament, because there again lies the radial nerve. So these were the 3 tricks which we need to know while you are operating these fractures, and where to put the plate, because it's really critical. Sometimes you try to put the plate at anywhere, then you get the restriction of the movement. So this is what Hotchkiss has told, that's called safe zone. If you make 3 such marks made on the forearm neutral rotation in full pronation and full supination, what you find is if this is the neutral mark and this is anterior half in full supination and this is the posterior half in full pronation. So from neutral to anterior 2/3 is safe, and from neutral to posterior half. So this is the reason which is safe to put, so that your plate does not get to the tuberosity. So this is critical. And while you are fixing, you need to check completely both on supination and pronation. And this is what you do. Any comment or any further tips to avoid these injuries from the panel?
I think that was very clear. No?
Yeah.
What I find is
Yep.
I tend to do the more direct lateral approach, and in doing so, it's possible to elevate the lateral column muscles of the distal humerus anterior to the lateral collateral ligament complex. And what I feel is by elevating the brachioradialis, and not necessarily brachioradialis, but mainly the ECRL, by elevating it, you put less tension on the anterior soft tissue structures, and so you have less risk of posterior introsseous neuropraxia. So I almost always release a little bit of the ECRL origin from the humerus, so I can put a Hohmann onto the anterior around the head of the radius. And because I've released the soft tissue, I'm not going to, because otherwise the nerve would be tethered. So I feel that's probably a way to keep it safer. And by going anteriorly, I feel I get a better exposure of the radial head. But I totally agree with what you've said.
Yeah, perfectly. So there are times when you have an even coronoid process fracture, even that in that time you can always elevate that. Or even if you want to further extend, as you said, you can do an lateral epicondyle osteotomy also. So that takes away all the pressure on you, because many a time what we find is your assistant try to put an Hohmann here to show you better the headdress. So it's always wiser, if anybody requires or feel comfortable, that they can erase a bit of extensors from the lateral column, and then all the pressure goes away. Perfectly said, Randy. So this is how per-op and post-op, this is the range of movement in 3 months. And this is the most important part, that many of the patient, they misses the last 10 to 20 degree of extension. Their main concentration on to get the supination and pronation and full flexion. So during their exercise, even the physiotherapist, they miss this part of the exercise, and many of patient takes about 6 months to get this kind of full extension. So this was all about this particular case. So any further comment on this case? Any panelist?
So there are 2 kinds of plate. One is a neck type of plate where you have sit a little bit more distal, and what you use is a head type of plate. So no, just personally think that there's a lot of time the patient complain of crepitus if you use a plate that is so close to the joint, and because that rub on the annular ligament. I mean, do you have such an experience?
Yeah, actually, if you see the AO plate, the diffuse synthesis plate, which they give the neck plate and the rim plate. So if the head plate you're putting, yes, that causes a problem. Despite they say that it's a low profile, I always feel that it's a high profile plate. So I haven't used that make in this particular fracture. So you're absolutely right. So neck plates, they are better than the head plate, because head plate, that do causes pressure and problem during the movement.
Thank you very
And
much.
there is another choice, Dennis, which you can use is you can use CMF plates for these head radius fractures also.
One more thing I've found is, if it's possible, sometimes it's really difficult, but if it's possible to actually piece the head together, either with headless, sort of cannulated screws or something to that effect, and then you can just use the neck plate instead of using the more sort of the one that goes for the head and the neck. Meratis has got a very nice sort of a buttress. They call it a buttress, radial head buttress plate. And sometimes I use that because it's slightly lower profile.
I completely conclude.
So I'll go to the next case. Thank you. This is a young girl of 21. It's a medical student, had an injury to left elbow. There were no comorbidities. So this was the X-ray, and this is the CT. I'll go straight forward to CT. So that's type 3. There's no confusion, I hope.
No
Dennis, it's type 3.
Yes.
Yeah. Yeah, please.
So you want me to see how we manage this, right? So this is a young girl with such a bad radial head fracture. I would want to see if there is any dislocation. So also feel for the medial tenderness, whether the MCL is okay. So otherwise, I will proceed to surgery to aim to fix the radial head and to see if the LUCL also needs some fixation. So this one, probably I would just retrieve all the fragments and then assemble the head on the table before putting it back using a neck plate. Yeah.
Dennis, had you seen this my case before also? That's what I
No.
actually did. So the purpose of bringing this case was the approach remains same, but as Dennis said, that you can take all the parts of it, reconnect them, connect them temporarily, and then can put up the plate. So this is another way if you have difficulties while putting the head radius inside, you can take out all that part on the table, do it like this. So that can be also done. And another important factor, as rightly pointed out, that once you have fixed up all head of the radius, you need to check back your medial collateral ligament. If you find it's unstable, one need to repair. Like in this case, there was an injury to medial collateral ligament, and we repaired it through a drill tunnel into the medial column. That's how we repaired on the medial side. And another important factor is that if you find the annulus ligament and the lateral capsule, they are all combined. Sometimes it becomes really difficult to close this part. So how really you guys manage that part? Any comment, Dr. Ruhi or Randy, from your side? Repair of annular ligament and the capsule.
I'm particularly not very concerned about the annular ligament, but I do like to repair the lateral capsule and the lateral collateral complex. So because I feel that if the annular ligament is going to be tight over the plate, I'm going to restrict forearm rotation. But most important for me is to make sure the lateral ligament complex is stable. And then I would put them in pronation for the first 3 weeks in a hinged brace, which allows which allows elbow motion, but with the forearm pronated. So I won't stress the lateral collateral complex. That's my technique.
Perfect. Ruhi, your take on this annular ligament?
I fully agree with Randy. I find sometimes that with the plate, it's difficult to oppose the annular ligament, and sometimes we create more damage by trying to do so. So if we actually just close the lateral complex, it actually holds it in quite well. I once did one of the plates that I'm not going to say which one, but it was really high profile. You know, it's like Michael Jackson profile, and I couldn't then get to close, and I had trouble even closing the lateral complex. So, but I find actually that once you close the lateral complex, it actually holds it in quite well. So, yes,
that's the reason actually I brought this point into discussion, because once you start discussing these, there are a lot of people who ask you that annular ligament should we close, repair, or reconstruct. Actually, with these kind of injury, it's almost impossible most of the time to actually relocate the annular ligament. Where are the threads? So it's always safer and better to tightly repair the lateral complex, and that does the job. So this was the per op. This is 3 months. This is the range of movement which she got. The another thing happened at this patient, and again, if you can notice that by 3 months, I don't know about what is your experience. Many of these patients lack this 10 degree of movement and takes almost another 2 and 3 months to get into full extension. So what are your experience regarding this particular last 10 to 15 degree of extension? Do all your patient gets into first 2-3 months, or they also require another 2-3 months add on?
hello. I find that it actually depends quite a bit on the fracture and the patient. So we're quite lucky in that we're a smaller country, and our patients manage to come back to hospital and do their therapy. But you're right, it's the last 20 to 30 degrees that are the most challenging. Luckily, that does not really cause that much of a functional deficit. But what we do is usually we start them early in terms of therapy. So when we do that, I find that that deficit is not there.
Right. Thank you. So I'll go with another case. Do I have the permission of panel to go ahead with another case?
Yeah, you still have 3 minutes.
Okay. So this one is a 6.
Mate, just maybe just move through it a little bit quicker. That's all.
Okay. So this is 64-year male, diabetic, on insulin, chronic renal disease, ischemic heart disease, high risk patient, had this fracture of the head radius, where you can find the whole of the head is almost half the head is lying over here. How would everybody want to manage? Whether they would manage it operatively or conservatively with so much of the risk?
How about Professor Randy? Yes.
That looks like it's displaced now. If you tell me he's got multiple comorbidities, then the first thing again I would do is just examine the range of motion. If he's got reasonable elbow motion, he's a very sick person, I would just wait and see what happens, and then excise the radial head when he's better, or if he ever gets better.
Yeah,
I wouldn't be too concerned.
Perfect, Randy. That's what I did. I did it under local, and I found that range of motion was good. So I kept him on conservative. This was after 2 months. And what I found is there was actually no need even to remove that particular, because I got a CT done at 2 months and found that half of the head radius was lying inside the muscle. So I left it like this, and he got absolutely painless movement. So the purpose to bring this case is that you need to decide each and every case, not just by type 2, type 3, that what is their requirement, and then decide your case. Another case, 46-year male, diabetic, hypertensive.
Nope, that may be the last case. So we'll just
Okay.
over to Dennis so you can close that little section.
Okay. So this one was with fracture.
We'll hold this case for another day, Anu.
Okay.
Yes. Yes. Thank you, Professor Anobi. You have a great presentation on radial head fracture. I'm sure the audience know a lot now. So maybe we invite the next speaker, Professor Randy, to talk about esophageal injuries. Okay. Professor Randy, yes. Please. Please, you need to unmute yourself, Professor Randy. Unmute yourself first.
Got it.
Okay.
Thank you. Sorry about that. Thank you, Dennis, and Dr. Al-Zarani. And Marini, thank you for giving me the opportunity to present some interesting cases on the issue of longitudinal forearm instability. What I'm going to do is go through some cases, talk about an acute situation, and a little bit of how we manage these when they come late, because sadly, SX Lopresti injuries still do present late more often than acutely. And then while discussing the cases, I'll just talk a little bit about the anatomy and the mechanics of the forearm articulation. This initial presentation by Anup was an excellent segue into getting into the discussion of these patients. So we've already covered some elbow injuries and radial head fractures. Now here is a patient. He's had a motorcycle accident and he's got bilateral elbow injuries. So I'll just show the panel both sides, and then we can talk a little bit. So this is the right elbow, okay? We don't know if there was a dislocation or not. He's brought in by the ambulance. And so that's the right elbow. And this is the left elbow. How would you approach these, if I may ask Dr. Ruhi? That's the right elbow. This guy's in his 40s.
Sorry. So both right and left, yeah? Okay, so the left elbow does not look as bad as the right. I may have to eat my words, but the right elbow.
I'm not trying to catch you out. It is what they're not. There's nothing hidden there. Yeah.
Yes. Okay. No. So yes. So the radial head is sitting right over. I think across the elbow. So, but
it's
looks
actually posterolaterally. No, it's sitting posterolaterally behind the capitellum. But yeah, it's on the lateral side.
Yep. Yeah. So, but it does look like it's in one piece. It could be more, but I actually only see one piece. So, yeah, so we would probably need to assess the stability in terms of the lateral and the medial complex. And of course, we need to see the wrist.
He's complaining of some wrist pain, Dr. Ruhi. So the clever PR doctor gets some x-rays of the wrist as well. So what would you feel you should do now? Do you feel any concern about the wrist at all?
Well, the ulna looks like in a lot of plus, right? It looks very prominent. But with a radial head fracture like that, but I'm not sure whether this part of the radius is fractured. I'm not sure about that, but yes, I just feel that the ulna is a little bit prominent and I'm a little concerned about that. And
Dr. Anup, you would do anything else at this point if you see the ulna as prominent as Dr. Ruhi is concerned, and the patient says that part hurts? Could this be a congenital thing where he's naturally long in the ulna? Is that any bearing on this injury at all? Do you know? What do you feel? I think you're muted, Anup.
Yeah, problem, Randy, here is that perhaps you'll have to go to the other side also. But again, you may get confused because even the left side is fractured. So you might find the similar condition on the left wrist also. Otherwise, it's required to confirm on the other side, see the X-ray on the left side and reconfirm whether it is DRUJ or it's congenital by birth. So that's the thing. So
that's his left side, Anup.
Yeah.
We may need to do other investigations to sort of figure that out. Okay.
So left is just,
that's his left side.
So left side is just the ulnar sterlite, which is fracture. And if you see ulnar variance is on the minus side. So probably on right side, he has that longitudinal injury. So these are the kind of head radius fractures which require to be seized on the both the sides, that either you replace it or you fix it, and then you check about the DRUJ instability, and if you find it, you might have to fix it with 1 or 2 K wire, or really need to look at repairing the DRUJ also along with that.
Okay. I just thought I'll put in these couple of points of when you're assessing a radius after you remove the radial head, if you decide or if you're concerned or if you're confused whether radial head needs to be replaced or not. I think one of the options is after you resect the head, if you apply longitudinal traction with a little pointed forceps and you look at an x-ray of the wrist, when you pull on that radius proximally, if you can create more than a 3 mil variance, then you may have some intraosseous ligament disruption. But if the ulna can become as positive as 6 millimeters, then probably you're looking at quite a significant injury of the triangular fibrocartilage and the intraosseous membrane. Another technique you can do, and this is intraoperatively, when you've taken the radial head out, is to grab that radial neck and with a forearm in pronation, which is the position you're putting it anyways, pull on that radial shaft. And if the shaft comes right out of the wound, it tells you there's probably quite a substantial tear of that intraosseous membrane. In any case, I agree with what you said, right, Ruhi, and you were right in picking up that the right wrist was a problem because that ulna was looking too long. And so given that his left wrist x-ray is normal, so I think getting the opposite wrist x-ray is probably an easy way to figure out what's going on. So we did a CT of the elbow, Dr. Ruhi. Does that still keep with your plan? You're going to fix that radial head?
So there's a small coronoid fracture, and yes, the radial head is displaced, but I think I could actually still probably fix that. But I would keep my handy head replacement set nearby. But I would still try to fix that actually.
And we know that there is some kind of disruption in the forearm, right, Dr. Ruhi? So do you have any thoughts on what you do with do you do anything for the soft tissue after you fix the radial head at all?
Sorry. This is one condition where I would feel immobilization is, key to allow those tissues to heal. I wouldn't go in to repair it. No, I wouldn't do that. But if the TFC is injured, then I would address that.
Dr. Yildirim, do you deal with these kind of injuries? Do you have any thoughts on that?
Yes, I agree with Dr. Ruhi. I will first try to fix the radial head and then assess the RUJ, and if it still remains unstable, I may repair TFCC.
So this is what we did. We did this tripod fixation, which is one of my colleagues did a study where they looked at tripod fixation versus a plate, and it appears to be equally strong. At least in non-osteoporotic bone, probably is equally strong. So, and maybe less of a external profile, so less challenges with repairing the annular ligament, as Anup pointed out. And so we did that repair, and the distal radioulnar joint felt reasonably stable in supination. Should we pin it or should we leave it free, Anup? What are your thoughts on that? Should we repair? Should we leave free or should we pin?
That's what one need to see. After you have fixed the head of the radius and put it back in its place, then we need to assess that what is the condition. If it is stable, then you don't need to put anything else. But even after that, if it is unstable, then probably putting the 1 or 2 K wire across would be fruitful. That can be removed in 2 weeks thereafter. Because at that time, we need to assess medial collateral, lateral collateral, and DRUJ. All three complexes one need to assess after you have put in the fixed head radius back into position.
So, Abdullah, you have any thoughts on that?
I couldn't get, sorry.
Dr. Abdullah,
Yes.
do you have any thoughts on this? Would you do anything for the distal radial ulnar joint?
I don't think so. If it feels stable intraoperatively.
Dr. Rui, you're going to talk to us about distal radial ulnar joint, right? So in this kind of scenario, would you be repairing it, or would you be pinning it, or would you be leaving it alone? Can you unmute yourself,
Rui,
please?
unmute yourself.
Okay, unmute. I would probably do what Anup said. You know, after fixing the radial head and trying to get the annular ligament around that, I would then assess the DRUJ. So if the DRUJ is stable, then I believe it doesn't need fixation. But if it's not, then I would have to look at that complex as well. Ah, there we go. Okay. Including the TFC, because that's the one that's usually missed out.
Yeah, so here, you know, we did not repair the TFC, and it felt okay. And so we put a K wire across. Now, I should have put two. That's what I normally do. But one point, I tend to pin all of these SX Lopresti type injuries simply because I'm concerned that the soft tissue may not heal adequately. But I think one tip here is if you ever put K wires, make sure they are out on both sides, because if it breaks, if you put it where it's not out on both sides, and if it breaks, you don't want to be taking that out. It's a very painful operation. You have to make an incision here, and you have to millimeter by millimeter push it out. It's very painful for you, not for the patient who's asleep. So anyway, the other side, we just fixed the radial head with some transverse screws, and that side did okay. This is a patient at 1 year. So, I mean, he's kind of a stoic, tough Aussie guy, but you can see it's not perfect. He's not unstable in the distal radial ulnar joint per se. He's got rotation, but he's certainly got ulnocarpal impaction. I don't think we've restored him completely there. And in retrospect, if we had repaired his TFC, maybe we would have been better off.
Randy?
Right? Yes, sorry.
Randy,
Yes?
may I just ask, do you have any experience, you know, like putting the K wire instead of just putting it distally, you put a proximal one as well? Would that help, you think?
You mean more proximal than this? You mean somewhere there?
Please unmute
Sorry.
yourself. Yes.
What I mean is one here where you've put it, right? The place where you have placed it, and one near the proximal joint, you know, all the way up.
Right, proximally in the forearm. Okay.
Yeah.
You know, I have never done that. You know, there's always been this concern proximally of two things, right? One is the nerve, right? We all get scared of that nerve.
Yep.
Secondly, you know, from our experience with biceps tendon repairs, any wires proximally, the risk of HO has always scared me. So I have not put pins more proximally. Is that what you feel does work?
Yeah, that was my concern. I have not done it myself, but I was just wondering. You know, the other thing that I feel maybe that wire was a bit fine. I don't know if, you know, if you had a stouter wire, would it have worked? I really don't know. I'm just guessing.
It should be 2 mils. I agree. This one is a 1.5. It should have been a 2 millimeter wire. And I think there should have been 2 wires. So perhaps
maybe the second wire more distally would have solved the thing. Maybe mono, it's just speculations to keep it more stable.
Moral of the story, don't leave it to your registrar to finish up the job, right?
Yeah.
Randy, just a couple of questions. One of the questions often is like, where do you pin it? What position do you pin it in? And the second question is, you know, have you fiddled around or played around with any of those synthetic endo button devices for these types of injuries acutely?
Acutely, yeah. So Marini, good points. And I'll come to the intraosseous part a little bit later, but in acute situations, I have not done any endo button or any reconstruction. I have seen fracture of the ulna with those endo buttons just from the tension and the bone erosion. In position of the forearm, what I generally find is because usually in the DREJ, the ulna is sitting dorsally. So typically most of the time it's a supinated position when it drops back into place. And so we pin it in supination in that position. You can pin it in neutral, but I find sometimes pinning it in neutral, the joint can be a little bit dorsally subluxated when you pin it. In supination, I feel more confident that it's locked home and it's going to be good. So that's what I generally do.
Professor Randy can
Yeah.
ask that. So supination is good for DREJ, but for the PRUJ, it is the pronation that is better. So
correct. Agreed. But in this case, I've repaired the collateral ligament. I've got a good, strong repair there. And so, yeah. I don't know if it would put it at risk, but you're right. In some situations, you would have to examine it and decide which way you want to go. Yeah. Good point there. So just a few points about the SX Lopresti is that often they're missed early. Now, this is one of the few cases where acutely they became so ulna positive, right? We don't usually see that. Usually we see that after the fact. And just a point here is that the forearm is exclusive to humans. And whenever you have any injury of the proximal radioulnar joint, you got to think about the distal one and always look at the wrist more carefully. And interestingly, this paper that was published for SX Lopresti was done posthumously after he died. And that's how the injury got his name. And originally, they just said, this is an injury where you dislocate the distal radioulnar joint and break your radial head. But now, of course, we understand that it's three components. Number one, number two, intraosseous tear, and number three, disruption of the distal radioulnar joint. Now, we don't know the true incidence. And if you look at Michael Hausman from New York, they did an MRI of all radial head fractures, and they would say that 60% of radial head fractures have some tears of the intraosseous membrane. But if you look at how common radial head fractures are and how common the SX Lopresti injury is, it's probably only 1% of radial head fractures. So it's not, I don't know if it's that common, but the fact is that most of them, or a large percentage, are diagnosed late. And then when you think about it, with these kind of injuries, you've got the radiocapitellar joint. So we address that by replacing the radial head. The secondary part, these two stabilizers. Currently, most people, like I see on the panel here, feel that you replace the radial head and you can pin the distal radioulnar joint plus minus TFC repair. But acute repair of the intraosseous membrane or using something like an endo button that goes right across the mid forearm where the oblique fibers are, as Marini was pointing out, I'm not sure that has been proven to work. And certainly putting it under tension has two possible risks. One is stiff forearm, and the second is ulnar fracture, which can occur because of the holes that you drill. And this is the middle ligamentous complex. That's the critical one, the central band that we talk about, the one marked in the asterisk here, which runs from the upper third, middle third junction of the radius to the lower third, middle third junction of the ulna, which is about a 21-degree angle that it runs at. So that's the critical part we're always trying to replace right in the middle. And that's what it looks like in the cadavers. And that's about where that ligament runs. So we know it helps to transfer the load, prevents the proximal migration, and gives you that forearm stability. Now, certainly, when you look at the outcomes like that patient where we did an acute injury, if you look at this paper from Schnetzky from Germany, they looked at acute ones that were detected and repaired versus late ones that came 6 weeks later, where the radial head was excised and then needed radial head replacement. If you look at it, they still have a lot of disability. So if you look at the DASH score, if you find this late and treat it late, these are long-term follow-up, about 45 score of DASH, which is a lot of disability. Even the elbow score is not that great when you pick it up late. And the grip never comes back to normal, especially if you treat it late. The grip is half of the other side. And in this series, they had 4 of 25 with unstable distal radioulnar joints. These were by just pinning, no primary repair. And when they did it late, 10 of the 67 had late distal radioulnar instability. So it is a problem if you don't treat it appropriately early. Same thing, if you look at the rotation of the forearm, they don't get back full range. They do lose some range of motion, but it's much worse if you do this reconstruction late. So again, kind of moral of the story is you pick it up, treat it early, but they do get stiff. They don't get full range, about 80% of grip. So it's not a great injury to have. So here is the next scenario, okay? So this patient fell from a tree. Now, this is from when I used to work in Arkansas, and they're in their deer hunting season. These guys are up on the trees in these little hideouts, and they drink a lot of beer while they're waiting for the deer at night. And usually, more often than not, they fall off the tree. They come in pretty drunk. And so he had his radial head taken out. So he had that radial head excised 6 months earlier. That's his scenario there. And that's what he complains of now is ulnar-sided wrist pain. Any thoughts on how you would deal with it now as a 6-month late scenario? Dr. Abdullah, any thoughts?
I don't treat these injuries, so I cannot.
Okay, yeah. Sure. Anup, what do you do for these chronic ones?
That's the big problem. Giving results in these chronic one is really difficult. So one need to assess TFCC, BRUJ both, and are there any secondary changes because of the snugging of ulnar sterloid with the carpal bone? That has to be seen. So actually what you need to do is something like Derek's procedure, which can be done for these kind of patient. That works, I think, best for
No, he's still okay at the distal radioulnar joint. He's still okay. I mean, he's got painful rotation, but the X-rays, they don't show much arthritis there, Anup.
Yeah, much of the arthritis, but if you see, there is, I think it's about 8 to 10 mm of ulnar variance, which is on the positive side.
Sure. Yeah.
So how else are you going to deal with this?
But his elbow also hurts, right? If you do a DARA, Anup, I would be concerned that now he's lost instability distally and he's unstable proximally. So the whole forearm axis, right now it's stable because the ulna is abutting the carpus. If I take away the distal ulna, I may worsen the situation. Dr. Ruhi, any thoughts?
Yeah, this is like Anup said, this is not an easy situation. I don't really like doing a direct. It is, we've been taught in Louisville not to do a direct, die first before doing a direct. So, do we do Sove Kapanji? Can we get that distal end of the ulna down to where it should be? And like Randy said, it's 6 months down the line, there's no DRUJ arthritis, so you don't want to go and do something drastic like fusion or anything like that. So the Sove is not a solution either. I think it has its own issues. So I wouldn't know, but yeah, but the ulnar shortening is something that that always comes to mind, because that's I don't know who developed this, but he's a brilliant guy who developed ulnar shortening, and it kind of it's like a fix it all. The only trouble with ulnar shortening is the incidence of non-union, but I think that's a lot less now.
So what I find with these is that when you replace the radial head in cases like these, which are a couple years, even under a couple years out, the forearm axis is still mobile, So in this case, in fact, we put the radial head in and it brought him back to a pretty good length. I didn't have to shorten him. I just repaired the TFC and he actually was quite happy. He was quite happy.
Great.
So
Great.
the radial head replacement is still a good option as long as, and if you're concerned, you can do a longitudinal pull and get an X-ray intraoperatively. And if they truly are unstable longitudinally, there is still time to put a radial head in and you can jack it up. Now, in this case, he was only 6 months. The moment we put the radial head in, he became nicely long. You can see from his hand, he's a smoker. So certainly ulnar shortening would be one of the little concerns there with all that nicotine staining there. But largely, he did pretty well. So in my mind, even if they come a little late as a secondary reconstruction, radial head replacement, distal radio ulnar joint repair, they seem to do all right. That seems to be a reasonable formula.
Randy, may I ask you something? Up to what point do you think that it would be okay to, sort of pull that ulna down? Is it, let's say, 6 months, 1 year? What time frame would you give it? Obviously, if there's arthritis, we're not going to do it. But other than that,
I would say it's possible for a couple of years, Dr. Rui, because these guys remain so unstable that when you get a longitudinal traction film under anesthesia, you can see it actually opens up. Then you have a good idea that you can do that. Now this is the next case. Sorry, go ahead.
Yeah, but Randy, my concern is no, wonderfully done. No, I'm surprised with the kind of result which you gave. My concern is no, as we discussed about the Essex lacrosse tie, that with 6 months onward, you will have all those things healed up by fibrosis, the DRUJ also, and the membrane also. So was it easy to really pull it back, the head of the radius, while you were operating?
Yeah, it's
Or
actually,
how difficult it was?
You know what's interesting is that intraosseous membrane never heals. And so they're actually surprisingly very easy to pull back. But let me show you this case.
Okay.
This is the same situation, okay? But much later in the time zone. So this girl is only 35, okay? She's in the military, so they have to do push-ups and all that stuff. So she had a radial head excised 8 years ago. Then she developed an Essex Lopresti scenario. So 3 years after that, they did a radial head replacement and a DRJ repair. And actually, she managed all right for 5 years, okay? So this was done 3 years later, okay?
Okay.
And now she's got elbow pain because the radial head, because that intraosseous membrane really never heals well, that radial head takes a lot of load, you know? And when we talk about radial head replacement and we talk about long-term results, those radial heads don't hurt. I believe the radial heads that don't hurt is because they don't take any load. Because anytime in a young person you put metal against cartilage, it's got to hurt at some point, right? It can't keep going on forever, is my belief. So when I read papers where they say these metal radial heads lasted 15 years and they had no pain, I'm thinking that's probably because they bore no load. Only the surgeon was satisfied they put it in. But in any case, now we've got a problem because now we've got a radial head that's hurting. You can see how the bone has remodeled nicely around that radial head stem, right? So that's become stabilized. She's hurting at the elbow. She can't rotate her forearm because it's painful. So now we have a scenario where she's actually neutral at the wrist because they've done her DREJ repair. We've now got a scenario where we've got this, we've got a painful radial head. Now we know if you take the radial head out, she'll end up back where she was 5 years ago, correct? Because that radius is going to migrate. So what do we do now?
So was she painful right after the radial head replacement? Because it looks like it's slightly larger size of the radial head which has been put.
You know, interestingly, she managed 5 years. She managed 5 years. Maybe she was a little painful, I don't know. But when she saw me, she said, I've had this done 5 years ago, but I've reached a point now where I cannot put up with the pain.
Well, I think we can consider doing downsize the implant.
Downsize implant is one possibility. But you know what? Probably her cartilage is worn out now, right? On the capitellum, right?
Yep.
These kind of scenarios are a little bit more difficult. And because of shortage of time, what I decided was I need to put a soft tissue spacer. Now, for whatever it's worth, you know, it may or may not work. But I believe that if I can reconstruct the intraosseous membrane, then I can prevent that proximal migration again from happening. That was my thought. So now this is what she looked like with that radial head. You can see there was some serous fluid there. And when we took her radial head out, the capitellum had completely lost all its cartilage. I don't have a picture of that to show you, but the radial head came out easily. This was one of those non-fixed stems. Thank goodness for that. And so I tend to use any kind of allograft soft tissue. I have a preference for allograft dermis. Some people use allograft tendo Achilles. You could take the patient's own fascia or tendon or something, but you need a big ball. You know, you need a real big ball to create a massive scar in there where you can tighten the collateral complex onto. So I shove in a huge piece of thick allograft dermis, allograft acellular dermis, stick it in there. Now the key is to reconstruct that membrane. Now there are various techniques, and I'll tell you my preferred technique.
Mr. Randy, last
this,
1 minute. Okay. Last
yeah.
1 minute. Yeah. Okay.
Yep, absolutely. What I like is to use a pronator teres, because the pronator teres inserts on the radius. As you can see here, if you flip it over, it becomes a nice IOM band. So here is a cadaver study. Here's the patient, same patient. We've taken her, this is anterior approach. This is the medial elbow. And you can see the pronator teres coming onto the radius here. So I've taken the pronator teres tendon, left it attached on the radius, turn the hand over, and now it's going under all the extensor muscles and coming across towards the ulna. At the middle third, lower third junction, you can see she's had a previous ulnar shortening, this girl had, when she had a radial head replacement. We brought it through a drill hole in the ulna, anchored it, and there's a 1-year follow-up. And she has remained pain-free, stable, without proximal migration of that radius. So this reconstruction of the intraosseous membrane does become a useful tool in later reconstruction. And people have used patella tendon bone. I find the pronator teres is right there, readily available and easy to use. So I hope I've shown you an acute injury, a little bit chronic, where you can replace the radial head and repair the DRUJ. And I think in the most severe scenarios, perhaps a situation like this, consider repairing the intraosseous membrane using the pronator teres tendon. Thank you. Thank you for
Thank you very much, Professor Randy. So with no further delay, we would like to welcome next speaker, Professor Tugru, to speak on the distal radius intraarticular fractures. Okay.
Hello, everyone. Thank you for giving me this opportunity. My name is Turu Dildirim from Hans Macrosurgery Orthopedic Hospital in Izmir, Turkey. Now we will discuss few intraarticular distal radius cases, functional distal radius anatomy, and indications and surgical techniques. So our first case, 34 years old, right dominant male. He had motorcycle accident. He admitted to hospital with bilateral intraarticular distal radius fracture. His neurovascular examination was normal. His soft tissues was okay, and he had no other injuries. So these are the initial X-rays. He had both intraarticular distal radius fractures. On the left side, he had metadiaphyseal comminution. On the right side, he had volar carpal translation. So what is your approach of this injury? Dr. Ruhi.
Okay, let's tackle one by one. I'll rope in Dennis to help me out here. So I'll probably do the left and have Dennis do the right.
Okay, sure.
I think we'll, there's a lot of, besides the intra-articular comminution, what I can see on the x-ray and the metaphyseal, which is extending all the way almost to the mid-shaft of the radius. I can't see the ulna clearly. I'm not sure whether that's disrupted. It looks disrupted. The DRUJ looks disrupted on the lateral film, and I can't see the head at all. So I would definitely order a CT for, well, both sides, because the right does look quite bad as well. So I would probably order a CT, maybe even an MRI, to look at all those, to look at the DRUJ, to look at the TFC. And of course, I would have to plan in terms of a longer plate. So I would either use Acumed, or I would use MetaArtist. They've got some good solutions for distal radius plate, which extends proximally.
Okay.
So for the right, okay.
Okay, the right. Okay.
Okay. Yes, I'm sorry. Yes, for the right.
So for right, it looks like more than a button fracture because there's also intraarticular component. So definitely we'll go Fowler because it's a button type. Probably we'll try to see if I can reduce the Fowler lip and then what happened to the intraarticular fragment. Sometimes it is depressed and I will insert some percutaneous K wire from the dorsal to try to check it up, or from the fracture gap over the Fowler to check it up. And maybe sometimes need some bone substitute to remain that in place. So probably that will address any DRUJ issue if you can reduce the this radius well.
Yes, you're definitely right. So to treat intraarticular distal radius fractures, you need to have a true understanding of functional anatomy and comfort with all approaches, and you should be aware of versatility in fixation methods. So there has been several classification systems have been described. AO is very comprehensive, but it cannot explain the all fracture patterns. In 1996, Rickley and Regazzoni proposed three column concepts, radial, intermediate, and ulnar column. But this cannot explain the biomechanics and fracture mechanism. Dr. Medov proposed a classification of fragments that may result from multifragmentary distal radius fracture, and these fragments are very consistent fracture patterns. So when you look at an X-ray of distal intraarticular fracture, it's very essential to recognize especially volar rim and dorsal ulnar corner fragments because they made up lunate fossa and sigmoid notch. Where intraarticular fractures usually occur, these intraarticular fractures at the distal radius occur at inherent areas of weakness between sites of ligament attachments. So these are weak areas where we usually see fracture patterns. Extrinsic ligaments are very important. They encounter the force from brachioradialis and DRUJ, but there is a bare area where there is no ligamentous attachments. It is dorsal ulnar corner, and when you mix reduction with ligamentaxis, you should be aware of this dorsal ulnar corner fragment. You should restore anatomy and stability all unstable fragments in each column and start with simplest technique. And you should keep in mind that advanced techniques may be needed. So let's get back to our case. This is a right wrist. We did volar and dorsal approach. We put the volar plate as much as distally to fix rim fracture. And we put a dorsal plate to fix dorsal wall fracture, and we fixed the celloid with a tension band technique. And what do you think about this fixation? Did we miss anything there, Dr. Randy?
Dr. Randy?
I think you can hear me? Yep.
Yes, yes.
I think, yeah. I think you've done a good job on getting that radius out to length. My little concern is the radial styloid may not be adequately addressed, but I see you've got a dorsal plate trying to hold it. And then the volar lunate teardrop fragment that you see in the right, on the X-ray on the right-hand side. Yeah, that would be something that would be concerning, whether it has been sutured down or not. That would be something to watch carefully. But otherwise, you've got a pretty good alignment. Radial height is pretty good.
Okay, thank you. And this is the left side. As Dr. Ruhis mentioned, we used long plate. We fixed celloid fracture with tension band technique. A week after the operation, when we examined the patient was unable to extend his fingers. So what do you think happened there? Dr. Anup?
Dr. Anup?
Dennis, what do you think?
So it seems not just the fingers, the wrist extensor cannot move. Is quite uncommon, especially.
So this was not the exact picture of the patient, by the way.
Okay. So there can be. I mean, compartment syndrome is very rare. Usually, it's more volar muscle instead of the extensor muscle. If you sometimes you can your screw or KY can catch some of the muscle, but it's uncommon for the whole wrist extensor. I mean, an X-ray does not seem the screws are too proud. I would probably check a CT to see the screw length and if anything is jammed. Sometimes when you close the wound, your suture can also catch some of the tendon. Maybe that can be one of the reasons.
Well, we did an ultrasound and we didn't see any interaction with tendons and screw. So we did a dorsal approach again and see screws were not penetrating the tendons. The sharp edge of the fracture edge was the reason for laceration. So all the 5 extensor digitorum communis tendons were lacerated, and it was not possible to repair tendons primarily. So we used palmaris longus graft to reconstruct extensor tendons in this case. So this is right wrist. After a 10-week surgery, the patient was unable to move his wrist. And when we took X-rays, we recognized volar carpal dislocation. We did a CT scan and see that volar carpal translation, and we recognized we did not adequately fix volar rim fracture. We did a volar approach. There was a fibrous union. We removed the plate, fibrous union, fibrotic tissues, get an iliac bone graft, and use the same plate for fixation. And as Dr. Randy said, we recognized there was instability in the radial column, and we utilize a radial column fragment-specific plate to stabilize radial column. And we also used additional 2 key wires to keep volar rim fragment in place. So it's very important to be aware of the importance of volar rim fracture. If you can fix it adequately, you may see disastrous results, late carpal dislocation.
Hi, Togrul. Sorry, missed that. Can I go back to that left one and talk? At that time, I missed it.
This is
was
left wrist.
Was that a crush injury?
No, it was not a crush injury. It was a motorcycle accident, but soft tissues were okay.
Okay. Actually, Anup, I agree with you there. You know, it's very unusual that all the 4 extensor digitorum communis tendons were cut by the mid shaft radius fracture, or rather the metaphyseal diaphyseal fragment.
I have never seen Ruhi to happen like this.
Yeah, quite unusual.
So that's really an. What is the experience of other panel regarding this?
I was actually thinking that it's maybe the nerve, you know, until Togrul said that it was they explored dorsally. I actually thought it might have been the nerve.
But there was no nerve problem, so it was tendons were totally lacerated.
Yeah, true. Mm-hmm. I understand.
Thank you.
Okay. And as two subsequent complications, the fractures healed uneventfully, and patient had satisfactory range of motion and almost a full pronation and supination. So let's move to
There is one
second
thing.
case.
There is one thing that of note, that the Medartis, they've got a new plate which has got little sort of extensions which can deal with the volar rim fractures, where we're not able to put a screw in, or we're having difficulty to get them down. So in one of their plates, they've got these two little sort of something like mallet hooks, yeah,
Yes.
with a hole, and you can put a screw in. So it's quite ingenious. So, but that's something new, yeah.
I'm going to mention about that. So our next case, a 42-year-old right-hand dominant female. She fell on us French hand. She had closed distal radius fracture. She had no other injuries. So this is the initial X-rays. Dr. Randy, will you treat this patient conservatively, or do you need to see CT scan?
On this one, when I look at the lateral view, there is a volar lunate facet fracture there. So I would get a CT scan to understand the fracture pattern better, please.
Yes, you're definitely right. We did a CT scan, and we saw a marginal volar rim fracture, which was very difficult to fix with standard volar plate. So we did volar FCR, modified hand-ray approach. We fixed the volar rim with key wires, and we put low profile mini plate for buttress to support the fracture. There are, although versatile, volar plates may not provide to all critical fracture fragments. So due to this, fragment-specific concept was introduced and become popular nowadays to reconstruct the fracture components while avoiding creating large holes, as Dr. Ruhi said. You can use these fragment-specific plates. You can anatomically restore the old articular surfaces by providing stability to allow early range of motion. There are lots of plates available in the market, but if you don't have one, you can use key wires and mini plates. There's a very useful algorithm proposed by Dr. Ree. If you recognize a volar rim fragment, first ask if it is amenable to be fixed with internal fixation. If it is not, you can consider doing X-fix and percutaneous pin fixation. But if you can fix with internal fixation, then ask if you can fix this with volar plate or not. If you can, do the volar plate. But if you can't do it, then you can consider doing fragment-specific fixation or volar plate with key wire fixation. Our next case, 72-year-old right-hand dominant female. She fell on ground level. She had severely comminuted left distal radius fracture. She had normal neurovascular examination, no other injuries. She had osteoporosis, hypertension, and diabetes. Those are the X-rays. She has severe comminution and dorsal carpal subluxation. So how would you treat this patient? Reduction and casting, external fixation key wires, or spanning plate, distraction bridge plate? Dr. Ruhi.
Okay. She's 72, right?
Yes, she's 72. She has
A lot of
comorbidities.
comorbids.
She has
Yeah.
osteoporosis.
I don't know. It's quite a tough one. I really don't like doing external fixator, but I think in this case that might be what I would go for. If we can get a CT to see how bad that and how much of the distal radius is actually there. If there is hardly any fragment left because it looks rather comminuted, then I may actually opt for one single surgery and go for fusion. If there is some amount of distal radius left, then I may go for a bridge plating.
Okay. And in this patient, some distal radius was left.
Left hand or right?
What's that? Sorry.
Is it left or right? I mean, dominant or non-dominant?
Is it? It was non-dominant side.
Non-dominant side.
Will it depend your decision?
Yeah, I think for a 70-year osteoporotic with so much comorbidity, it is going to make a lot of difference for me, whether it's dominant or non-dominant. For a dominant hand, I would definitely try to give her the best possible, maybe take more risk, do a mini open, look at the depressed fragment, put them back, put some K-wire, put some buttress plate and maybe X-fix. And for a left hand or the non-dominant hand, I might just do it under C-arm, reduce it, put the K-wire percutaneous and put in on X-fix. So I think my strategy are going to be different for this lady for dominant versus non-dominant hand.
Okay, we think the same. It was her non-dominant hand. She had comorbidities and low age, so we, instead of doing X-fix, we decided to do a spanning plate in this case. So we made 3 step incisions. The third incision is on the dorsal side of the wrist to release APL. After purchasing the first screw to metacarp, we reduced the fracture and put the screw to radius, and then purchased the remaining 3 screws. And this is post-operative X-rays. Do you think we issued good alignment and Wöhler tilt?
Looks like okay for the kind of fracture she had, because you actually can't do anything for those depressed fragment. Still articular surface looks okay, pretty fine to me, considering the type of comminution she had.
Yeah, it looks pretty good actually.
Yes, thank you. In this patient, we use 3.5 millimeter LCD CP plate, but in this, while doing spanning plates, you can do 2.4 or 2.7 plates. We applied the plate to third metacarpal, but you can do this to second metacarpal if you want to have better traction. But biomechanical studies have shown no difference between 2 techniques.
I noticed that she looks quite hefty, so probably you could get away with the 3.5. Sometimes if the patient is smaller, then I find that the 3.5 becomes, in the forearm it's okay, but in the wrist it becomes very prominent, and then they feel very uncomfortable over the metacarpal. But,
yes. Yeah. And another disadvantage of 3.5 is you can make a fracture in metacarps, especially in Turkish people. Metacarps are small, so it's risky to do a 3.5 millimeter plate.
Probably that's why you have put in another 2.7 screw or something in metacarpal.
Yes.
This screw, no?
Yes, this one.
Yeah.
You can issue really good reduction and union with external fixator, as we all know, but complication of external fixation is mentioned to be 20 to 60%. Majority of them are minor complications, but you don't see many of these complications with spanning plates. You can not correct Waldor tilt with X-fix, but spanning plates buttress the dorsal cortex, and you can have really good Waldor tilt. And spanning plates are much safer, allowing patients to bear weights immediately. This is especially important, I think, in polytrauma patients, because these patients require immediate weight bearing and rehabilitation. So you should consider doing spanning plates in polytrauma patient. And major disadvantage of these plates is you need secondary surgery to remove this. So if you have severe comminution and metaphyseal bone loss, and if you have a polytrauma patient, you can consider doing spanning plates. But if you have a fracture that can be fixed with standard Waldor plates, and if your patient has a second or third metacarpal fracture, you should not consider doing spanning plates. And of course, you have a contaminated and open wound, you should do X-fix. So after 3 months, we removed the plates, and patient had satisfactory range of motion and supination pronation. So my last case, he's 28 years old male, falls from 2 meters from a ladder. He had comminuted left distal radius fracture. He had normal neurovascular examination and no soft tissue problem. So these are the initial X-rays. Dennis, what do you think? Which approach should we do, and which implants should we apply to this patient?
It looks like may need a combined approach for plus dorsal, because there is a quite sizable dorsal intermediate fragment. I mean, if we don't fix that, then maybe DRJ may be some kind of instability. And of course, we need to address the folder, because there are also some fragments being pushed out. Even maybe there is an acute carpal tunnel, because there is something in that region. So I would do both fold and dorsal approach in this case. Probably, yes.
Yes, and what do you think about scapholunate interval?
You probably need to reduce this radius first before reassessing again. I mean, sometimes if you did a good job with the radius, the scapholunate probably will try to reduce a little bit better. If it doesn't, then I would just pin 2 KY to fix the scapholunate, maybe with arthroscopic guide reduction.
Okay. So we did Waldor and dorsal approach. We use Waldor plate and fragment-specific dorsal plate to fix all intra-articular fragments. After fixation of the radius, scapholunate was unstable, so we repaired the scapholunate ligament openly and applied 2 key wires to stabilize scapholunate joint.
How do you choose to go dorsal first or volar first in this case?
Well, we use we go first Waldorly, stabilize Waldor rim, then radial column, and then go for dorsal fragments. But if you can't fix dorsal fragments with Waldor approach or Waldor plate, then you should put your screws not very long, especially to ulnar corner. You should go dorsally, make your dorsal reductions or intra-articular reductions, put the dorsal plate. Then you can change Waller plate screws and make them longer.
To roll this, there's this device by the Acumet guys where you can put in a peg and then put in make a small incision and put in a screw dorsally, and it actually compresses those dorsal fragments. That can come in quite useful. But I agree with you. I fully agree that we go in volarly first and fix the as much as we can from the volar side, and if we can't get those dorsal fragments, then only we go in dorsally. One more question I'd like to ask. I know you did a lot of work on this. I just wanted to know what you found. How was the DRUJ? And that ulnar styloid looks rather large, that fragment.
Yes, I agree. There is a ulnar styloid base fracture, but after fixation, all these fragments, we examined DRUJ and it was stable. And we decided not to fix the ulnar styloid. But many of these styloid base fracture require fixation.
Okay, so Dr. Tugo, we almost time's up for this section. Maybe you can try to conclude your section. Yes.
Okay. So what are the advantages of your approach? If you can reduce your fragments with traction, or if you have volar shearing, volar capsular injury, displaced volar rim fracture, or artery nerve injury, you should do a volar approach. But if you cannot reduce fragments with traction, or if you have dorsal shearing fracture, or intercarpal ligament injury, as we experienced in our case, or scaphoid fracture, you should consider doing a dorsal approach. As a summary, each distal radius fracture is unique, and you must understand the functional anatomy, and you must be able to perform various approach to the wrist and provide stability to all unstable fragments, if it's possible, of course.
Thank you very much. I think we have very good discussion on the cases. So may I invite the next speaker, Professor Suhi, to talk about scaphoid fractures.
Dennis, am I audible?
Yes, you are loud and clear.
Right. Thank you very much for inviting me to speak on scaphoid fractures, and I'll get straight away to this case, who's a 28-year-old patient who fell down a flight of stairs and has pain and swelling of his right wrist. Would anyone care to comment about what is seen on these x-rays? And this is what we normally get in a trauma room.
Given that this is a scaphoid session here, I assume there's a scaphoid fracture. But in that oblique view, in the oblique view, I do see the possibility of a scaphoid waist fracture on the X-ray on the right-hand side.
Right.
So I would, based on clinical exam, I'd probably get additional imaging.
I remember Andy coming into the casualty room. I was his senior, and he would ask me such serious questions about the scaphoid. I had no answers. So, Randy, you still have all the answers, and I still have all the questions. But yes, what would you do in a case like this? The reason I'm asking this is because this is normally passed off as being sometimes as not having a fracture. So, would you do anything at this stage, or would you just put him in a cast and patient does have an obvious swelling? So would you put him in a plaster cast for X-ray him, or would you look for a CT scan?
I'm sure everyone's setting is different. In our setting, we can now get CT scans very quickly. So even in an outpatient clinic, I can send him down to X-ray and he can be back in half an hour with CT scans. Certainly, MR takes about a week, even in my hospital. So I would just get a CT if I suspect a scaphoid. If I wouldn't suspect a scaphoid and I'm thinking scapholunate or something else, then I'll get a MR and I'll see him back in 10 days. But in this case, given that appearance on the X-ray, I'd probably send him for a CT in the clinic and figure out if it's displaced or not.
What if you saw something like this on the CT scan? Would you want to fix him or would you not want to fix him?
Now this is where the discussion comes to the patient, right? About his job, how quickly he wants to rehabilitate. And just on one plane, I don't get too concerned, Sudhir. And what I do is I get them to reformat along the scaphoid axis because when they do the wrist CT, it's can be misleading. So I look at the sagittal and coronals, and if it looks non-displaced, then I think there is evidence that cast or screw will still heal in 4 to 6 weeks. But if he needs to get back to work or at least move his wrist sooner, then I have a low threshold to fix these percutaneously.
Yeah, more and more we're seeing patients who want to get back quickly. And when you discuss the fact that they're going to be in a cast for 6 weeks and then maybe a few weeks of therapy, they'd rather opt for a surgery. We also have some social indications like students who want to travel just before they leave. They're playing a lot with their friends and they enjoy themselves. And then it's time to leave and go off to countries where they don't have medical insurance. So the indications are now becoming a little nebulous as to whether you would consider. If I had, I would probably think in terms of getting a screw in and getting on with work. If there are any contrary opinions.
Scaphoid fractures are quite notorious. So even though this looks like from the X-ray, looks like a waist and it's transverse, it's not oblique, I would still, get a screw in. Yeah.
Mm-hmm. So here's a patient who refused to get a screw in, and we had to conserve him. So this again was a waist, and it looked fairly in position, and we did manage to get a good result. So we know from literature that a large number of these which are undisplaced or minimally displaced, and that's where the whole discussion comes in. What is minimally displaced and on what modality are we talking about? So, but then if they are good, then they go on to a good union. But on the other side is, and of course that you increase the risk of complications when you operate them. Dias's paper also talks about the fact that open methods are better than percutaneous methods. So percutaneous methods are gaining ground, and it seems simpler to do. And probably some of the older percutaneous studies had the problems of a learning curve involved in that. But once the fracture is displaced by more than 1 millimeter or 2, then the chances of a non-union increases to 17 times more. And then it wouldn't be right to put these patients into a plaster cast. And that is reflected in another paper which talks about a 55% risk of a non-union of displaced fractures treated in a cast. Now, these are numbers, and numbers are always confusing. Numbers are always things that you want to have in the back of your mind when you're discussing with the patient, and yet oftentimes you'll come across a patient like this who is and is young, 17 years old, and says, I don't want a screw in there. I don't want a surgery. So what kind of a cast would you give him? An above elbow cast, a below elbow cast, include the thumb, not include the thumb, pronation, supination? Does it make a difference?
It doesn't make any difference as far as I know.
Right. So most of the studies that were there in the past, a lot of these studies were there in the past, and they've all been very vocal about their own methods. But more or less, I think we've come to a point where most of us would give a below elbow cast and probably not include the thumb. And some of us who choose to include the thumb would include the thumb up to the IP joint and keep the thumb in the glass holding position so that you can actually function with this plaster cast. So at 9 weeks, I was still in doubt about this patient, and he's had a birthday in between. He's become 18 years old, but 20 weeks later, he united completely. So, and he had an excellent function. So these numbers are something that always catch you out, because at times you may give opinions to patients. They may go to some other surgeon who says, no, I'll give you a plaster cast, and he becomes all right. And then he comes back to you sometime, or maybe some relatives come back and say, you know, that fellow, he didn't need a surgery. So when you discuss this, the numbers game has to be discussed in the right perspective. That's an important point.
I think the other thing is to also find out whether he's a smoker or not, because I think
Oh
that
yes, oh yes, oh yes. That's one definite negative when you're dealing with the scaphoid fractures, and it's been shown beyond doubt that smoking does affect the union rates in scaphoid fractures. So looking at
his duplicated thumb, I assume he's not trusting of surgeons anyways, right?
Pardon? I didn't get that, Randy. Nobody is trusting of surgeons in any case. Everyone does not want an operation, except the surgeon, I think. Every time it's a big fight trying to get surgery across when you have a whole bunch of people who are ready to conserve. So it's always difficult to get this. So, okay, let's move on. This is a patient who's been selected for conservative treatment, but at 6 weeks, and I'm showing you only one X-ray. Sorry for that, but it shows what I mean to get across. There is a gap and there is a displacement now. So it's now 5 or 6 weeks, and it's time that we make a decision whether we want to continue with the plaster cast or not. At this stage, what would you plan to do? Dr. Dewey?
I would definitely take off that cast and go in for surgical treatment.
I shouldn't have asked you, because you're going to put a screw in all of them. You just mentioned
except
that.
maybe the first one.
Right. So the question here is, would you add grafts or would you not add grafts, and would you go in volar or would you go in dorsal?
Well, I have been caught before where patients have said, you know, it's a fresh fracture and it's actually not. So I do like to go in with an MR sometimes. And I found it's just to safeguard oneself, and also to look at other possible associated injuries. So there's a few things that we look at when we ask for an MR. One of them is other ligamentous injuries, but the vascularity of the proximal segment, and you know, if we are missing something. So I would do that before I rush in to do anything else.
All right, we'll come to the MR a little later if we find time. But the point I was trying to make here is the fact that some of them may not need anything but just a good screw right across to compress that fragment down and get a good union. It's cases like this where you have the formation of a cyst and a complete displacement that you need to consider putting in grafts. So Dennis, what type of a graft would you opt for, or would you look for further investigations?
Well, I usually want to see if they did vascularize or not. If vascularized, my teachers probably will use the distal radius 1-2 arterial. Yes. So, but I personally did not do a lot of scaphoid fracture myself. Yes.
Oh, okay. So that's right. When you have a cyst, you need to also assess whether you need to put in some form of grafts. And this is another case, but all that it requires, if it's not collapsed, is just cancellous grafts and a good screw to put across to get union in these cases. So you need to see the proximal pole, the proximal fragment at this time. We've not reached the proximal pole fractures yet. These are more waist fractures. and they usually are vascular enough. And especially if it's 6 to 12 weeks, that's a good time to put in just cancellous grafts, clear up the bone, and go on with that. What if there is collapse? When you have an established collapse like this, uh, almost like a humpback deformity. A humpback deformity is described as one that has almost a 40 to 45-degree flexion of the scaphoid with an overhang and seeing the bone on both sides of the proximal hole when you look at it in the PA view. And that would mean that the middle segment of the bone is affected and has lost bone because of constant rubbing over time. So in such a case, you would need to think in terms of graft. So here you can see the scapholunate angle has changed a lot. The scaphoid's gone into flexion. So there is collapse, and it seems as though cancellous grafts alone won't do, but it still is a waist fracture. So what would be your choices for the grafts at this time?
Well, I would choose iliac three-cortical bone graft for this case.
Right.
But before, as Dr. Rohi said, we can have an MRI to see if the fragments are vascular or not.
Right. So we do need structurally stable grafts when you're fixing fractures like this. And you can assess collapse by various means, by looking at the angles and by the indirect means of seeing the DZ that probably is there. You could use the Roos technique where you can inlay the graft into a slot that you can create, or you can use the Fis-Fernandez wedge graft as we did use in this case. Now, the approach for these would be preferably volar, and you would tend to try and use the nerve sparing approach. The reason being that if you try and stay within these innovations in the ligaments that are supporting the wrist, then the mechanoreceptors are not affected. So post the repair and the healing, if he does have another injury, these mechanoreceptors are capable of protecting this joint just as it was before he fell the first time. So it's
I don't subscribe to that. So there, I think that's all focus.
I don't want to believe it until Randy proves it to me that it's a hoax. But it seems logical, Randy. Why not?
Too much science. It's too much science over basic orthopedic mechanical fixation.
But then you want,
Especially for us orthopods.
Pardon? Pardon?
I said, especially for us orthopods, it's far too much for our brain.
It's just a slight change in the way in which you're running your knife. You're going to cut and you're going to get in there and you're going to put in your grafts in any case, and you get two nice flaps to suture. I think.
No, we're just messing with you.
I know, and I think Mark Garcia is messing with all of us. But I quite like it because I get a good approach and I can open two nice big flaps, and I go home thinking I haven't done too much harm for the patient. Randy, you got a lot of work to do. Well, the first thing that you need to do in these cases is to restore the height. So you need joysticks. You're going to put in the joysticks and restore the height, and then you calculate your wedge. When you restore the height with the joysticks, you can see the mid-carpal joint on the right is well maintained, and you can see the smiley face of the mid-carpal joint, and I love to see that. Once I see that, I know my graft is to be trimmed to that size. You can use distractors intraoperatively. You can wedge in your graft and then tailor it into place and get them to heal and give you a good result. Especially when you're dealing with non-unions, it's better to use screws. There are studies that show there's a slight advantage, but K-wires would do if you use them well. We'll quickly come to the proximal pole. We have 10 more minutes.
Yes.
This is a fresh fracture. Would anyone care to go about how would you treat this one? This is a fresh fracture in a young patient.
This is the one where I usually tell the patient it's probably a good idea to get this fixed, simply because the fragment is small, union rates are a bit lower, and fixation and reconstruction late is much more difficult. So in these ones, I tell them, if you were to ask me what I would do for myself, I would have it fixed. So I certainly would strongly recommend fixation.
Right. So if you conserve them, a large number of them, that means 1 in 3 is going to go into a non-union. So you don't want that to happen to your patient. Would you care for an MRI at the in a fresh fracture? Would it tell you
I
anything
think,
that
It's not unnecessary, I think.
yeah, just fixation.
yes, my big worry is when do I ask for an MRI? At what time frame? And no one's been able to tell me this. 2 weeks, 3 weeks, 6 weeks, 8 weeks, 3 months, 8 months, 1 year, 2 years, and how? So anyway, we'll come to that a little later. But this patient came to me with an MRI, which really wasn't necessary.
Actually, so there, I would say any time after 6 weeks, but if you ask me why, I don't have a reason for that. I'm not as intelligent as Randy, so I can't come up with the answers. But I tend to think that if it's more than 6 weeks, and it's just that vascular supply is precarious, and I would just be more comfortable getting an MRI.
Right. So this is what we fixed. Here's another patient. He's now 8 weeks out, and he's got a proximal pole, and you can see a little gap in there. So you need to do either an MRI or you can do an intraoperative assessment of the proximal pole and be prepared to do a vascularized graft in these. So here's one where we did cancellous grafts. He had punctate bleeding, and we put in an antegrade screw, and he had a great result. So when we come to MRIs, the one thing that, especially in India, because we have very few 3 Tesla machines, most of them are 1.5, and many centers do not have wrist coils. So you don't get good information that you're looking for. You need to have the radiologist rather than the technician to be there, and you can ask for contrast enhanced MRIs, because that gives you a little better idea. But far more important and far more informative, though the science on this is still evolving, is to use the dynamic contrast enhanced MRIs. That tells you with time as a part of this whole thing, that how much time does the proximal pole and how much time does the distal pole take to vascularize while the scan is being done. And that gives us so much more information. And if both these curves are close to each other, that means both of these sides are being vascularized or getting enough supply. And then you would consider, rather than looking at black and white images with fat suppression, with stir images, they'll confuse you with so many terms. But when you have a dynamic contrast enhanced MRI, you get far better and clearer ideas. Of course, David Green's technique of looking inside and saying this is subjective, but I think it's useful, as can be seen in this patient, where you can actually see nice punctate bleeding before I've already gone in. Just as soon as I opened it and scraped it a bit, you can actually see that before you burr it. Because if you have a completely avascular proximal pole, the chances of union is almost zero. So you then need to think in terms of getting in some fresh blood supply. And as someone discussed, that you would look in terms of getting one of those, which you're very confident of doing. The commonest one, of course, being the Zeidenberg or the 1-2 ICSRA. We've done a few of the others. I haven't done the Matula Wohler graft yet, but that seems to be promising as well. The only point about that is that before you go in, you've got to identify the vessel. It's a very delicate vessel, so you've got to identify the vessel, base your graft on that, get that out, then go to your bone, to your scaphoid non-union, and get it in there. So here's a patient with a avascular proximal pole with the ICSRA packed in and fixed with a screw and went on to a good union. So these take about 3 to 4 months to unite. Now here's a patient, and this is my last case, who is a non-union since 1 year, and he had a problem with the vascularity in the proximal pole. So I did a 1-2 ICSRA with a screw. At 5 months, he wasn't looking too great. And at 19 months, he's looking horrible. He's got a fair range of movement, but he's got a lot of pain. What would you now think in terms of? Subrul?
Yes, I would consider removing the screw, and I think you can do a medial femoral condyle graft with cartilage in this case. As a
Randy?
salvage procedure.
You know, I'd give him two options there. I'd either put a rib cartilage or do a scaphoid excision and four-corner fusion. Depends on how much uncertainty they're prepared to put up with. To me, a salvage procedure has more certainty. He's got 90 flexion extension, so I assume losing half of that will still be pretty functional. But if he's a bit of a risk taker and says, I don't mind if you try something else first, I find the rib costochondral is much of a less morbid procedure than opening the knee and putting him into the knee clinic. If you want to get rid of him.
And this is a non-vascularized graft you're talking about.
It's non-vascularized, it heals pretty well, and you're just using a big cartilage filler in that space.
Do you overstuff it? Do you overstuff it, or
you have to, because there's no ligament, right? There's no scapholunate ligament, so you overstuff it a little bit, but you can shape it very easily with a knife into a curve and just stick it in there. And it looks like an empty hole, but there's cartilage in there.
Yeah, we did a couple of these, but for some reason, I think maybe more than anything else, it's not fashionable to do that. So we moved on. So we moved on to the medial femoral condyle graft.
You know, this is one of the questions that I wanted to ask you a bit earlier, but I was just waiting. I have noticed you're very skillful with the screw when you do a vascularized bone graft. I always have trouble with those things, you know, they're twiddly little things, and to actually put in a screw down the center and get a good fixation. In fact, there's a nice article about stability versus, you know, fragility. We've got a small little pedicle that's going in. We want to be extra careful about it. And so the point I'm trying to make is that sometimes we actually don't need that vascularized bone graft. And if we get a good solid bone graft from the iliac crest, we can actually put that in and get a good solid fixation. In this case, the patient you just showed, I may want to do that and then use a scaphoid plate. And that would give me stability and good bone graft fixation, which just might work.
Right. So that brings in plating, which not a lot of people are doing. And I certainly have not done any. Randy, have you done any plates for scaphoids?
I have, but more on the palmar aspect, Ruhi, simply because on the dorsal side, with this little proximal pulse, there's no room, right? But you know what? I've done 8 of them, Sudhir, and I have 100% plate removal rate, right? And 2 did not unite, and they were all for failed screws. So they were a second redo. But the plate almost, I've had to remove it because it impinges inflection, even though I cut the plate short, etc. But yeah, it's not a large series, not 30 and 40 like some people are doing. But I only reserve it for a failed previous bone graft and screw.
Yeah, we heard Sumit Talwalkar from Wrightington talk to us about this, and he was very enthusiastic about this. But we did the medial femoral condyle graft, and like Dr. Rui was saying, getting in a screw from this one. I'd like to respond to your comment about the fiddliness of using small fragment. It's the good ones that I show during presentations. Obviously, I've got some KY ones, which I don't want to show you. But we do obviously not fix the modality of stabilization preoperatively. We take that decision obviously on the table, and when we find it's precarious, because we spent a whole load of time trying to maintain the vascularity, and then when you bring it here, you're going to just explode the vascularity. So you need to be a little careful. That's a good point that you brought out. But this guy has gone on to union, a sketchy little union, but there's a lot of there's a lot of cartilage there. So you always, like Randy mentioned, not going to see strong bone like a scaphoid, but that's how he's united. In some of them, we managed to get in a screw like this one, and they go on to union. So in summary, and I have just about 1 minute, the way I look at scaphoid, especially non-unions, is that I assess whether there's collapse and avascularity. And depending upon that, if there's no collapse, no avascularity, and it's early enough, all it needs is either just a compression screw or cancellous grafts. The moment you have collapse and it's still in the waist region, then I would think in terms of an iliac crest graft. You could use grafts from the distal radius or the olecranon non-vascularized in these cases. And if there is a problem of vascularity, I think in terms of a distal radius vascularized graft. And if there's a collapse plus an avascularity, and it's a case where something else has been tried and it's failed, then I'd like to use the medial femoral condyle graft with fixation, because at least until now, I'm sure the future is going to show us different numbers, but at least until now, almost all numbers are 95% or 95% and above. That's what I think.
Yes, thank you very much. So time is almost up. So we would like to let the next speaker come, Professor Ruhi, to talk about TFCC and DRJ injuries.
You're mute, Dr. Rohi.
Yes.
Sorry. Okay, I was going on and on. Very good afternoon to all. Thank you very much for the invitation for me to speak here. It's a very interesting session that we're having. I would, without further ado, I'd like to go in. We're talking about injuries to the triangular fibrocartilage and the distal radial ulnar joint. It's always a mystery at times, and I'm talking about mostly the acute injuries. So we'll go. I do want to point a few things out in terms of the anatomical aspects and the mechanical considerations before I go on to discuss the cases. So if we look at the AP film of the wrist, we see that the ulnar styloid is actually in the lateral view, all right? And when we look at the lateral film, we see that it's actually an anterior-posterior projection. And when we look at the joint end on, and we look at the scaphoid and the lunate fossa, and this is where the triangular fibrocartilage disc would be, and then these are the dorsal and volar radioulnar ligaments, right? Now, when we look at this from this point, there's a couple of things that are very interesting. So the ulnar head, as you may well know, has a smaller radius of curvature as compared to the sigmoid notch. So this is about 10 millimeters, and it has its center at the fovea, and this is about 15, and the center of rotation is at the ulnar styloid. Now, I'm not going to go through the classification because I think everybody can look at that. But what I do want to emphasize here is what the triangular fibrocartilage complex is all about. So here we have the scaphoid fossa and the lunate fossa, and this is basically a cadaveric dissection, and you can see the triangular shape of the TFCC, and you see the thickenings on this side, and these are the dorsal and the volar ligaments. And what we have is this is inserted into the fovea, so you have the meniscus homologue and the ulnar collateral and the ulnocarpal ligaments coming off here, which are also part of that. And we should not forget the ECU sheath. Okay, now biomechanically, we always talk about tension and compression, but I want to introduce this concept of tensegrity, which I found quite interesting, developed by Kenneth Nelson in 1948. And what his premise is that the integrity of the structure is actually a balance of the tension and not the compression unit. So he did some very nice sculptures which are actually basically suspended in midair. And if you look at some of, I like carpentry, obviously I'm in orthopedics, so if we look at how this chair is constructed, there's nothing actually holding it. So basically it's the tension. Now how does that apply to the radius and the ulna? All right, so we talked about acetyloplasty and we talked about the interosseous membrane, and that is the rope that is holding it. And on either end, at the proximal and at the distal, we've got the proximal and distal radio-ulnar joints, which is important. So that's why I'm emphasizing that here. And if you look at the shape, it's actually twisted. So there's a little bit of a twist to it, and that's what gives us the pronosupination. Now, if we look at Benjamin Liang's paper, this is from from Khoo Teck Puat Hospital in Singapore. They treated about 1,000 patients, and what they found, interestingly, is that it is important to get the distal radius. We know that, to get the distal radius articulation right. But what they also talk about is this distal oblique band. And this distal oblique band is key to maintaining the tensegrity. And so if we get this to radial height, then the TFC maintains that tensegrity along with this. So most fractures would be in this portion, and that's why this part is extremely important. So now we come to the cases. Having that background knowledge, we come to the cases. This is a straightforward a young gentleman. He's a banker. He's quite athletic. He loves to cycle, but he fell down on his outstretched hand, and he has pain more on pronation at the extreme end, and a little bit on supination, and he has trouble doing push-ups after 2 to 3 weeks of resting the joint. And he's tendered the TFC and the ulnar styloid, but he has a fairly decent range of motion, and there was no DRUJ laxity. So the X-ray basically looks quite all right, right? I'm not going to ask you guys yet because there's more exciting things to come. Okay, so at this point, all right, would anyone like to comment? Let's see. Togrul, are you there?
Yes, I'm there.
Okay.
So
what would you like to do?
Well, in X-rays, I recognize positive ulnar variants.
Yes.
I would like to see 90 degrees elbow flexion and abduction X-ray.
Those were all pretty good.
Okay.
There was no laxity, so the joint was stable. I'm sorry, I don't have the lateral, but we've got the MR here. So what we did, because I was a bit suspicious, so even though the DRUJ was pretty taut, there wasn't any laxity, but I just thought I would do an MR just to be careful. And what we can see is the superficial fibers are intact, and the deep fibers seem to be just a little bit there. Yeah.
Yes.
Okay, now when we take a closer look, Togrul, what you said was right, because he's ulna plus, right? So we can see that there are a lot of films, but this one kind of shows a little bit of chondromalacia there. So what would you do with this gentleman?
Well, I would I will consider doing arthroscopic wafer procedure, maybe to shorten ulnar positive variants, and I will also check for TFCC. And if I recognize rupture, I can make TFCC repair at the same time with wafer procedure.
Okay, so we were not as adventurous. we actually treated conservatively. Um, uh, he was not too keen. I did suggest surgery, but he was not too keen. So we did splinting, and we offered injection, but he was not keen for that either. And so he actually got better with about 2 months of splinting, and he was back on the road again. Although I think, what you said about the ulnar plus, I think that's going to cause him some issues, because here we can't see anything on the x-ray, but the MRI is just a hint, just a suggestion there. Okay, on to our second case.
Ruhi, I have a problem with MRIs because they overdiagnose TFC tears, as you know, and they overdiagnose TFC pathology. So if you're looking for an operation to do, I guess it's a good idea to do an MRI at the outset. But generally, I find it less reliable. And in fact, there was a study in the Journal of Hand Surgery where they took young asymptomatic volunteers in their under 30 years of age, and a large percentage of them had radiographic report of TFC tear, including foveal tears. And these are young, healthy people. So the overread of MRI is pretty high in my mind.
Even I have the same opinion, Ruhi. And did we get the other wrist X-ray also done for this patient? No?
No, I didn't get the other wrist done. But for me, with TFC, and I'm going to discuss that in a while, I actually find that, although arthroscopy is very good, I actually find splinting works quite well in my practice. So quite a number of times I actually get away with splinting and conservative management as opposed to operative. I don't know what you guys think about that, but as I grow more on these things, I find I tend to go more non-operative than operative.
I
How
totally
many
agree.
weeks do you wait until symptoms resolve?
Well, if the patient, it depends a little bit on the patient, but definitely on my side, I would give them at least up to 3 months. So 2 to 3 months. If the patient is really not keen on splinting, then I would actually go ahead with surgery then. But otherwise, I would give them a good 2 to 3 months, sometimes even longer, because once they have that splint on for a couple of months, and this is the monster splint we're talking about, so it's not a small splint. So but then when they get used to it, and of course during that time we give them some therapy as well, some ultrasound, some hot pack and all that, and a little bit of range of motion exercises. So I find even up to 3 months, I'm not too worried, sometimes even longer.
Ruhi, for these kind of patient, even I am in favor of these conservative, because I'm not an arthroscopist for us. Another thing which is important for these who are doing a lot of exercises and push-up, that alteration of these kind of activities has a long-term result. So they need to alter these habits and these activities.
Exactly. Very well said. So I actually advised this gentleman not to do the normal push-ups, where we do that, but to do more of planks. I find that is safer, and it engages more muscle mass in other ways, and is a better exercise than doing push-ups. So thank you for that. Yes, I agree. I don't know, Dennis, do you go into
No,
okay.
I concur with your find. I find most of them are really improves, especially in distal radius fracture. Some people will just treat acutely for all those soft tissue, but I find it is usually not necessary at the acute stage. At least wait for 2 to 3 months. We'll see them in clinic, see how the therapist report to us. Yes.
Okay. Shall we move on to the next case?
Yeah, sure.
Okay. So this is a 49-year-old female surgeon. Marinis was talking about female orthopedic surgeons. So lifting heavy boxes and felt a sharp pain on the ulnar aspect of the dominant wrist, right? The pain was mostly on supination, a little bit on pronation, but there was not much limitation of flexion extension. On examination, the patient was tender at the ulnar snuff box and slightly distal to that. There's a little fossa, so this is the ulnar snuff box, and then just distal to that, where the hematotriquetral joint is, and the DRJ was stable. Okay, and now if we look at the X-ray, this is the right wrist and this is the left wrist. All right, so somebody was asking me earlier whether I have the left wrist X-ray. So this patient, I have a right and a left. And let's see, Randy, do you want to comment on that?
Yeah, I see some cystic changes on her ulnar half of her lunate bilaterally.
Yep.
Initially, when you first presented it, I was going to say I would look for ECU subluxation. I wondered if she if she had an ECU sheath tear, with a subluxating tendon, but clearly it's not. Now, even though she looks ulnar neutral, from what I can see here, there appear to be some changes on the ulnar half of the lunate. So it looks like she may have ulnocarpal abutment. That may be an issue there. So this is one where I do get an early MRI. So I don't not always get MRIs. I do love my radiologist. So I would get an MRI on this one. And I'd
so
look
you
for
can
signs of
see,
ulnocarpal infection. Yeah.
so this is a closer look at it, and you're right. You're absolutely right. You can see that there. And that's the MRI. We've got more coming. So you want to comment on that MRI? That
Yeah,
already gives it away.
It shows an attenuated TFC. It shows edema. I mean, I prefer to see a T2 image, Ruhi, just so that I can see. There we are. That's better. So I can see the bone marrow edema. 9 out of 10 times, the radiologist will call this Keen box disease, and I tell the patient, don't be alarmed. Your life is not over. Everything's going to be fine. It's just a matter of getting your ulnar shorter. So again, she'd get the injection, she'd get the splint, and because this has been there all last 49 years, she might get another 5 years out of that. And when she gets fed up with it, I'll shorten her ulnar for her.
So she got fed up real fast.
She got, okay.
Remember, orthopedic surgeon can't wait.
I like arthroscopic wafers, but I find that the outcome can be a bit variable. So I reserve those for my 70-year-olds because for them,
we're coming
they don't
to
want
that.
a big operation. But so yeah,
we're coming to that. So here, remember, she had some tenderness here, so you can actually see there's something going on here as well. There's a little bit of instability at the hematotriquetral joint. So that was a bit of concern, and actually a lot of the lunate is gone if we look at that. So you're right, she had a ulnocarpal impaction, a TFC tear, ulnar, because of the ulnar plus, slight ulnar plus, and hematotriquetral instability. So she was put on exactly like what you said, Randy, splint, glucosamine, injections, restriction of movement, blah, blah, blah. But the patient was keen for something to solve because actually she was not able to proceed with work. So she was having quite a bit of pain. You must remember that as surgeons, we'd probably be doing a lot of those impact exercises, which we ask our patients to avoid. But we obviously don't listen to that. So, so do we do a TFC debridement? And you were coming to that, right? So basically, when we do a debridement, you're right, we're going to make a ugly hole a nice clean hole, but that's about all that we're doing. So do we do a wafer or not? So Tomino and al, they actually felt that just doing a debridement was not adequate and we probably needed to do something else. So the question is whether we do a wafer or whether we do an ulnar shortening, right? Randy, you were saying something about that, yeah?
I find the ulnar shortening, the diaphyseal shortening, is more reliable. I certainly would scope it as you have done, and certainly the arthroscopy, when you have an advanced, as you know, when you have an advanced ulnar-sided abutment syndrome, you do get secondary lunar triquetral instability, and that could lead to her developing hamate triquetrum symptoms. In those cases, again, that further strengthens the case to do a ulnar shortening, so you get a little bit of tightening of the ulnar side of the wrist. So I find in someone who's a surgeon in this category, I think an ulnar shortening would give her a good outcome.
Right. So agreed. Patient did not agree. Patient did not want an ulnar shortening the traditional way. Although we've got some nice plates, but she was a bit concerned about the hardware. And of course, we've got lots of trials saying that the wafer procedure is actually gets the patient back to work faster, and there's a lower complication rate, and also a good grip strength, but that was not significant. So we went ahead and we did a dome osteotomy. Basically, we did do a resection, but what we did was a bit more than usually. We've actually shaved off quite a bit there. We did a hematotriquetral ligament reconstruction using the ECU part of it. We also did micro drilling of the lunate, and then we gave some HA and some stem cells. And then we also, of course, we then splintered the patient. Right? So we're going to come down to after the quite a stormy follow-up. So there was a lot of physiotherapy, but the patient was actually very compliant. So after about 6 months to a year, she was pain-free, and at 5-year follow-up, she's got a fairly decent range of motion and quite a good grip strength and pinch strength. And if we look at the 5-year x-rays, so this is the initial one, and this is the at 5 years. So you're right, you know, there is quite a little bit of arthritis, but at the moment still symptom free, right? So surprisingly, although there is a paper that says that happens, you can see that the lunate has actually come back. You know, it's the cysts are reduced, and we can see from the MRI, this was taken in 2014 and this is in 2020. So we've actually regained back some of that lunate, which is quite interesting. And if we do look at the coronal views, again, this is in 2014, and we can see actually some of the cartilage coming back. So it's quite interesting to note that. Any comments?
I find that those who are concerned about the plate, right, Ruhi, the option of doing a distal ulnar shortening osteotomy, you know, right at the level of the metaphysis, the metaphyseal shortening, and fixing with
those heal better, right?
Yeah, and they don't have the hardware problem. In this case, I still would have done the diaphyseal shortening simply to tighten up the ulnar side of the wrist. I perhaps may not do a lunate, you know, the ligament reconstruction, simply because I'd be concerned about making her stiff, and do it as a secondary procedure. But I can understand you want to try to do everything in one go because it's a colleague and they don't want too many operations and time off work, etc.
Yeah. We had 2 hand surgeons working on her for 4 hours.
Understand. Yeah.
It was, yeah. I mean, a fairly demanding patient, but you know, sometimes we do that for our colleagues, right? And then we get hit for it as well. But anyway,
that's my concern with the wafer in younger people, is the secondary arthritis, whether we create some issue there because the head is no longer smooth, you know.
Yeah. I remember Louis Schecker would say, would probably turn in his grave and say, no wafer, no wafer. But anyway, yeah, you're right. That's an issue.
Ruhi, the lunate coming back to normal on MRI, if you say that, was it due to those micro drillings or combined with the stem cells. I mean, my purpose of asking is that would you contribute this all to stem cell?
You know, I actually do not have the answer for that. I did some literature search, and some papers actually say that you know, the MRIs done 2 to 3 years later also show in some patients that some of the lunate recovers, although in this case it is quite significant, I would say, because if we look at the numbers, it's doubled, right? So I think there is some component in terms of the stem cells. How much, we can't say.
Okay.
She had about 3 injections of stem cells.
Okay. Randy, what is your experience regarding this kind of where you already have lunate eaten up a bit with this and you do an ulnar shortening? Do these lunate come back like it had came here also?
They do. They do. You know, a lot of what you're seeing is just bone marrow edema. Remember, it's not truly a missing lunate. A lot of it is bone marrow edema, so that will recover anyways. But the cysts do recover. They're like cysts, and by drilling those cysts, Rui has decompressed the cyst. There's no longer the impaction occurring, so naturally bone would regrow into that. So yeah, I've seen even large lunate cysts recover. Remember, this is not Kienbock's disease. This is a cyst from pressure. You decompress the cyst, and the cyst should fill in back again.
Okay, thank you.
Okay, third case. We're still with the TFC, but maybe I should go on to the DRUJ because we're kind of a bit short on time. So I'm going to go ahead and come to DRUJ. We've got about 5 minutes left. So with DRUJ's injuries, as we discussed earlier, you know, there's a lot of factors. They don't usually occur just on their own. They're associated with a lot of other bony injuries, radial head fractures, acephaloplasty, Galeazzi, ulnar styloid. And what we're looking at is the integrity of the dorsal and volar radioulnar ligaments and acute versus chronic, and whether we should just go ahead and pin it, repair it, or reconstruct it. So this is a very nice article by Lixman in Hand Clinics in the year 2000. He has taken the Palmer classification and done a twist to it, and he's talked about stable, partially stable, and unstable. I kind of like this classification, partly because it makes it easier because it divides into two, you know, generally stable and unstable. And so then we will know what to do with each, right? So let's go to this case. This is a 42-year-old engineer who fell off a cliff, which is about 40-50 feet. So he had quite a fall. He had a loss of consciousness, some chest trauma. So the radius was the last thing that was on the orthopod's mind. So it's just put in a cast, and he came to see me after 3 months, right? So this is his x-ray after at 3 months period. Who's there? Dennis, you wanna
Okay.
take that on?
So this is 3 months. So it really depends on the symptom. It probably had healed, I guess. But if there is a significant ulnar wrist pain, I would have no hesitant to really osteotomize it and fix it. Probably it is a big, large piece, so it won't be too difficult to fix. But some patients, they don't have a lot of symptoms. The other alternative is do ulnar shortening, but it seems, yeah.
He had a lot of symptoms. He was not happy. He had quite a bit of stiffness. He had numbness and tingling in his median nerve distribution. He was generally not a happy camper. Right? So,
but he's stiff, so probably I don't want to lengthen the radius. I probably will go to shorten the ulnar instead. Otherwise, that will make him more stiff if you want to lengthen the radius.
Okay. Any other comments on that before I go?
Clearly, you're pointing to
some kind of complex regional pain scenario, he needs a median of decompression.
Yeah.
And of course, here you've got that radial translation. So his PFC is torn and he's got the radial translation. So his IOM is also loose. So I guess the first thing I do is get this guy into a pain management program, maybe just decompress the carpal tunnel. First get the pain better, then worry about the rest if he's very stiff.
Yes.
Okay. So we were quite ambitious. We did do a CT, we did an MRI. We saw that he's got, of course, as you all said, he's got a TFC, he's got ulnar styloid, DRUJ ligaments are affected. So he's got quite a lot going on, all right? And on top of that, his FCR was severed. We had to do that. So we've got quite a lot on our plate. So I think most of you guys would want to go with an ulnar shortening. Am I right?
If the complex renal pain syndrome is sort of a little bit under control first, otherwise that will exacerbate. Yes.
So
because he's got that spike sticking out there, if his ulnar shortened, it's going to hit that spike. So his radius needs to be corrected.
Yes, so absolutely right. So this was the issue I felt, this part. And so that's why I said, okay, I felt that all that pain was probably due to the malunion of the radius. And so we went on to do a corrective osteotomy and bone grafting and plating. But we were also looking at whether we need to do a DRUJ reconstruction. But we thought that maybe that would be for a second stage, like Randy said. But we obviously had to do a deep compression of the carpal tunnel and a reconstruction of the FCR. So what I find when I do these distal radius fractures, whether I do them first off or whether I do them a bit later, is I like to, when I correct them, and then once the plating is done, I will test the DRUJ. And if the DRUJ is lax, then I would put a pin through it. If the ulnar styloid is big, then I would address that. In this case, we had far too many things going on, so we just pinned the DRUJ and started praying really hard.
Okay, time's almost finished, so probably best to conclude the section.
Okay. So he's got, after about 3 months, we took the pin out after 6 weeks, and the DRUJ was actually pretty good. He was quite happy. His pain had all disappeared. The carpal tunnel symptoms had gone. He had gone back to regular work. I offered to actually see whether we would do the DRUJ reconstruction, but since the DRUJ was good, we said, okay, fine, let it go, and he's quite happy. So that was that.
Just a quick comment, if I may, about the pin through the DRUJ. I've had 2 patients who had cross union at that point. So I generally avoid doing that. I just pass them a little proximal.
Okay.
Okay, thank you very much, Professor Wee. So last but not least, we come to the last section in this morning, which is about Manguing's forearm by Professor Mostafa Mahmoud. So, the stage is yours, Professor.
Yes, I'm sharing the screen. Yes, do you hear me?
Yes, loud and clear.
Yeah, welcome to you all, and good morning and good afternoon for you, of course. And I am an orthopedic surgeon, hand, upper limb, and microsurgery unit, Cairo University in Egypt, if you don't know me. I'm very thankful for you all and for the board for inviting me, sharing my experience. Our practice is a wide spectrum from severe amputation injuries to open fractures and dislocations with associated neurovascular compromise and coverage problems. In our region, we are also exposed to severe gunshot injuries. Some of our patients present in the acute condition while others present and for their secondary procedures or revision surgeries. So in any mangled forearm injuries, all of you know that we take history, especially smoking and comorbidity. We do ATLS, pain management, especially blocking of the brachial plexus, a quick secondary survey, and informed consent for the procedure. And I don't know if you are doing a mangled extremity severity score for the upper limb or not, but in an interview with the creator of the mangled extremity severity score, Johnson, he said that this needs to be revisited in the upper limb, and the 7 score, the cut edge of a 7 is not that strict in the upper limb because we have no replacement in the upper limb. So I'll move to our first case with major upper limb amputation. He is a 58-year-old motor vehicle accident, having one side amputated and the other side severely traumatized. He has no comorbidity. In fact, he is a very healthy athlete. He was a farmer, and he presented to us in 3 hours warm ischemia time. And as you all know, we work on the distal part till the preparation of the patient himself. We do very generous debridement of the muscles attached to the distal stump. We do routine fasciotomy. We do irrigation of the vascular tree to wash out the metabolites. Also, in these patients, we intend to shorten. We plan to do stable fixation. We don't routinely use heparinized catheter for a temporary perfusion. We do routine sampling of the venous return for the potassium level. If it's more than 6 or 6.5, we tend to amputate for the fear of reperfusion injury. And we plan to do intended bleeding, then arterial clamping. In these patients specifically, we repair the brachialis, basilic, and cephalic vein. In all these patients, we tend to repair superficial and deep veins and to do debridement again after revascularization. In this patient, we repaired the median nerve, the ulnar and radial nerve. Well, there was segmental loss, and we didn't repair them. We plan to repair the radial later on. And we performed arthrodesis of the elbow in slightly bent position, and we covered the place where we performed our vascular repair, and we left the fasciotomy wound open. And here I can ask you if anyone wants to comment on how to avoid the crush syndrome, post-crush syndrome, reperfusion injury. How to do you agree with the shortening and the procedure that we have done here?
I totally agree, Mustafa. I think when you see some of the experience from India, from Ganga Hospital, where they've had the largest series, I think the shortening is the key for all these major limb replants, that we avoid a vein graft. If you avoid a vein graft, you have one anastomosis, less chance of getting it blocked. So no doubt. I think in this patient, the sad part is the level, right? It was right at the elbow joint. So you're forced to fuse the elbow. So the final function is going to be, unfortunately, quite poor because of that,
Yeah.
but there's nothing you can do about it. So I agree with the shortening. I think the fasciotomy is good. In our hospital, we put them in intensive care, because these guys have lost a lot of blood. They're high risk of infection. And certainly, as you do, we put a wound vac, leave that fasciotomy open, and then we come back at 48 hours and then either we'll skin graft it or do a flap. It just depends entirely on what's going on and what tissues are exposed.
Okay. And a week later, we performed his other hand, and the other hand had crushed forearm also and crushed hand, but there's no problem with the skin. And this is how the fasciorami wound looked like 1 week later on the amputated part. And you see also in the X-rays of his other hand that there is cross union between radius and ulna eventually occurred in the final follow-up. At 5 months, we plan to graft the radial nerve, and this is the final result that we get in this patient. He has some motion in the AIN innervated muscles and protective sensation in the prehensile area of the hand. And at this point, I regretted not repairing the ulnar nerve, as you see, because the medial 3 fingers are not as good as the index and thumb, and we are still waiting for recovery of the radial nerve. We are 13 months after, with no recovery of the finger extensors. And you can see here his other hand with the cross union of the forearm, but he does not want to remove the new bone formation because he compensates his motion with the shoulder. Any comment on repairing the nerves? Should we repair all the nerves in this emergency condition? Or
I wanted to ask you about that. You know, you had your hands full, right? You know, it's easy for us to sit back and say, you know, should have done this or should have done that. But, you know, you had 2 sides to deal with. You had a lot of decisions to make, and it's not an easy situation. I mean, if possible, ideally, I mean, we would want to repair the nerves. I may think of not joining the muscles. After the bone fixation and the vascularity, I may then go for the nerves. I don't know. It was a extremely difficult situation, and you had a lot of other things that you had to do. I mean, the nerves could wait, but I would want to ask you, why didn't you go in earlier for the ulnar nerve? Was there an issue with that?
For the ulnar nerve, we didn't plan to re-repair it because there is a segmental defect more than 7 centimeters, even after shortening. So we plan to do the radial nerve grafting, and probably this is something I think we regret. Even in a large defect in any nerve, we need to reconstruct all the nerves because this increases the chances of recovering. And this, as you know, it's a one-go surgery. If you didn't address all the components, there will be some time you regret not doing it. You're extremely right, and also if you see these publications from subopathy, considering the techniques and of these major upper limb replantations, as Randy said, they strongly recommend doing everything at the same time and leaving the secondary procedures for something like releases, correction of positions, and not addressing the major neurovascular bundles. So I agree completely with you, Ruhi.
Mustafa, just a comment.
Sure.
If I had to choose between the ulnar nerve and the radial nerve, I'd choose the ulnar nerve to do. The radial nerve is easier to restore through tendon transfers. The ulnar nerve is a big problem.
I completely agree, but we had issues regarding this patient because we thought that that 57-year-old guy, even if he is healthy, is a very notorious for delayed recovery of the nerves, and we didn't expect actually this recovery of the of his median nerve. Where our aim from the start was to give him sensibility in the prehensile area and some motion in like the grasp you have seen. Any other comments, or move to the second patient? Okay. We have also a patient with a severe fracture dislocation of the forearm, and this patient was he's actually an engineer. He's 47-year-old, and he has this injury. And of course, you all know we need to debride these injuries. This is the brachioradialis, and it was an exposed elbow with the head radius subluxatable and the lateral collateral ligament injured all the time. And as you all know, in debridement, we need to identify every longitudinal structure like the vessels, the nerves, and here in this patient we had his posterior osseous nerve going into the supinator, and it was exposed, and he had some weakness of his wrist. This is the radial nerve, as you see, full of dirt and surrounded by dust. And this is his supinator with the PIN emerging from its posterior border, and explaining to some extent why this patient had finger drop, but we didn't understand if it is a muscle condition or it is a nerve condition this time. And we debrided the joint. We removed every debris from inside, and then we repaired the lateral collateral ligament, putting an anchor to close to give him stability, and finally we repaired the anterior capsule and the lateral collateral ligament over this anchor through bony drills to the supracondylar ridge. And in this condition, we had closed the anterior capsule of the elbow, repairing the lateral collateral, and we didn't fix the fracture in this condition. We planned to fix him after the second loop debridement. Any comment from Sudair or Tughrul? The question is, do we need to close the joint in such conditions? If it's your case, will you fix the shaft of the radius in the same time, or leave it for a second stage?
Well, I will fix radius shaft during the initial operation and wait for secondary debridement. And for this case, I will put a vacuum assisted device after definitive radius fixation. So I will fix it.
Okay. So we plan to fix it 48 hours later after debridement, and after re-debridement for the fear of infection. And as you see here, we preserved the periosteum over the proximal and distal parts for better counteraction of infection. And we succeeded at osteocentesis of this patient, and actually we didn't need any coverage for this patient, and we left the wound open. And what you see here is the secondary intention of the tissues. This is what nature does to our patients.
Wow, that's quite amazing. One of the things that I have tried in some of these extensive wounds is We debride as much as we can. And of course, there's a second look debridement 48 hours later. Usually I would try and fix to get the stability. But one of the things that has worked well for me is using what we call the bead pouch technique. So we put in antibiotic beads and then we cover it with a sterile dressing just to maintain the cleanliness of the wound.
We'll move to our next patient with open dislocation of the brachial, open dislocation of the elbow with brachial artery injury. In this patient, you can see here that flexion extension is maintained. However, in any valgus, the joint subluxes, and this is the median nerve stretched over the distal humerus. And this was her presentation to us. And we need to stabilize the elbow to allow us repair the ulnar nerve, as the median nerve. And after fixing the medial collateral ligament with anchors and doing internal splinting between the two ends, the distal humerus and the proximal ulna, we could manage to have a stable elbow that was neutralized with an external fixator, and then vascular graft was initiated. And this is her function 3 months after. This patient had ipsilateral AC joint dislocation that was not addressed in the primary surgery because of the emergency situation she was in. My question is, if you have a severely stretched median nerve, do you leave it to see the recovery of the nerve, or you address it completely, excising the part that's severely stretched and grafting in the first place? Because this patient recovered some of her sensation before 3 months. I'd like to leave the stretched nerve to secondary assessment and to see how it works within the first few months. Do you agree with me, or do you have other experience?
Well, what we do sometimes is intraoperatively try to assess the nerve. So we feel, and if we feel the fibers are in there, I mean, obviously if it's cut, then it's cut. But if we actually feel the fibers inside, then we would actually leave it be and see how much of a recovery there is. If we don't feel very much inside, then as much as it hurts, sometimes it's better to just resect and then join if we can primarily, but if we can't, then it has to be a nerve graft. So I always err on the side of trying to keep it as opposed to cutting it out.
Do you depend on intraoperative electrodiagnostics?
No, I don't do those. I don't have experience.
Me too. Okay. So this is her pictures 16 months following the surgery, and we were preparing her to do release surgery for the elbow. Moving to the next patient with mangled forearm, mangled distal forearm with an ischemic hand. This patient presented to us after a motor vehicle accident with loss of the radial aspect and the dorsal aspect of his distal forearm. And as you see from the dorsal aspect, exposed distal radius, carpus, and lost most of his extensor tendons. And this is his traction x-rays. This patient, we had his ulnar artery repaired after debridement and fixing the distal radius to the corpus. We pinned the corpus in the middle because we plan to do arthrodesis later on. for this patient. In a defect like this, we plan to take vascularized graft from the fibula, osteocutaneous fibula, to cover the dorsal defect and to compensate for the bony loss. And we managed to do this. And this is his picture after finishing the surgery and during the healing process of the defect. This is the final X-rays with healing of the defect. The skin grafting on the dorsum of the hand didn't heal, and this is the picture after his secondary intention for this patient. And you can see the motion of the patient and the sensation. We didn't do anything for the median nerve. Median nerve was just stretched, and he recovered most of the sensation and the median nerve distribution. But as you see here, he has stiffness in the MCPs, and we planned an MCP release surgery for him to improve his grasp. And my question for you is: there any other way to reconstruct the bone in this distal forearm? The second question, would you do radiocarpal fusion and distal scaphoid excision instead of formal wrist arthrodesis in such patient? So there, if you are here.
Mustafa, can you plan the proximal fibula to reconstruct the joint on the fibula side and put a graft on the ulna side in these kind of patient? But probably I couldn't see that. What is the status of carpals? Are there or not?
The corpus is not there. It's even the shadow that you are seeing in the corpus is the dorsal. As you see here, the dorsal part of the scaphoid and the lunate were completely gone. It's it's apparent here.
Right.
This is only a shadow of the volar side of the corpus.
I mean, with that information, I think what you've done is perfect. I mean, there's no point trying to do a radio scapho lunate fusion kind of thing with a graft and try and get mid-carpal movements, because it would be very, very difficult to hold and expect that kind of function to come out. So I think the difference between that and having the function that you got with the fusion would not be very, very much different. And to answer Anoop's question, a lot of times we used to do this for giant cell tumors where we use the upper end of the fibula, and I think they gave really horrible results. We had beautiful slides, but inside our hearts, we knew we were doing not so great.
Yeah, I agree with you, Sudair, for this. And I think we have just 2 minutes left for the last case. This patient presented for us for his secondary procedure after his crushed forearm injury. As you see here, he has a problem with the dorsal skin, and he has extrinsic extensor tightness of his fingers. He can bend the fingers, but the MCPs does not give him good time to flex. We plan to excite the scar, release the MCP joint, and to have a pliable tissue, the thinned anterolateral thigh flap performed by my colleague in Cairo. And it was thinned to be suitable for the distal forearm. And this is what we get after releasing the wrist and releasing the MCP. But still, there's no active extension. And after achieving the passive range of motion, we transfer the flexor corporeal radialis through a graft taken from the foot to to the remaining 2 fingers. And as you see here, the graft is fixed quite nicely to the tendon graft, and we refixed to the extensor expansion of the remaining index and middle finger. The little finger, the ring finger was amputated, obviously, and the little finger was stiff joint. Also, we took superficialis, flexor digitorum superficialis from the amputated ring finger, transferring it through the interosseous membrane to have it repaired to the remaining parts of the wrist extensors to have wrist extension. And this is the final result we get. He had
Wonderful.
quite good finger extension and wrist extension as well. And as you see from the X-rays, there is arthritis of the little finger MCP, so he does not move his little finger quite as good. I think it's time if anyone wants to add a comment.
Remarkable.
I think you have. You first.
Dennis?
Yeah, I said you have an excellent result. So it's so amazing
Thank
to
you.
see all those patients having a good clinical outcome, even though they have very terrible injuries. So yes, so thank you very much. Yes.
I'll skip the last case and I'll move forward to the conclusion. In major limb amputation, avoid reperfusion injuries, in open fracture dislocations, debridement after neurovascular identification, repair of the ligaments and restore joint capsule. In secondary procedure, restore the passive range of motion, tendon release and nerve grafting are the most needed. Restoration of tissue pliability sometimes needs free tissue transfer. Thank you.
Okay, thank you very much. So we have an excellent talk in this section 4. We have had great cases and a nice result. So with no further ado, let's move on to section 5. Maybe I would just introduce the next panelists and moderators as a handover. So we have a very excellent panelists from Melbourne, Mark Blackney and Andrew Opie, and moderators Amy Tonsel and Sarawati. So we'll hand over to section 5 to talk about foot and ankle. Okay. So the stage are yours.
Okay. Thank you. So my name is Amy Towsell. I'm an orthopedic surgeon working in Melbourne. We're all just coming out of lockdown, which is amazing. Our first talk will be on high energy ankle fractures with Ihsan Osman from Indonesia.
Thank you so much, Amy, for the opportunity. Can you hear my voice clearly?
I personally can. Yeah.
Yeah. Okay. So I will ask the permit to share screen. Okay. Okay. For the first presentation, I will get the topic about the high energy ankle fracture. I'm coming from Indonesia, Jakarta, from the University of Indonesia. And to presenting about the high energy ankle fracture as well is quite, in the beginning, it's quite confusing because actually when we're talking about the ankle fracture, sometimes it comes from the high energy, but maybe sometimes come from a low energy. So when we're considering about what does high energy means, it is showing sometimes from the literature showing that high energy ankle fracture, they're also showing about the lock splitter injury, which is indicating they have the transmuscular ankle fracture dislocation. And also if they also having a highly comminuted bone fracture pattern from the, both the malleolar, from the posterior, lateral, or from the medial side. And sometimes it also consists about the major soft tissue breakdown based on the Gustilo-Anderson open fracture grade 3A and grade 3A, B, and C. And also sometimes if consists about the 3 malleolar fracture patterns. And do the isolated malleolar fracture also considered as a high energy fracture, because sometimes they come for us with a soft tissue major breakdown, but inside is only consists about one isolated malleolar fractures. And always the biomechanic of the injury does matter for the high energy ankle fracture. So how about the anatomical disadvantage from the ankle side? Actually, we can see that the subcutaneous location of the medial border of the tibia creates a really high indicated high chance incidence of the soft tissue injury, and then will be leading into the open fracture. And also they have the bony prominence, including about the medial malleoli and distal fibula, and also the high incidence of the compartment syndrome. And the other one is also the lowest part of the body from the heart, which just can make the blood distribution block track, and also the high incidence of the deep vein thrombosis as well. So we can see that the high energy ankle fracture, maybe we can see the pattern from the bone fracture and stability cam from the patient age, also the weight, sometimes with the patient very thin, but maybe came with the obese patient, also being concerned with past medical history, and also energy of the trauma, the bone quality, and also the position of specific organ during the trauma as well. And incidents, which should be suspected with the high energy ankle fracture with the high risk contact sport, and also with the direct blow, road traffic accident, and falling from the height, and also direct trauma to the ankle, and even consists about the street fighting, gunshot, and domestic violence as well. So we can proceed to the first case. This is the case 1 with the male, 40 years old. Sorry, 43 years old with the motorcycle accident since 8 weeks before admission to the hospital. They have the mild right ankle swelling, including about the minor laceration, and also CRT less than 2 seconds, and also the patient first is refused to performing the surgery as well. And we can see from the clinical appearance like this one, and this is the initial X-ray. Is there any comment from the panelists regarding about those about this condition?
Ihsan, may I ask a question? Mandeep Dhillon from India.
Yeah. Yes, thank you.
Is this the X-ray when he presented to you, or is this the initial X-ray?
This is the initial X-ray.
Okay. So did they try to reduce the talus at the time of the ER management, or no?
Yes, they did to reduce the dislocation first at the ER. Okay. As we can see that the fracture is combined between the medial malleoli and also about the extending into the comminutive bony fragment into the lateral distal fibula, and also consisting about the synosmaltic injury as well.
Do you have a CT scan?
Unfortunately, we do have the CT scan because actually, based on our hospital policy for the ankle, if do not consist about the pylon, so they do not will make a CT scan as well.
Oh, because then we get so much additional information about any articular damage or any lip fractures at the back. Anyway, we agree this is a high energy fracture.
Yes, sir. So we can proceed to the next step, that actually this patient, as I mentioned before, that came to us about 8 weeks after the accident. So actually when we open up at the surgery field, we can see that the fibrous tissue had already been covering for all the fracture site. So first we do the fibrosis lysis, and also actually from the previous X-ray, we can see that also the extending comminutive fracture made the ankle is slightly into the valgus position. So we decided also to make the osteotomize from the lateral fibula, and then we tried to not and after we clear up from the lateral side, and then we move into the medial side. Also, we can see that from the medial malleolar fracture, we can see that also the fibrous tissue have been covering all the fracture site, and we also proceed to do the exactly same procedure like the lateral one. And after that, we try to fix and reduce the gap from the ankle joint by using this device, and make the screw insertion for treating the synosmaltic repair. But as we can see that by we get the commutative fractures on the side of 1.5 above the ankle joint, which is indicating there will be the same place that we want to put the screw, but actually in this patient at that size is quite comminuted. So we decided to lift up a little bit the screw more proximal comparing with the usual one. And this is the result after the operation. We can see that, is there any comment?
Janet, Andrew Oppie, and thanks for having us all, and it's a great case. So I suppose one thing I'd ask is, I think the most crucial part of this operation is actually the syndesmosis reduction. And,
yes.
And I think it's the most difficult part as well. And that's something that I would focus on at looking. I personally, when I see that there's been what I would call a frankly dislocated syndesmosis as part of the injury, I would perform an open reduction of the syndesmosis joint. So that lateral incision you've made to fix your fibula, I tend to extend it a little bit anterolaterally so I can actually see into the syndesmotic joint and flick out and clear anything that may be blocking it, and also to help you assess where you are sitting in the anterior to posterior plane, because it can be very difficult, especially if there's a small posterior malleolus fracture, which I suspect there may have been in this case. And I think your comments about where to put the screws is very, very good and interesting too. I mean, I you know, in a way, I ignore where the fracture on the fibula is, because again, I want to get the best for the syndesmosis, because the fibular fracture will most likely heal, and the syndesmosis and the ankle joint is the key to this operation. So I'd be looking at putting a screw straight through the fracture site, or even maybe in that third screw from the distal end of the plate, for the syndesmosis to hold it. So that would be my only comment. I personally also tend to try to use screws in the medial malleolus. Obviously, I presume you've used it wires because it was comminuted and difficult, or it may just be your choice of technique. But that would be my only comments.
Great comment, Andrew. But may I add to something? I agree with most of what Andrew says, but I have a little bit of something to add. So Ihsan, if you allow me, can I make a comment too? Now,
of course, yeah.
Two issues which Andy brought up is 100% we must never forget about it. You see, the fibula has actually shifted away from the distal tibia. Usually, most of the time, there's a rotational element, so the posterior ligaments of the syndesmosis are intact, and they avulse a piece of the posterior malleolus. Here, it seems to be a pronation abduction kind of injury, where it's been. That's why there's so much comminution. One of the key factors in a comminuted fracture is getting the fibular length right, which we can't. So one tip which we do, one trick is we keep an X-ray of the opposite fibula inside the OR to make sure we've got the length right. And 100% I do agree that we must always look at the front of the syndesmosis to evaluate the reduction. One, it also gives you an idea of whether you're getting the length of the fibula right. Because as Mike Gardner's paper has shown, 50% of good-looking X-rays show a syndesmotic malreduction post-operatively on CT scan. And I would err in putting two screws, not one, because this is an unstable comminuted fibula. I don't even mind putting two syndesmotic screws, maybe higher, lower. I avoid going through the syndesmosis per se, because that's a little bit of cartilage there, which I don't want to damage. I would put it at this height only, maybe two of them, to make the whole complex that much more stable, so that I can allow early ankle motion to get back cartilage nutrition of the ankle. Do you agree with this, Andy?
Yes. Yes, Mandeep, great to hear from you. Yeah, no, all of those things. I mean, and sometimes you may just pull on that fibula and ignore the fracture initially, as you said, to get your length right, and use a K-wire to skewer that into the tibia to try to get that position correctly for the mortise, then reduce the fracture and put your plate on. So as you said, exactly right.
It's Alison Taylor here. Can I ask if any of you would consider flexible fixation or a combination of diastasis screw and flexible fixation here?
I think that's a great question, Alison. I mean, I think the simple answer is yes. I would personally use it. The key is to get that reduced, and it depends on how good your fixation is, whether I would combine it with a screw and a flexible fixation rather than just one or two flexible fixations. Mandeep?
I would be a bit worried, because I think that now if you look at it, if you look at the concept of this, the foot, the medial malleolus and the distal fibula are hanging from that little comminuted segment of the fibula. So I would much rather have the construct of the fibula with the rest of the foot little more stable. So it's my personal opinion, but in so much comminution, I would be a bit apprehensive about a flexible fixation.
Okay, thank you. At the first time that I want to put also the second syndesmotic screw at the distal part of the lateral plate of the fibula, but actually by the time that I want to insert, I realized that actually the side of the location of the screw will exactly at the time of the 1 cm above the ankle joint, and actually it will be getting and also with the great initial place to put the screw should above the 1.5 cm above the ankle joint.
It's a fair argument, Ihsan, no problem. I think you can go ahead.
Okay, can we proceed to the second case? This is the second case with high energy ankle fractures. This is male, 40 years old, the motorbike accident since 6 hours before came to the hospital with the right ankle swelling. Actually, will be no wound, and also there will be no problem with the neurovascular on the distal part. As we can see that this is the initial X-ray, also considering about the fracture from the proximal part of the fibula, and also indicating they have the transverse fracture of the medial malleoli, and also indicating they have also the problem with the posterior malleoli fracture as well, and also including about the syndesmotic injury. Is there any comment about this one?
I think the important thing with this injury is protecting the soft tissues with these and trying to work out what your approaches are going to be based on where the injury is and if there's any associated injuries such as open fractures, trauma blisters, because obviously this patient is heading for some kind of posterior approach to the ankle. So I think it's really important to have a very good look at the soft tissues and see what you have basically with access to the ankle. Oppie, what do you reckon? You're a posterior medial approach fan?
Yeah, posterior lateral. Well, look, I totally agree, Amy. I think it's about getting all the information. Funnily enough, the posterior approach is normally the best tolerated in the ankle compared to obviously the anterolateral and the medial part of your incisions where there's not much soft tissue coverage. And so I agree with what you're saying, just to assess that and wait to the appropriate time. And also, important for me, as Mandeep's mentioned previously, if appropriate and it's available, Ihsan, would be a CT scan of this would help me with my operative plan. So I think I would look at making sure the ankle was a little bit better reduced in the emergency department, in a back slab. And if that's not possible, sometimes even doing it with an external fixation to allow the soft tissues to settle. And then a CT scan to help me plan my definitive surgery.
May I?
Yes?
Yeah, no, I just felt the same thing. Probably CT scan is very important to look at the posterior malleolus morphology, because if we have a big chunk and once we fix it, we'll have a syndesmotic stability if we fix the posterior malleolus, because it is most of the time the avulsion fracture, as Dr. Mandeep had already mentioned. It's the posterior inferior tibiofibular ligament which gets avulsed along with the major chunk. So if you get a CT scan, probably look at whether it's a rim kind of fracture or a big posterior chunk, we can go perpendicular and then probably fix it with a screw or a buttress plate to help in stabilizing even the syndesmosis.
I think the whole discussion has brought out most of the things which are important. But the two key points I would like to highlight is what Andrew said, that the reduction while you're waiting for the soft tissues to heal has to be good. And there should be no compromise in leaving the talus subluxated, whether it is for 2 days or 7 days, how long it takes. Once you've got the talus reduced, you can wait as long as you want. The second point is that we must in my opinion, not operate on any intra-articular fracture without the guidance from what the CT scan shows. It's not only a chunk. I think Dr. Saraswati said a great point that there's a chunk. There is also a degree of articular impaction which we must understand, whether that it is there or not, because recently now so many studies are coming out with a very high incidence of osteoarthritis after these ankle fractures. And one of the reasons is we are missing out small cartilage impactions, or we are not taking into account the degree of cartilage damage at the time of injury. And that cartilage tends to, denude or erode over time, nor are we mobilizing these so that the cartilage doesn't get the nutrition. So 2 points, do a CT all the time, reduce the talus all the time.
Yes, thank you, Mandip. Actually, we had already had the CT scan, but I forgot to put on the slide. And actually, after the CT scan, we can get the result that the posterior malleoli just only one big slide fragment without any comminuted on that side. So that's why we proceed into the next slide. This is because after we evaluating the soft tissue at that site, because actually there will be no sign of the high swelling, and also including about the chance of getting from the compartment syndrome. So we try to open up and try to reducing performing the trimalleolar orifice and also the syndesmotic repair. As we can see that we can start from the fibular side, and also we can see the fracture side, and we put the firstly we do the spanning for the fibula, and then after that we can try also make the second window from the posterior light, getting insight into the posterior malleolar fragment, and we try to reducing and also fix with the candidated a 3-candidated screw, and then we can try to and we can proceed into the medial side and try to make also the candidated screw for fixing the broken on the medial part. And this is the result after the operation. As we can see, maybe I think the length of the syndesmotic screw is not appearing into the next cortex, even we're using 2, because actually by the time that we purchasing the screw, is also hit from the posterior and also including from the medial malleoli screw. So that's why we did it. This is the longest screw we can set to keep the syndesmotic back on the track. Is there any comment from the X-ray?
Isan, I think you've done a good job at getting it reduced.
Yeah.
What I tend to do is very similar. I mean, Amy's talking about, I went through a phase of plating the posterior malleolus in more larger fragments, and I still will occasionally, but I did find that they got quite stiff after that surgery. So it's all based, for me, the posterior malleolus. I think your fibula and the medial mal is pretty, when I say straightforward, I think you've done an excellent job, and that's easy. It's the posterior malleolus which is a point of discussion. And I think to me, it's all about the reduction. And if I need to do an actual open reduction, I actually go in and, like similar to you, but go in posterior lateral. I actually do more of a more posterior incision, and then I do a separate anterolateral incision for the fibula. But more and more, I've been doing a similar screw technique to you, but I actually have been using a cannulated screw and passing a K-wire from the front, from the anterior, a part of the ankle, and then shooting it down to the posterior where I want it to go, to the posterolateral part. And then I then push it out the back of the, just lateral to the edge of the Achilles. And then I percutaneously put a screw in, then posteriorly back up anteriorly along that K-wire. And I found that technique to work quite well to fix them. Again, it's about the reduction though. You've got to be confident that the reduction is adequate. And if it's not adequate, then you would have to open it similarly to what you have done to get the reduction correct, and then fix it with the screws in that technique.
Alison, we had a presentation last year at the Australian Orthopaedic Foot and Ankle Society meeting for, he was a registrar who described a safe approach for percutaneous screw fixation to the posterior malleolus. Did you ever try that technique? I've tried it a few times and it works well for these undisplaced fractures, and I haven't had a sore nerve injury yet, cross fingers. What's your comment on percutaneous fixation for posterior mal fractures?
Well, based on my experience, actually, all the intraarticular fractures on the ankle should be displaced. So I regardly always trying to open up and see clearly about the fracture site, whether instead of using the percutaneous technique as well.
Can I add my 2 bits worth here? I don't know whether it's worth 2 bits in the first place, but I think I like the comment Andrew made about making it too stiff in the back with a buttress plate. But I decide whether I need to buttress it or not on 2 issues. One is how much is the initial posterior lateral displacement of the talus. If it's gone too much, that makes the whole complex very unstable. If there is associated fibular comminution, then we tend to add a buttress plate because it reinforces the ankle complex and allows us ease and comfort in early mobilization. Secondly, I don't 100% agree that if we can do a minimally invasive surgery, we should. But MIS is advocated for those guys who are comfortable with the anatomy and the approaches and the reduction techniques after doing many open reductions. A first timer doing an MIS is going to cause some degree of damage. So that's my 2 bits worth, if it's worth anything.
No, I think it's very important because doing open procedures is the first thing that we learn the anatomy, we know the structures, and minimally invasive always follows that. I completely agree with you. I just have one small question to Dr. Andrew, because you said from anterior to posterior, you prefer to put the screw. But when you have already opened it from posterior, like the posterolateral approach, why not put a screw from posterior to anterior? Is there a difference? I mean, do you feel the stiffness is more because you're going from posterior to anterior, you feel more compression is achieved, or what is the reason?
I may have not been too clear. I actually put the screw from posterior to anterior.
Okay.
But I put the wire from anterior to posterior, and it's the reason I do that is because it's when I'm not doing an open reduction of the back. So it's a percutaneous procedure, like Mandeep said. Confident that I know it's well reduced. So if you are doing an open reduction, you're absolutely correct. You might as well put the screw in from the back while you're there. That's exactly right.
Okay. Right. Yes.
Can I ask the panelists a question and our speaker? Given that long-term, the 2 major issues will be either arthritis or, in the medium term, issues regarding the syndesmosis, if you had this fracture and there may be a difference in the quality of the syndesmosis, whether there is a posterior malleolar fracture or not, given that it may hold components of the posterior tibiofibular ligament. Do you take any different approach if there is a posterior malleolar fracture or not with this particular injury? Does that change your, do you leave screws in longer? Do you put different type of fixation? Is that something that bothers you?
Actually, for treating the syndesmotic, it doesn't depend on the posterior malleolar line. So even they had or not have the posterior malleolar fracture, I will also performing the same principle by using 2 screw for the, if you only have the 3 cortices, or maybe we can use the one type rope for the fracture dislocation of the ankle. Is there any comment, Andrew? Yes.
I hear what Mark's saying. I suppose firstly, Mark, not specifically so much about this case, but if I see a posterior malleolus fracture, to me, automatically bang, that's a syndesmotic injury, and I'm treating a syndesmotic injury, and then I apply my syndesmotic principles. So if fibula is length stable, then I'll reduce it and fix it with a flexible fixation. If it's not length stable or there's comminution, I might augment that with 1 screw, or even just fix it with screws and then leave them in for 3 months, which is my standard for a syndesmotic injury. So posterior malleolus is treated as a syndesmotic injury in my book.
Yeah, I guess that was the point I was trying to make for the audience, I guess, that you need to leave the screws in for a long time with this injury, as that the syndesmosis will take a long time to scar up and heal.
We've just got a couple of minutes left. Isan, have you got another case?
Again, 2 cases, but we can proceed to the next the case number 3. This is the high energy ankle fracture, case number 3. The female, 60 years old, with a motorcycle accidents. left on the ankle wound, and also we can see that there are moderate contamination, but there will be no problem with the neurovascular problem on the distal part. And this is the clinical picture, and we can see also from the X-ray. This is the including also the fractures on the proximal part of fibula, and also medial malleoli, and also the fracture dislocation of the talar, tibiotalar joint. Is there any comment on this case?
Iksan, in the interest of time, you may just click through this particular case so we can see the outcome, and then we should be
of course.
Panelists.
See, thank you, Marinis. So this is the first stage. We do the Binamang and ORF. We can see we try to extend the wound so we can easily put back the bone fragment from the tibia back on below the skin. And also we try to reducing the fibular spanning by using the Q wiring, and also try to treating the intraarticular fracture from the medial malleoli by using the Q wire. And after stabilizing and do the Binamang, we can start to proceed to make the external fixation by this triangular frame from the AO trauma concept. And after we reduce it and try to move to the second stage, that 2 months after the injury, we can see that we try to make the conversion from ORF into the ORF. And we try to put the plate on the fibula, and also try to reducing by using the cannulated screw from the posterior malleoli, and also inserting the cannulated screw for the medial malleoli. And this is the last result from the X-ray. But I'm sorry, because actually the X-ray is quite overlapping with the backslap as well. Is there any comment on that side, on this case?
So Iksan, we may want to move on to the next presenter. I think you showed some great cases, and Amy, I'll hand it over to you.
Permit to stop sharing. Okay.
Saraswati, you're on mute.
Unmuted. Yes. So just wanted to say that wanted to know about the soft tissue of the last case, but otherwise it was well reduced. The next topic is on talus fractures, and we have Dr. Chong from Singapore who will talk to us on talus fractures.
Thank you. Good afternoon from here from Singapore. I don't know what the time is everywhere. It's good to see some of my old friends around, and thank you to the organizing committee for giving me an opportunity to present some cases on talar fractures. Okay, so I have 3 cases today, and I think each of them is meant to illustrate some points, and for the panel and the panelists and the moderators, please feel free to stop me and ask questions and clarify any doubts, or if you have a point to raise, do feel free to just interrupt me. Okay, so some objectives. I think each of the case is meant to illustrate a certain point, how to avoid malreduction, how to approach different talar fractures, and how to approach a mangled open talar fracture. So let's have a look at the first case. This is a 25-year-old male who was playing basketball overseas. It's a low energy injury, very interesting. And he just twisted his ankle and was in severe pain and couldn't weight bear, and was sent to hospital, and an X-ray showed a talar neck fracture. And he then decided to take a flight to Singapore without having anything done except for a back slap that was applied. And from the time of injury to seeing me was about 15 hours. The swelling was not too bad. He had a good sense to ice his foot, but there was some pressure erythema on the lateral aspect of the foot. And this is the injury films. So he came like this, and the lateral side was the site where there was quite a bit of pressure and erythema appearing. So some issues to consider. Should we delay the surgery to do a CT scan or do a prompt, bring him to theater promptly? What kind of surgery, if we do bring him to the operating room? Is it a stage procedure, which means just reduce the major fragments and look at the soft tissue condition? Or should it be a definitive procedure? Approach to reduction, and of course, what implants that can be used. So in view of the soft tissue problem, I skipped the CT and I brought him to the operating room because it was a displaced fracture, and I felt that the CT scan would not have been fantastic in the background of a displaced fracture. In any case, it would be good if the CT was done with some degree of reduction. So my options when I brought him to the operating room was to reduce the major fragments and temporarily pin the fractures and wait and come back another day, or to do a definitive fixation if the soft tissue allows. So I have two options, and I was prepared with my implants to do a definitive fixation. So I chose to have an anterior medial and an anterior lateral approach. And you can see that intraoperatively, this is the medial window. This is the distal ankle, and the toes are on your left. So this is the medial side. And I can see a lot of medial comminution of the neck and part of the anterior part of the body. So do you expect any problems in fixation? Would anyone like to comment in the case where the neck is comminuted?
I think these are really challenging cases, and the issue with medial comminution is obviously the talus can just collapse down into varus, and you try and stabilize the fracture and you just end up crunching it down even more. Alison, what's your preference for these? How do you plate them but get stability of the fracture at the same time?
Sorry, well, obviously the plate's got to go on the medial side, I think, in this case. What I try and do is I usually go from the back to the front if I can. So I do this through a dual incision. And so stabilize, reduce it through the incision you've got there, put your KYs in from the back through the posterolateral incision, and then come down and put the plate on once you've stabilized the fracture.
Yeah. And Oppie, what do you do to stop it crunching down?
So I'd have my dual incisions for this. Ken, nice to see you. Thanks for a good case. Yeah, I'd have my dual incisions, and for this, and as Alison and you're saying, you know, I'd be thinking about plating medially where the comminution often is, because you try to go to your side that's not as comminuted to get your cortical read, get that reduced and fix it with a wire. And then often I'll actually do acute bone grafting into that medial sort of comminuted defect, try to give it some structure to you know, have it held out of varus. And then I put a little plate, and you never feel really comfortable putting a plate in medially, and you're always worried that it's going to cause impingement. But I've been surprised about how well patients have tolerated that. I've thought I'm going to take it out really early, like 3 months or something. But they've tolerated them quite well. I don't know what the other panelists' experience with them are, the plating on the medial side is.
Yeah, I agree that
the original. Oh, sorry, go on.
That's okay. It's okay. No problem. I was just going to say that I agree that they tolerate the plate well.
Yeah, they tolerate the plate well. When I first started doing these, the plates weren't nearly as anatomical, and they didn't tolerate them well. But with the newer plates, I don't seem to have any problem.
I have a small comment. How many of you have experienced undersurface comminution of the talus? We all talk about the medial surface comminution of the talus, but when the subtalar joint is so significantly reduced, especially when the fracture is sort of extending partly into the body also, I've seen a lot of undersurface comminution of the talus which has been identified on CT scans. Any comments on that?
I have a case coming up with that, Mandeep. So maybe we can leave that. Yeah, maybe we can leave that for later. Okay, should I go on? Okay, so clearly everybody brought up the very relevant points about medial comminution and the need for avoiding compression on the medial side. So a little tip that was brought up already. One of the important point is actually two windows. It is actually very, very important for talar fractures to be fixed with two windows, because on the lateral side, there is good bone, there is not, well, there is one side that is not comminuted. It could be the lateral side, it could be the medial side. It could be used as a guide to look at the degree of reduction and how well reduced you are. Do not compress. The intraoperative fluoroscopy should include fluoroscopy of the foot. I will talk about it a bit later, but what I actually did was after reducing the lateral side, you can see this huge degree of bone loss on the medial side, and I did exactly what Andrew said. I bone grafted it with an allograft, but I use a K-wire just to hold it in place. This is the loose K-wire technique. I was not planning on removing the K-wire at all, so it's just completely buried into the bone. So,
can I just ask, where did you get your bone graft? Where did you get your bone graft from?
It's allograft. Allograft. So it's a block allograft because I wanted to have some structural stability and not just not cancellous bone. So don't compress if there's bone loss. In the ideal situation, a plate will be good for bridging that defect. Otherwise, screws will be fine too, but make sure the screws are not compression screws. So this is a very important picture that I always use, and it's an old picture from the injury supplement from 2004, illustrating the importance of having two windows in the fixation of talar neck fractures. And I still see a lot of talar fractures being fixed with one window. Sometimes they are fixed properly. The surgeon is lucky. Most of the time, if you encounter malunited or poorly fixed talar fractures, and you look at the foot, and invariably it's a single incision. So the reason why you have two incisions is that it is because the talar is a very, very odd-shaped bone. And even though you may see very nice reduction on one side, it may be completely distracted or compressed on the opposite side, or there may even be a rotational malalignment. So this is very important. If you think that the opposite window does not need to be such a big window, you can make a smaller window, but I think it's still important to have a look at the opposite side of the bone of the fracture. So intraoperatively, fluoroscopy checks are very important. A lot of talar fractures are performed with the intraoperative images only involving the ankle, AP lateral. I think we should not forget to do fluoroscopic views of the foot, because the talars, if you just do an AP lateral fluoroscopic views of a talar fracture, then you lose a lot of information. And once you do an AP and oblique of the foot, you can see the bone defect. You can see the relative length of the medial and lateral borders of the talars. You can see whether your talar neck is fixed in varus or in valgus. So these are extremely important points to bear in mind. So this is the final result of this patient at 3 years. He's doing well. There's some talonavicular arthritis, as you can see, but he absolutely does not wish to have his implants removed. I even suggested having the impinging dorsal osteophytes removed, which might improve his talonavicular ankle movement, but he said that it's fine. So any comments before I move on to the next case? This is a relatively easier case. Then we get to a little bit more interesting. once. So learning points, 2 windows, bone graft defects, don't compress them. Do intraoperative fluoroscopic views of the foot and not just the ankle. AVN is not dependent on the time to surgery. I think in the old days, a lot of us, when we were in training, we were told that talar neck fractures is an orthopedic emergency. It is no longer an orthopedic emergency. It is an orthopedic urgency, yes, but not an emergency. I think perfect reduction is more important. Get someone who knows how to fix the fractures to fix it. That is actually more important. Case 2, 45.
Can I just
Yes.
say to everyone on that final point, but I think, and you totally agree, I know this because you and I have discussed it many times, it's just the only urgency to the reduction is skin compromise. So to get even a temporary reduction rather than to having skin compromise is the issue. You'd agree?
Yep. That was the reason why I went into the operating room without a CT scan. So, okay.
Kinvai, one
Yes.
small comment from you.
Yes.
How often with these comminuted fractures, when we focus all the time of getting the lateral and the medial lengths of the talus correct, and we've loss of bone on the medial and maybe on the dorsal side, do we leave behind residual rotations? I've seen feet fixed with a little bit of internal rotation, and varus is okay, but that also we understand. But how do you ensure that we don't leave behind any rotation of the head and neck fragment with the neck and body fragment?
Okay. First of all, can you all still hear me? Because I think I'm kind of frozen in time.
We can hear you.
Because my video is off, I think. Okay, I'll just go on then. Okay, so I think the rotational malalignment is one of the very difficult aspects of talus fractures, and the fact that you have 2 windows on both the medial and lateral side does certainly help to reduce that rotational malalignment. Looking into having a window that allows you to look into the subtalar joint to see whether there's any residual subluxation at the end of your fixation is also quite useful to correct the rotational malalignment or reduce the chances of that happening. I hope that answers your question, Mandip. I don't have a fantastic way of solving that problem, the rotational malalignment problem.
Okay, that answers the question. We can go on to the next case.
Okay.
I think
my video is okay.
Yes, it's
sorry.
better.
Yep. Okay, case 2, 45-year-old female who drove a golf buggy off an 8-foot cliff. So there's a split level golf kind of terrain, and she just drove it off. And she was flown in from the resort. And again, there was a big delay from injury to seeing me, more than a day. The left ankle was swollen and bruised. And this was the injury films. And the foot was very swollen. The medial side was very bruised, but the x-rays looked quite innocuous. And when she came, the report that I got was that it was suspected ankle fracture, and then but x-rays did not seem to show anything. So what we can see on the x-rays is that there is a bit of a cortical break or a surface break of the talar body on the medial side. So, and because in view of the medial soft tissue bruising and swelling, I got a CT scan for her, and this is the CT scan. And this would probably be what Mandip was talking about with the subtalar joint comminution. So there is extensive medial talar body comminution, which involves a significant part of the subtalar joint. So any comments? What's the plan? So the fracture is comminuted. Should we talk about the approach, the fixation, and of course, nothing, no talar fracture can avoid the discussion of blood supply. So let's hear from some of the panelists before I go on.
I'd like to comment on this. If you look at the CT scan, the image which you're showing us, you see you've got compression and crushing on the medial side, but you've got a small chip of the fibular edge over there. And if I notice something in the other X-ray, there may have been a small chip of the navicular also. I may be wrong. So this makes the subtalar joint unstable. So these are the cases which we can't identify and label them only as medial process fractures. I would say that there's a bit of a medial subluxation of the subtalar joint also, which we have to take into account when we reduce them.
Okay. So what my own thought process is that because the fracture is comminuted, I probably can't use screw fixation alone. I got to get my plates ready. My approach would be a medium malleolar osteotomy to expose the medial surface of the talar body. And of course, in this kind of cases, generally the blood supply is not as big a problem as the neck fractures because the medial side of the talus actually is well supplied by the posterior tibial artery, and these small fragments are actually all attached to the deep deltoid ligament. Intraoperatively, I can see that they are attached to the deep deltoid ligament, and preoperatively, from experience, I knew that most of them were attached to the deep deltoid ligament. So as long as you don't remove them and make them a loose body, then you are generally one is all right with such cases. So the approach I chose was the medial malleolar osteotomy, preserving the deep deltoid ligament. So this would be a picture from another case. This is the medial malleolar osteotomy. The deep deltoid ligament would be right here, and it's not stripped away from the medial body of the talus, so it's not stripped away from the medial body of the talus. And the plan is to put a plate here, which is deep to the deep deltoid ligament, inferior to the medial malleolus, so you don't get impingement, and hence it is outside the medial gutter, but yet not stripping away so much of the deep deltoid attachment to compromise the blood supply and create pieces of bone fragments which are completely loose. So this was exactly what I did. The reduction was surprisingly easy because all the pieces were actually connected to soft tissue. So as long as one does not strip away the soft tissue, it all comes together when you put a buttress plate onto the medial side of the talus. So this was exactly what I did. I put a buttress plate there and noticed that there are no intervening screws because it is quite pointless to put screws in this area because they are all small pieces of fragments. Again, intraoperatively, ankle AP, lateral mortise view, foot views are important to look at the talar neck and to see that it is well aligned. The medial and lateral length of the talus are balanced. I like the oblique view of the foot because I can see this curve. This curve makes me very happy whenever I fix a talar neck. Of course, in this case, it's not as important. In the body fracture, it's not as important. So final results after 1 year. This is the X-ray. It has all healed. I'm afraid I don't have the ankle X-ray. I would love to have the ankle X-ray, but she doesn't really come back to Singapore, and this was all I got from her. But she is walking around. This is now 3 to 4 years after the fracture, and she has gone back to work and all her activities. And for a while, she was complaining about stiffness of the ankle, and we were thinking about whether there was a medial impingement of the plate. And as we discussed this earlier, subsequently it just went away. So, and she didn't want the plate removed. And this plate would have been horrible to remove because I would have to do a medial malleolar osteotomy again to remove the plate, and I certainly didn't want to do it. So some learning points: do not miss such fractures because very often in the emergency room will just x-ray the ankle and tell you that it's completely normal. Blood supply is usually not a problem. Know the proper approach to talar body fractures and know how to use talar plates. So to backtrack a little bit and discuss Mandip's point that he raised about subtalar comminution. I think subtalar comminution, it's a very difficult problem. To me, it is really not possible to get a very good direct visual reduction and fixation because it's really difficult to look upwards towards the subtalar joint. It's not a very big space. But my experience with a lot of fractures involving subtalar comminution is that a lot of them, once you buttress the cortical, or rather the surface, the osteochondral surface, once you buttress and reduce the osteochondral surface, a lot of these pieces tend to come together. They may have some cartilage loss or some irregularities in the subtalar joint, but I don't think there's a good way to reduce them. And to me, if I can get the talus to heal with a good shape, then a subtalar joint arthritis in future is not a big problem for me to solve. So that is my thinking. Maybe Mandip, you have some advice for us?
No advice. I'm just trying to tell you that in my learning curve over the last 15, 20 years, these kind of fractures are okay because you don't really have the whole foot moving. But in a fractured neck body, you sometimes don't have those fractures which are purely neck or purely body. You have neck fracture with little element of crushing of the body, especially on the undersurface. And you think you've done a good job on the neck, but some of these fragments stay missed. And I've seen some cases referred to me with a significant hindfoot varus, and then you have to sort of look at fusing the subtalar joint. But that's just something which we are understanding, that we are finding that in high velocity traumas, there is almost always a degree of subtalar comminution in about 20% of the cases which we have to look for.
I think it's a great point, Mandeep, and really important that we make sure we manage our patients' expectations early regarding that, because I look at this case that Kinway's done a fantastic job at reducing, and straight away I'm thinking about trying to preserve the ankle joint and do the best I can for the ankle joint, knowing that yes, I hope the subtalar joint will still be good and go okay, but there's a high chance, as he said, that you'll end up with post-traumatic arthritis and potentially a fusion of that when you've had these very nasty injuries with comminution into the subtalar joint.
Probably got about 5 minutes to go.
Okay,
Have you got
one last case, yes. Case 3, 42-year-old pillion rider, motorcycle, road traffic accident, severe soft tissue injury with open talus and calcaneal fractures, no other injuries, underwent debridement, external fixation, and offered amputation, but the patient declined. Plantar sensation was intact, and then she came over to me for further management. So these are the injury films. It's just bad hindfoot. The whole talus and calcaneum is smashed, and you can't make out too much from this anyway. So let's go on. CT scan was done at back in the first hospital, and it's just a mess. So it wasn't very useful to me, except to know that it is a terrible job that I have to do. This was the X-rays done at her home country. There was some attempt at reduction, and they put an external fixator, which was actually the correct thing to do. And when I received her, this was the X-ray I got, and this is the soft tissue condition. So the foot was viable, the plantar sensation was intact. However, there's a huge open wound on the dorsum. The lateral skin over the calcaneum was not too bad, but as you can see, there is a little bit of degloving onto the lateral aspect. The medial side was the open injury, and this is all part of the calcaneum bone chips that are just all coming out from the medial wound. So what I did was, so what's the plan? So in view of the time, I'll just go on. I did a debridement, reduction of the main important fragments, temporary pinning using K-wires, and a bridging external fixator. So all I did was just clean up the soft tissue and reduce the important fragments. So the talus was fractured. There was a talar neck fracture. This was reduced. This was pinned. The calcaneal cuboid joint was smashed. So this is actually part of the calcaneocuboid joint. So I pushed it back up to as good a position as I could to get the length of the lateral column out to the correct length. But then I realized that there was a huge defect and there wasn't much bone left after debridement. As you can see, the small chips was just coming out of the foot. So I put a big, huge cement block between the articular surface of the calcaneocuboid joint and the rest of the calcaneum to maintain the length of the calcaneum. And then again, pin the whole hind foot with K-wires and put a bridging external fixator. So this is the final result after the initial operation by myself. And as you can see, the soft tissue did not look too bad. Fortunately, she had no major infection after the surgery. So she went for a few more second look wound debridement. And once I was confident that the soft tissue was all right, the plan was to do a flap, to get my plastic surgery colleague to do a flap. So with the understanding that the flap is going to cover up some access to the joint, I decided to change some of the K-wires to definitive fixation, to screw fixation, especially for the tailor neck, because I didn't want to go through the flap again to try to fix it later. But the heel was the bad part. The calcaneum was the bad part, so I left that alone. So the X6 was removed after about 6 weeks, and this was the X-rays at about 10 weeks. And it showed relatively good shape of the foot. This piece, which is the joint piece of the calcaneocuboid joint from the calcaneum, has dropped inferiorly. But at the moment, she was able to do this at about 6 months, and she was able to walk with a cane. So I was not eager to do anything at that point in time. I fully expect that her lateral column will shorten as she continues to weight bear. And at some point in time, I will have to come in onto the lateral side of the foot and do a calcaneocuboid joint fusion with bone graft. So, but that is something that is left for a later time. So this is the final result. Okay.
Well done.
Learning points.
Great
Soft
case.
tissue. Okay.
Yeah.
Soft tissue comes first. Temporary K-wire, X-fix, and weight. Reduce the main fragment, get the foot shape, eliminate bone defects. Early flap coverage and partial conversion. Delayed reconstruction can be done later. Thank you very much.
Yeah. Yeah, fantastic. That was a great case.
I just have a point to add, if I may. The fact that you offered her amputation first and then you ended up doing all these procedures.
No, I didn't offer the amputation. The primary hospital, the first hospital that received her, offered the amputation. I probably would not have offered an amputation at the first stage, but it is perfectly reasonable for the first group of doctors to offer her an amputation, because you know, she was probably back up and about much faster than doing all this.
Yeah. Dr. Kim, just one more question. Is there a role for tibiotalo-calcaneal nail in highly amputated or fractures which are highly comminuted, both calcaneum and the talus and the distal part of the tibia?
For a primary fusion, you are saying?
Yes.
I think that for a fusion in the first place is very difficult. So I think it is much easier to get the shape of the foot out to the correct shape and then wait to see what happens in future, because sometimes you may have radiological features of arthritis, but they are not symptomatic, and therefore you don't have to fuse that joint and you end up with a much less difficult operation. I think in a comminuted, dirty scenario, doing a primary fusion is very, very difficult, and I think it's very high risk.
I think it's a really good option. I think your calc fixation for a hindfoot nail will be really difficult in a calcaneum that's that smashed as well. Like it'd be really hard to find some bone for those screws. But yeah, certainly as a delayed procedure, a hindfoot nail is a really good option. So I'd like to introduce Professor Dylan. He's going to talk on calcaneal fractures.
Thank you so much. I've had some great cases, and I'm going to start sharing my screen if it's possible. Can you guys see my screen?
Yes.
Okay. So, oh, where did it go? Here we go. So I'm going to start, and I'm going to be talking about fractures of the calcaneus, and I'm going to make frequent references to the manual of fracture management, AO manual, which I've been part of it. So, we all know that calcaneal fractures are of many types, and I'm going to go away from the standard displaced intra-articular fracture and talk about 4 or 5 cases which are not so conventional. Now, let's start with peripheral fractures. We all know they are different from the displaced intra-articular fractures. They could involve the tuberosity, the sustentaculum, the anterior end of the calcaneus, and sometimes even the medial inferior tuberosity. So I'm going to start with a simple case, an 18-year-old male who had twisting trauma to the foot, and he was tender medially and laterally and unable to bear weight. And these are his emergency room radiographs. He couldn't walk. So I'd like any comments that, can you see something on these poor quality x-rays? Would you like to order any additional investigations? Or should I just go ahead and show you what we've got? Any comments?
So the anterior part, the calcaneocuboid, is not very clearly visible. I'm not sure about the...
Yeah, that's what I'm saying. So this kind of an X-ray usually is accepted by an ER resident or ER doctor, and they're sent home in a slab. But you must be careful about palpating each part and seeing what is happening. So I won't sort of keep it prolonged. I'll just show you the CT scan. Now this CT scan shows us very clearly that there is a displaced fracture of the sustentaculum. You see, you can see the degree of displacement and some degree of element, and look at the significant displacement over here, plus a fracture on the lateral side of the lateral process of the talus. Now this makes for an unstable and significantly damaged subtalar joint. So this is what we saw, and which was considered to be not so bad X-ray, has a significantly disrupted subtalar joint, but the fracture of the calcaneus is a displaced comminuted calcaneus fracture. Now I'd like some quick comments. What next do you think we should do for this case? Anybody going to take me up on this? Are we guys there?
Mandeep, you always have the interesting cases, don't you? So Mandeep, this is I've done a few of these, and I find them very tricky, and I really need to go through those CT scans and in detail to plan exactly how to fix it. But I find that this has obviously been involved with a subtalar joint dislocation, and it seems to be quite a significant sort of fracture of the talus associated with the sustentaculum. So as well. And so anyway, normally with the sustentaculum fragment, when they're this size, and I would go in and do a very careful medial approach, being wary of where the neurovascular bundle lies, and internally reduce it and internally fix it with either screws or even sometimes a little well-molded sort of T 2.0 foot plate as well, to give it that sort of buttress and anti-glide effect down the medial wall. So, but very, very difficult fractures to fix.
Yeah, I agree. Any comments from anybody else?
I think the lateral process of talus fracture is going to be a bit of an issue as well if it doesn't unite. So I'd look at doing both a medial and a lateral approach and fix that lateral process of talus too.
I think both of you have hit the nail on the head, and that's exactly what we've written in this chapter in the book also. So we did it through a medial approach to the calcaneus and a small sinus tarsi approach to the talus, and we fixed them with screws on both sides. And this is a fairly good outcome of a significantly complex fracture. So the issue over here is that we have to do both of them. Otherwise, the subtalar joint stays comminuted and stays unstable also. And this is a 6-month follow-up, and this is a follow-up of at 1 year with the patient doing fairly well. And you see the whole subtalar joint has got its anatomy restored, and this young adult is now back to his old job. So the message here is a sustentaculum, despite being a small part of the calcaneus, is an important weight-bearing part, especially for the anterior, for the middle facet. And a depression or displacement can alter the subtalar joint mechanics. And you'll find a large percentage of them will lead to late osteoarthritis. And if you've got comminution, you should plate them also. That's what Andrew said, and that's what's written in this approach. So that's a very clear message that you need to fix them if they are displaced. And any comments on that before I go on to a similar case? Now, any comments on that, what we did, anything you could have done differently?
So not a comment, but just would like to know intraoperatively, what are the images that you would like to see? Is it possible to look at the reduction, especially the sustentaculum? What is the image?
We are fairly lucky because you've got some high-end C-arms, which will give you almost like a CT-based thing. But we often tend to see them physically right there in front of you. And we do a lot of axial views. Plus, we can do a 3D reconstruction for the sustentaculum. For the talus, it's not so much of a problem.
Correct.
Hello? Can you guys hear me?
Yeah, keep going, Mandeep. It's
Okay, sorry about that. Now, just as an example, I've got another case which happened in the lockdown. You can see this happened in August. He was an employee in our own institute, and he twisted and fell down the stairs. Now you can see a very obvious fracture of the sustentaculum here. You can see this. And what should we do in this case? There is nothing in the talus. This is the only injury. He's a 29-year-old clerical worker. Comments, guys? That's the fracture. That's the fracture. That's the fracture.
I have a feeling you're hiding something, Mandeep.
No.
I would treat
very
this
honest,
patient in
cross my
plaster.
heart, hope to die kind of stuff. That's it.
Okay, well, plaster or fiberglass cast for me for that one.
That's exactly why I brought it up. Because on the contrary, there are these undisplaced sustentaculum fractures which we should not try and operate on. Because one is you could move them. Secondly, you could damage the structures on the medial side. So he was treated very well and he healed at 2 months. And that's his outcome. In November this year, he's gone back to work. So exactly what I'm saying, all sustentaculum fractures do not need to be operated. They only need to be operated if they are displaced, if they have an associated injury, and if there is comminution. So that's, Andrew hit the nail right on the head. So that's what I was talking about for sustentaculum fractures. Any comments before I go on to something else? No comments? Okay, this is the message which I have. Okay, guys, I'm going to be talking now next about fractures of the anterior end of the calcaneus. Now, many of the normal orthopedic surgeons, the foot and ankle surgeons know everything about it, but the average orthopedic surgeons tend to think this is a small issue. You know, although it involves the calcaneocuboid joint, these fractures most often do not involve the subtalar joint, which is a big problem when we have these displaced intra-articular fractures. Now I'm going to show you an example of a 35-year-old teacher who got a grade 2 open injury, fell from a motor scooter, and got a complex crushing of the anterior end of the calcaneus, along with the subluxation of the talonavicular joint and a dislocation of the subtalar joint. So that's what she comes up with. There's a wound right over the calcaneocuboid joint also. So I like your options. What should we be doing now? Any takers? Hello there. Can you hear me?
Sorry, stuck on mute. Is Mark Blackney still around? Have you got a comment?
Yes, I'm here. I'm just having a look. It's this is a very complex case, and I think you need to get some length going and reduce the dislocations. So I think if you've got an open wound, you probably want to put a fixation device on initially, and then see what you have left. But Mandeep, I think you've done many of these, so I will let you.
Okay.
I will let pass on to your expertise.
Mandeep, where is the open wound, Mandeep?
Right near the calcaneocuboid joint. You know, we've done a few of these opens. We've even published about this. The wound invariably comes out on this area. So if you want, I can show you what this is. The wound is interface, and this was one of my earlier cases. And I would show you how we've evolved in doing these cases over time. Now, if you want me to talk about the principles of treatment, you have to understand this. This is not only a calcaneus fracture, it's a joint dislocation. You have to be careful about the wound. And as Mark very rightly said, here the key point is getting the lateral column length out. And we have some experience with these kind of cases. So what we did here was we debrided it, and we first reduced the subtalar joint, held it in place, then lengthened the lateral column with an external fixator and put in a tricortical iliac crest graft. And you know, at that, this is done in about 2010 or 11, I don't know when. And we were not very comfortable with having, we didn't have so many plates in India at that time. So we put in a crossed K-wire for this lady. And that's what it is. The principle being that we treat it as some kind of a midfoot dislocation with a subtalar element, where you reduce the joints and get the lateral column length right. So here we've used an external fixator. Actually, we used it for about 2 months instead of a plate. We use an X-fix with wires, and that's her end result. You can see that the wound is healed. Her foot length is fine. And this is where the graft has incorporated, although we have a calcaneocuboid joint, but I don't think it's that badly disfigured. She's gone back to a job as a teacher. And I like some comments about this, how you guys would do it differently today.
Mandeep, I think you've got a great job with that. Would you ever think about a primary calcaneocuboid joint fusion for that kind of injury?
That's a pet peeve with me. I am not a great one for primary fusions, either of the subtalar joints, even at the Lisfranc's, although I'm changing now. But I have a feeling that whenever I'm trying to fuse fragmented bone with a good bone, after taking out the cartilage, I may not do a good job. I'm happier maybe going in later, because, you know, in our scenario, many of these people accept a lot of things. And they don't come back for, you know, a secondary fusion as they would perhaps in the Western population, where they don't accept even a minor disability. So I am not a great fan of primary fusion, although I do agree with you, it'll save so much effort and time, but it would involve much more graft. And in the presence of an open wound, I'm not so sure of using internal fixation.
So what would you do differently in this day and age, Mandeep?
Yeah, I think that's a great question, Mark, because I think Mandeep's sort of implying you could potentially use a plate as more of a spanning internal X-fix. But I mean, I personally wouldn't. I'd still stick to what you've done, Mandeep, because of the open wound, particularly the risk of infection.
Yeah.
You've held it out at length beautifully. I think it's a great result, and that's what I'd still do today.
I agree. I think with so much comminution, it's very hard to put plates and screws in those situations.
Well, the last case I'll be showing you today is perhaps the worst one, but we'll come to that. So this is another case which was part of our study. And the message which we have when you have crushed fractures of the interior end of calcaneum is that the mechanism of trauma is different from displaced intra-articular fractures. What we have is a crushing and shortening of the lateral column. Sometimes you could have a cuboid injury, you may not have it. So you need to plan it well. You have to understand the mechanics, and you have to make sure that the column length is restored. I think that's, in a simplified way, that is the message over here. You shouldn't think of them as a standard calcaneus fracture. So I'm going to come to the back of the heel. So everybody talks about an avulsed calcaneal tuberosity. This is a 32-year-old male presented with an avulsed tuberosity fracture. And I know everybody knows the answer. So I'm going to ask you what would be your thought process? What would be the steps in management of this particular case? It's a closed injury, minor, small, little thing like pinprick kind of a wound at the back.
Yeah, it's closed at the moment, but it may not be for long. So yeah, I think this is the classic emergency operation for us for calcaneal fractures, Mandeep, and I'd go in urgently and reduce it. And normally, honestly, it ends up being an open reduction, particularly with this amount of displacement. Sometimes when they're less displaced and they're well experienced, you can do more percutaneous reduction techniques. And then the next question then is the fixation technique. And although it looks like it's screaming out just to put some interfragmentary screws, they may be cannulated or not. I find that they've often, that the force of the Achilles is so big that it can just pull that up. And I know the guys out of Bristol, Roger Atkins and the team have described using a tension band wire technique around the lateral wall with some K-wires instead of the screws, and that works quite well. Or sometimes screws are appropriate in good bone. But that's how I would be approaching a really complex and really emergent injury.
I do agree with you, Andrew. And this is exactly what was done by a young senior resident in our department. And they treated it in the emergency. They did a limited incision percutaneous fixation, and they sat around having drinks because of the first case which it fixed and had a great outcome. But unfortunately, this is what happens within 4 weeks. Any comments? Andrew's given us some preliminary work about it. Why is it that the screws don't work?
I think these fractures often happen in bad bone. So these fractures tend to happen in diabetics, in people with tight Achilles, who often have underlying metabolic bone disease, such as severe osteoporosis. And sometimes that kind of fixation just isn't enough to hold it. Saraswati, do you have much in the way of diabetic foot in your institution and these kind of fractures?
Yeah, I mean, these are usually open fractures that come to us, and most of the times we initially just put an X-fix to look at how the wound is, wait for about a couple of weeks, and then plan an internal fixation. Here, I think the force of tendo Achilles is the one which is probably pulling it out and, making it open in 4 weeks' time.
And Alison, you've got a pretty busy diabetic foot clinic. How do you manage these kind of complications?
Well, I have to say that I have had this type of injury and this type of result before. They're very disappointing when you get such a good result, a good reduction initially. Look, screw fixation is fine, but I often supplement it with a plate as well, a buttress plate. And the other thing in diabetics you might consider is a tendo Achilles lengthening at the same time.
Yeah, very good point. Yeah, I think, Kinwa, you wanted to say something?
No, I fully agree that I've had exactly this kind of results as well. So these are terrible fractures to fix. Yeah.
So anyway, so I'll go ahead, and you see the problem with these avulsed fractures is, for those who are not specialized foot and ankle surgeons, the skin is always threatened. So you have to do something in the emergency. Screw alone has high failure rates because they don't grip enough. Some people say cross the opposite cortex, but still the TA pulls. And often there is significant associated osteopenia like in diabetics. So these guys go away. So in the book, it's been mentioned, like most of you say, that you should perhaps supplement them with some kind of a plate which is bent and can be done with a minimally invasive method. And since we talked about open fractures, I'm going to show you an open fracture which came to us. And she came to us, she's a young lady. She again came to us just this year. And I was trying to get her to come back for a follow-up, but I just want to show you, when you have an open fracture, you can't use implants like plates, etc. So the tricks which we do is you debride them, you put multiple K wires, and then we put lateral screws in the lateral side and hold this with a tension band construct while they heal. And we also tend to let them be in a bit of a quietness. So this patient, you'll have to believe me, he healed well, but we were extra careful. And notice we have offloaded her with an external fixator. You see this external fixator over here? We have forced the foot to stay in about 10 degrees, 15 degrees of quietness for about 4 weeks or 6 weeks, and then she healed quite well. Any comments on this? No comments? So I'll go on to the next.
Yeah. Sorry, just quickly, did you leave the Achilles alone?
In this particular case, yes, but we offloaded it with an external fixator. She was 19 years old.
Yeah, okay, yeah.
Okay. Now, the message again is this: you need an urgent reduction. Otherwise, you'll get soft tissue breakdown. Screws don't hold. You have to supplement the fixation. It's a simple message, but it has to go across. Now, let's come to the central fractures. You know, the simplest classification is joint depression and tongue type fractures. But, you know, you would get so many significant variations. Like these bilateral fractures we get, one side open, both sides different fracture patterns. And you can apply any kind of surgical procedure with a good outcome in most times. But I'm going to talk about these fractures being managed by the minimally invasive concept, which in 2020 is now very well established. And most surgeons are going towards the minimally invasive complex. And this could be a sinus tarsi approach. It could be a percutaneous fixation using all kinds of combinations of implants once you get an accurate reduction and stable fixation of the subtalar joint. Now, this is a doctor, a professor of anatomy, who fell down last Monday. And we've operated on this gentleman 2 days ago on Friday morning. So I'm just going to show you this X-ray because what I really want to show you is the last case before I run out of time. And you see his CT scan. You can see the CT scan. You can see there's a large fragment of the posterior facet, but there is a sustentacular fragment which is separate and a lateral wall which is separate. So if you look at the Sanders classification, it will probably become a Sanders 3AC. And you can also see the sagittal view, because here also you can see that the fragment is actually tilted down. It's a tuberosity, it's a tongue type fracture which has tilted downwards. And but the tuberosity, there's no secondary fracture line making it into a depressed facet fracture. So what next? Anybody would like to comment on this? What should we be doing for this patient?
Mandeep, for a surgeon with your experience, you know, and this is, I think this is where a lot of people, we come and talk about minimally invasive surgery, and you've already pointed out with previous parts of this talks today, but you need to experience these fractures in really an open reduction technique to then be able to apply the minimally invasive techniques. But I mean, this one here, and for an experienced surgeon, is crying out for a sort of, you know, percutaneous reduction techniques. Ian Winston, who I know you know very well too, and Amy and I fellowship with him. You know, we've done, you know, arthroscopic assisted perc reduction on this using a joystick shanks pin into that sort of tongue type fragment, getting the subtalar joint reduced, that posterior facet reduced anatomically, and then getting even some percutaneous screws for fixation across the posterior facet, and then longitudinally with long screws as well to help control the varus valgus. And that's how I would consider, you know, fixing a fracture like this.
I think you hit the nail on the head, Andrew. Anybody else wants to have a comment on this? It's not such a complex case. That is the first thing. But you have to have the understanding of the manipulation steps which are needed if you're wanting to open it with a minimally invasive surgery. So I'll just go across. Now, it's a fracture like this. Because the surgical plan depends now that in the 21st century, we understand the fracture patterns and reduction methods better. Now, if you look at this fracture, most of these fractures, which are tongue type, you want to elevate them indirectly. But to elevate them indirectly, you need to create some space like you would for a depressed facet fracture. So the first point which we need to do is we need to pull this down and then manipulate the tuberosity and push it back in and fix it with whatever method we want to fix it. So you can use screws, you can use K-wires, it all depends. It has to be stable. And so we've been doing it, especially in open injuries. We've been doing it for a long period of time, indirect reductions using external fixators, etc. This is a case which I am showing, a different case. This was operated in 2011, but the anatomy of the fracture is fairly similar to what I've shown you today. And these cases can be fixed by multiple K-wires, which was the norm at that time, and we didn't have the experience with screws, etc. But today, we do it slightly differently. This case, we went in, made the surgical plan, and we wanted to do a plating to maintain the Gissane angle. The Bowler angle is not a problem in this scenario, but the Gissane angle is the problem over here. So you open it up with the sinus tarsi approach. You can see that step right there. That's the big step, and that's the displaced fragment over there. And the next step is you put in a shank spin guide wire over there. You get the tuberosity out of varus if it is, not so much. You pull it down and you manipulate it to get your subtalar joint okay and the Gissane angle right. And then we put in 2 K-wires longitudinally to hold this in place. You can use screws in this place, or you can use K-wires. So if expense is a problem, we often use K-wires in India. So then you put in your plate, making sure it's in the right plate, and with the plate in situ, you can see both the Bowler angle and the Gissane angles, as well as the medial wall, are properly restored in this case. So this is the good reduction by an MIS method, and I like to see comments on this. Because even if it's a depressed fragment, you can use a combination of the sinus tarsi approach to elevate that fragment and the spike in the tuberosity to reduce it. So you can use both these methods. This is also an old case which we did, and then you can reduce it, fix it with multiple K-wires, get your screws across it. Now I would put only screws and plates, but this video is an old one. So you can do all of this with a combination of a small sinus tarsi approach and an MIS fixation. Any comments on that?
Yeah, Mandy, we do have to move on, but just really quickly, you mentioned that surgeons should learn.
Last case, I will not ask questions. I will just go along because I think a calcaneus fracture dislocation is a big challenge. These things, they look like simple fractures, but unfortunately they are not. They look like tongue type fractures, but they aren't. Because if you look at the axial views, the whole calcaneus has shifted out, leaving behind a small fragment of the sustentaculum tali. Now, this is also a chapter. The key point is that the dislocated calcaneus is abutting against the fibula laterally. You may not have a depressed facet, but you've got this huge chunk of bone lying out there laterally. Look at this young male. This is the shape of the calcaneus, and it seems as if the Bowler angle is right, but the bone is lying totally underneath the fibula. So what you need to do is you have to plan appropriately. Sorry, I'm going the wrong way. So calcaneus is lying beneath the fibula. The facet is not depressed, but along with the tuberosity, it is dislocated. And here we often modified the approach. The extensile approach won't work. The sinus tarsi approach may be smaller. So we tend to extend the approach a little more. And you can see the top of the facet. That's the whole top of the facet, which is lying here, pushing the peroneal tendons out. And then you have significant difficulty in reduction. First, you pull down the calcaneus, then I have tried to lever in the calcaneus back into it, and then you get a temporary reduction. Now, when you got this temporary reduction and fixed it, you could see the large void at the calcaneocuboid joint. There was some anterior crushing involved over here also. So you go medially now using the sustentacular approach, reduce the sustentaculum talus and try to, like you do the posterior malleolus, you fix the screws trying to hold that big chunk to the sustentaculum, and then you find the lateral column is unstable also. So we've distracted the lateral column, and since this was a closed injury, we've put in a plate to bridge the whole lateral column and maintain the calcaneus in the position. So we have an X fixed temporarily, subtalar joint fixed with wires, the sustentaculum fixed with screws, and a plate as a bridging plate holding the lateral side. And that's what the end result is after about 4 months or something, but the plate we've left in, but you've got a good reconstruction of the whole foot. So any questions on this or any comments on this case?
Mandeep, we may just cut it a little bit short just to
That's my
move
last
on.
case.
But they are terrific cases.
That's my last case. I'm done. I just wanted
Right.
to make people aware of the fact that you could get a fracture dislocation of the calcaneus also, where the foot length needs to be maintained.
Terrific.
I'm
Thank you,
done.
Mandeep. That was
Thank you.
terrific.
Thank you, Dr. Mandeep, for interesting cases, and the dislocation cases, really one of the rare cases that I have also seen. Now we request Dr. Alison Taylor from Australia to just talk to us about complex midfoot injuries.
Hi. So I'll just share my screen. All right, okay, so I'm going to talk to you about hopefully some solutions to restore the poetry of the midfoot. My first case, oh, and there's no declarations. My first case is a 26-year-old female who fell 2 meters onto a hyperplantar-flexed foot. She was wearing something like 10-inch heels at the time. And so when she landed, her heel obviously couldn't go down. So this was her X-ray. So from the panel, what do we see here? Perhaps you'd like, actually I'll give you a bit more information.
I see a reason not to wear stilettos, Alison.
Yeah, particularly when jumping 2 meters.
Yeah.
Right, so
clearly a severe medial column injury, isn't it, Alison, with fractures and dislocations?
That's right. So she's got quite a major fracture in the base of her first, and minor fractures, if you look at the reconstruction, on her plantar surfaces of her second, third and fourth as well. So the reduction was good. They reduced it in A&E, and we took her to theatre and put some temporary KYs in to wait for the swelling to go down. I guess one of the problems with this type of injury is that know from our predictive classification, this type of injury, particularly in the middle column, is the one that is more likely to cause degeneration down the line. So this was the fixation I used at the time. This was some years ago now, although it's not that different to what I'm using now. We originally had some KYs in her fifth and fourth as well. So how did the panel feel about, I know there's a big debate about screws, plates, wires, and possibly now flexible fixation. What are we generally doing these days? Oppie? Andrew? Sorry?
Yeah, thanks, Alison. No, it's okay. I'll respond to anything, especially Oppie. Look, I think with these in someone of this age group, to me, is the things that you've already mentioned. The key is initially to manage the soft tissues, make sure they're appropriate to internally fix, and then once it is appropriate, to then proceed with. And I think this sort of injury requires plate fixation, in my opinion, especially with that comminution at the base of the first. I'm not quite sure how you can sort of fix quite a fracture like that with only screws, and particularly with flexible fixation, probably not appropriate. So definitely be bridging the first with a plate. And then I personally, like, I'm a plater, and I would have plated down the second and third as well. And then I assess the fourth and fifth, but hardly ever have to. But sometimes in major trauma, when they're very unstable, would fix them just with KYs for 6 weeks. But so mine would be bridge lock plating down the first, second and third. But I suppose a question back to you is, I just find those base of firsts, they're like the one you've got, the most difficult, when they've got that massive sort of plantar, sort of lateral based large fragment that you just can't really get to reduce, and you're just relying on that dorsal reduction and hoping that that the joint's going to be okay. And I don't know if you've got any tips for everyone about how to fix that fragment.
I think sometimes a medial incision there so you can see it rather than a dorsal incision. Sometimes I'll go one medial and one dorsal incision, particularly for this type of thing.
Sarah, Swati, I know you've got a bit of a peds interest. If you have adolescents come in with these injuries, I've seen a couple in 17, 18-year-olds. Do you manage them the same, or do you consider like an internal brace or a tightrope type device?
Yeah, so I was muted. Yes, so the thing is, the reduction, the fixation looks beautiful here, but with the limited limited instrumentation that is available to us most of the times. We do rely on K wires and percutaneous CC screws to fix the fragment. We would definitely like to get this Lisfranc fragment reduced and supplement most of the times with an external fixator spanning the ankle, just to make sure that the length is maintained for maybe about 6 weeks, and then remove it. We may not, if we don't have plates like these available, that is the kind of treatment that we would offer.
Okay, well, look, I'll move on to my second case. This is a case that belongs to a colleague of mine, a 24-year-old working as a removalist, and he picked up a pool table and didn't realise that the slate top was loose, and it landed on his foot. So these were the original X-rays from the A&E department, which obviously there's a large medial column Lisfranc type injury and some nasty comminution of the 2nd, 3rd, 4th and 5th metatarsals, and it was an open injury, but only in a minor way. So that there was a puncture wound in about the mid-shaft of the 4th and at the base of the 5th. So moving back to the panel, what do you think we should do about this?
Well, I think if you can, is there anything you can get an external fixateur on initially, Alison?
Yes,
after
there is.
reduction?
Yeah, so that's right.
Very
That's what
nice.
they did. They put an external fixation on it and reduced the medial column. But then what happened with this chap is that he disappeared with the external fixation on and didn't come back for about 3 weeks. And so then they were left with this fairly feral young man who had a great big swollen foot and an external fixator on it when they had intended to do something a bit more complex, but ended up doing this via a medial incision, and then the wires were percutaneous. I mean, obviously not. I mean, the medial column is really good, and that's what I would do. But obviously, does anyone else think that, is there anything else you could have done with the metatarsal fractures had you had the opportunity to do it earlier when it wasn't quite as swollen?
I don't think. No, I don't think so, Alison. Yeah, I think they've done a great job, and you might have got the metatarsals a little bit better reduced if you had gone in a bit earlier. But look, as a good friend of ours, Havinda taught me, a plantar grade chewable foot is what we're aiming for, and I think they're heading in the right direction. And sometimes we need to, change our treatment plans based on the characters of our patients, obviously. And this guy's proven himself to not be very trustworthy, and any more may have mean more problems. So I think it's a great way of fixing it, and that's what I probably would have been doing anyway.
The metatarsal lengths have been maintained, and the toes are straight. So I think you might be surprised how well those metatarsals heal and remodel over time.
Well, this 3 months is at 3 months, and he's walking 3 Ks without pain. So,
Is he back to moving furniture out?
No. Then again, I'm not sure that was an actual job anyway. It might have been just a, slip the money in the back pocket job. All right, so let's move into a slightly more high velocity injury. So this is a 44-year-old male, a motorbike accident, and he's riding along his motorbike and his left foot struck a concrete bollard. So he had an external rotation type injury with a fixed heel. So these are the original X-rays. It's a bit difficult to tell with these what's going on. You can see there's something extruded up the top here, and the second metatarsal has a unusual angle compared to the others. And again, with the AP X-ray, again, you can see there's something happening in his Lisfranc area here, and his cuboid doesn't look happy either. So looking at his CT scan, obviously he has a dislocation of his middle column and a nutcracker type injury of his cuboid. So these nutcracker type injuries can be very severe and cause long-term problems. Mark, have you got any comments about nutcracker injuries?
Well, this is a fracture where I guess you've got an arthritic tendency, but also issues with length. So I think you need to maintain the lateral column length and also get some temporary fixation while the swelling goes down, and then try to obtain an accurate reduction. But you will need to maintain length for some period of time on the lateral side, would be my opinion.
Yeah, I agree. And he's also obviously got some metatarsal neck fractures as well. This was what was eventually done once the swelling went down. And these nice little cuboid plates are very anatomical now. And I find them very good at maintaining the length of the, or restoring the length of the cuboid. Anyone got any comment on this?
That looks great, Alison. I think you've done a good job. I mean, I quite often do leave an X-fix down the lateral column as well for 6 weeks, depending on the stability, obviously, of the calc cuboid and the 4-5 TMT joint. So just to even augment it sometimes, I just don't know. It depends how confident you are with the anatomy of the fracture that it's going to be stable in a lengthwise pattern. But your reduction looks fantastic. And it's interesting that you didn't need to plate down one, because the forces had actually gone through the medial cuneiform. So it looks fantastic.
Right, yeah, it's not doing too badly at the moment either.
When do you take the plates out, Alison?
Do I take the plates out, and when do I take the plates out? I don't necessarily take the plates out. The wires came out, but I would be happy leaving those plates in, particularly in this chap.
Alison, is that because it's 2-3, or you'd be happy even if it was 1-2-3? Like, does that change your
Yeah, look, it does. Yeah, you're right. It does a bit. I don't like leaving one in very much. And obviously, if I've spanned the 4-5, I like to take those out. But 2-3, I'm not that fussed, particularly in somebody that's going to hop on a motorbike again. Anyone else in the panel have any comment on this type of injury, the nutcracker injury?
No, but David Stainsby over in the UK, he's got some really good anatomical stuff. Exactly what you're saying, Alison, about the plates. That 2-3 actually doesn't move as much as we think, but 1 does, and that's why if you fuse or fix 2-3, you can tolerate the plates much better than number 1, obviously. So now the nutcracker, that's just, I reckon they're always hard. When I see them, I'm dreading having to fix them. They're always tricky fractures, and sometimes again. In fact, quite often with a lot of the footwork I'm doing, I'll be augmenting with some autograft using a cora, often for this case, maybe just from the calcaneum, to try and help give it some bony stock, because I'm just worried about it just squashing down again.
Yeah. Okay. All right, last case, and this is an unfortunate one. This is well, they're all unfortunate, I guess. This is a 38-year-old female who fell down a pothole and presented to A&E with a painful swollen ankle. Now, A&E and unfortunately the orthopaedic team diagnosed this fracture here beautifully and took it to theatre and put this plate on here. As you might have gathered, since this is a midfoot talk, this was missed completely, even though it's obvious on both x-rays. Okay, so, and this x-ray was actually done at the time as well and reported as normal. So she went through getting her ankle fracture fixed, and she was in a plaster for some time. When she came out of the plaster, she complained of foot pain. And at that stage, somebody had a look at her x-rays and noticed this and sent her to the foot and ankle clinic. And then we CT'd her only to find this rather nasty Lisfranc variant naviculo-cuneiform dislocation. So now we're at 3 months. Any suggestions?
How old was she?
How old? 34.
Well, it's a complete sort of medial column disruption, isn't it? So I think at 3 months, you would still open and reduce it.
Yeah, well, I mean, I don't think there's any question about that. But unfortunately, we had to do it using a great big Charcot reconstruction plate, because by this time, everything was pretty soggy and soft. And look, she's not doing too badly. We've had to take the plate out because it becomes quite prominent, these plates. But I think it's a big lesson to learn about what seems to be a simple fracture, and you've really got to have a look at the x-rays yourself rather than trusting the reports from the radiology department sometimes.
Yeah, it's tricky, isn't it? Such a simple injury that if it had been diagnosed early, could have been managed, you know, in a different way and probably a different outcome. It's, you know, the principles of your reconstruction are great and it looks great. But yeah, that initial diagnosis is always the way to try and pick it up, isn't it?
Yeah, that's right. I know. It was a bit sad. All right, so I've been very brief with my cases. Probably made up a bit of time for you.
No, look, I've got a couple of questions actually, Al. What do you think the role of flexible fixation is in isolated ligamentous injuries?
I actually quite like the flexible fixation, but I only ever use it when, you know, you've just got that fleck injury, just that flex line, and you sort of think, well, it's not very displaced, but it's potentially unstable. You take it to theatre and you rock it around a bit and you think, yeah, this looks as if it opens up a little bit. And then I'll be tempted to use that flexible fixation. But one like my first case, it's very tempting not to, really, because you really want a nice firm fixation there. I don't know.
Alison,
I think
do you think it's the flexible fixation? This is one of my little theories. It's interesting to discuss with you, but the flexible fixation is the thing that's aiding that injury, or the fact that you've drilled across the joint only a little bit and given it a little bit of extra stability, maybe a little bit of extra, you know, healing and stickiness there that it may not have had otherwise. I mean, I don't know the answer. I'm sure you don't, but what's your feeling on it?
Well, I have to say I don't ever use the flexible fixation in isolation. So, I mean, difficult to know. Sometimes a little diamond plate, sometimes just a little A-shaped plate on top. But as far as whether to use a screw, a home run screw, whether to use the flexible fixation, I'll only ever use a flexible fixation if it's minimally displaced. I don't think I can reduce it, hold it reduced with the flexible fixation. I'm not confident enough of it.
And Mark, you're a pretty amazing 4-foot arthroscopist. Can you stick an arthroscopy in these joints and check your reduction?
No, I don't really like to do arthroscopy in the midfoot. I think I've seen it done, but it's pretty challenging. But I think I prefer an open reduction. I like to see it reduced, even in the lower energy ones. I still prefer to do an open reduction. It's not a big incision for just a grade 1, a grade 2 or whatever. And I still prefer a screw. I like the idea of a flexible fixation, but I've always sort of just stuck with the screws, I guess. I've tried plates, which are quite good as well, but sometimes getting them in the right place is a bit of a challenge as well. So screws are my preferred fixation, but I take them out eventually.
Do you use screws from medial to lateral or lateral to medial?
I like a screw from distal lateral to proximal medial through the medial cuneiform from the second metatarsal. I think I prefer that, and some of the more you know, whatever screw you use is everyone has their favorite screws, but some of the sort of more beveled edge screws are quite good now. They're sort of mildly compressive rather than densely compressive, and so they provide reasonable fixation. But I you know, it's an area where I'm probably doing less of now than I used to, so I don't have as much opinion. But I think as long as you get solid fixation, the results tend to bear out positively over time.
Dr. Allison, I have a question. What is your threshold for bone grafting? Dr. Andrews suggested bone grafting in your previous case, the cuboid, or the navicular when you see a crush kind of injury where there is a void. Do you normally just maintain the length and fix it with a plate or a bridge plating across, or do you always bone graft them?
Oh, I like to bone graft them. I don't trust the bridge plates to hold them out to length. That's just a bit of, I mean, it's so simple to take a bit of calcaneal bone graft and pack it in there. I would prefer to do that than to wait and see what happens.
Okay.
Any void, I will fill. Oh, that's not true. I won't necessarily fill calcaneal void, but any other void I will fill.
Alison, I have a question for you. With that first case, with the comminution and almost dislocation of the first tarsometatarsal joint, would you consider a primary arthrodesis in those cases at this day and age, or are you still happy to fix and wait?
This one?
That one.
I guess
Yeah.
because she was 26, I
yeah,
probably
that one.
wouldn't. Yeah. Yeah, I probably wouldn't at her age. But look, yeah, I mean, a primary arthrodesis is not such a bad thing. In something like that, when there's only a couple of pieces there, though, you wouldn't, I don't think I would do that. I think I would reduce it. But when it's a smasheroo, it is very tempted to do it. The problem with the primary arthrodesis in Lisfranc type injuries is it's difficult to get your length right.
Mm-hmm. Yeah, it's a discussion that keeps coming up, isn't it?
But they also surprise you too, don't they? Like you think, oh, this one's definitely going to need a fusion, and you end up not fusing it. And another one, you go, oh, I've done really well, it's perfect, it's not going to need a fusion, and you end up fusing it. So you know,
It's
you
not
can't
fair,
really predict the ones that are going to need fusion.
All right.
All right. Well, we're a little bit ahead of time. So I'll introduce Jean-Pierre Lung to talk about syndesmotic injuries, please. Thanks, Alison. That was great.
Thanks, Alison.
Sorry, I did get the wrong speaker name then. Dr. El Porto?
Hi everyone. I'm the proxy of Dr. Leung. I'm Dr. Bernard from the Philippines, and thank you for having me here. I work in the foot and ankle service of Philippine General Hospital, and we are actually the youngest service in our department of orthopedics. So the lecture or the talk of Dr. Isan earlier is actually a good segue for the syndesmosis injuries. And there's a lot of controversies regarding this injury. And I hope everyone will learn after our discussion regarding this injury. So these are my objectives. I prepared 3 simple cases so I can more or less stimulate the discussion part, because as I've said, this is very controversial. So I would like to discuss part of the syndesmosis reduction, the dynamic versus static syndesmosis fixation, and the functional outcome after a syndesmotic joint malreduction. So let's go ahead with my first case. So this is a young male. He's 3 weeks post-injury already, and he suffered a severe twisting injury when he was running downhill. And these were his initial x-rays. And so for the benefit of time, I would describe what it's quite obvious what we see in the x-rays. So this is a bimalleolar fracture. You can see a lateral translation of the talar dome, and there is also widening of the syndesmosis joint. So I think this is a very unstable fracture, and I would like to ask the panel now if they, of course, I think are we in agreement that we are going to fix this fracture, or some of you would like to treat this conservatively? Hello?
I think everyone would do internal fixation, yes.
Yeah, okay, yes, okay. So we're all in agreement. And so my game plan here would be, of course, to fix the lateral and medial malleolus fractures, and then reduce the syndesmosis and probably put a syndesmotic screw, right? So this is what the surgeon did. And I would like to ask the panel again for comments regarding the quality of the reduction, and if they plan to change the reduction, or what other intraoperative measures they would like they usually do for these cases to ensure that there's adequacy of reduction.
Bernard, thanks very much for your talk, and tell JP it's nice that we've upgraded to a younger surgeon. He'll appreciate that. So look, I think what Mark was saying before, we definitely consider internally fixing a bimalleolar ankle fracture, and obviously has that syndesmosis component, which is so crucial. And we understand totally when we're doing these sessions over Asia Pacific, we have a huge difference in availability of equipment and prostheses, timeliness to surgery, and so all of those things have to be taken into account. In my practice, with the availability of what we have, what I would do is internally fix the fibula with an interfragmentary screw and normally just a 1/3 tubular plate anatomically. And then I would internally fix the medial malleolus with, as you have done excellently, with 2 interfragmentary screws. And then I actually perform an ankle arthroscopy at the time of surgery, and I do a syndesmotic stability test at the time. It just depends. Again, we spoke about the previous cases Isan had. If I've seen a dislocation at the time on an X-ray, I do an open reduction of the syndesmosis joint clinically through my lateral incision. If it's more of a subtle sort of injury, that's when I do the arthroscopic assessment. And then I leave one of the holes free. And I personally, because I've restored the length of the fibula, that's now length stable, I'd use flexible fixation, so a tightrope sort of fixation. And I think because of that, we've probably become more aggressive with fixing even subtle injuries because, you know, previously when I was using a screw, I personally would take them out at 3 months. So you know you're putting the patient up for another operation. But now that I can use a flexible, you know, fixation device, not needing to bring them back for another surgery, it means that I can put it in and probably even just with a subtle, you know, feeling of there may be a syndesmotic injury, fix it knowing that at least I've done my best for this patient.
Thanks for that, Dr. Andrew, and I completely agree with what you mentioned. But well, in our country, we are, yeah, like you said, we're quite limited with the availability of the dynamic fixation, the tightrope. So we usually end up using syndesmosis screws. And now my question is, if I'm left with the syndesmosis screws, how will you assess this intraoperatively with your intraoperative X-rays to be able to really ascertain that you've reduced the syndesmosis joint? You mentioned also that you will plan to do open reduction, but let's say other surgeons are quite worried because of the incision extending anteriorly, and they usually just do a close reduction of the syndesmosis with the use of the clamp.
I think it's really hard to tell if you get your syndesmosis reduction right just on X-ray during the operation. And Mandeep alluded earlier, there's some pretty good evidence to say between 30 and 50% of syndesmosis injuries are mal-reduced with a post-operative CT scan. So my preference is to either have a direct inspection, as Oppie said, or if there's a hint of a concern, get a post-op CT.
All right, thanks for that, Dr. Amy. So particularly for this case, this is already a 3-week-old fracture. So without the benefit of an arthroscope, and I won't be able to clean the syndesmosis joint, maybe I'll just go with an open reduction to really remove the soft tissues that might impinge the reduction. But if ever I'm just going to plan this with a close reduction of the syndesmosis, I usually just do get away with intraoperative X-rays, and I usually use the 2 methods that I will show later. But this was already mentioned by Dr. Amy that up to 52% of syndesmosis injuries are mal-reduced, and intraoperative assessment is still a challenge. Okay, so this is actually what I've been using ever since I started my practice and I finished my fellowship training. And basically, you just use the lateral intraoperative X-ray and you see the important lines, the anterior tibiofibular line and the posterior tibiofibular line. And in the study of Loiseau et al. In 2017, they determined this in 200 normal cadavers. And so the anterior fibular line, if it's adequately reduced, should just fall at the midline in the lateral view of the tibial plafond. The ratio is around 0.55, and the posterior fibular line usually should be at the level of the posterior articular margin of the plafond or just anterior to it. So in their study, they said that it has a good intra and inter-observer reliabilities. Even a 2 millimeter posterior displacement can be easily seen, like what you can see in the right lower x-rays. So, and I coupled these intraoperative x-rays with the Mortis view. And in the study by Futamura in 2017, you have to satisfy the 3 indices by Weber. The talocrural spaces should be equal and equidistant. The medial spike of the fibula should be pointing to the subchondral bone of the tibial plafond, and the contour of the intra-articular lateral part of the talus should be congruent with the medial recess of the distal fibula as well. So with the use of both those intraoperative measures, we don't have really the benefit post-operatively because of the cost of the C-arm, the CT scans, but with these intraoperative measures, we'll see later, I'll show a case that we're able to get away with the reduction. And this is another study. This is just, I just read this recently, and there's actually a centroid line where they suggested that there's an ideal placement of the tines of your reduction clamp. So it will be a perfectly reduced syndesmosis joint. So you place it within 2.5 millimeters from the lateral cortical apex of the fibula, and then you just place it near the anterior half of the medial malleolus. And it's around 15 millimeters above the dome of the talus. So you can use this to reduce the syndesmosis, and also a guide where you target your screws. So let's test that with this case. This is a classic Mysanov injured case. You can see the widening of the syndesmosis and the medial talocrural space. So intraoperatively, using the Weber indices in the Mortis view, I think the surgeon was able to more or less equidistant values of the talocrural joints. But on the lateral view, you see that the fibula is slightly anterior to the posterior tibial articular surface, but you can see that the talar dome is not, the contour of the talar dome is not superimposed. So it's not a good lateral view. And so luckily, post-operatively, when we got a good lateral X-ray, you see that the posterior tibiofibular line, or the posterior fibular line was indeed in the posterior tibial articular surface, and it's a good lateral view. And eventually, this patient had a routine removal of the screw 3 months after, and he had a good, excellent outcome. So if there are no more questions regarding the first case, I'll go with my second case. Is that all right?
Yes, please.
So this is case number 2. So this is a professional basketball player. You know, in the Philippines, basketball is really popular. So this patient came in 2 weeks after with this severe injury, twisting injury. And clearly you can see the widening in the syndesmosis joint and the medial talocrural space. And so I think this is really a surgical case. And now I ask everyone, because you have the luxury of all the available implants over there in your countries, will you change your fixation technique for an elite athlete?
Look, I actually think it depends on the athlete and the type of sport that they play. I've had a few women's AFL has become quite big in Australia in the last couple of years, and I've had quite a few women's AFL players come through. I don't know about you, Oppie and Mark, but I'm leaning more and more towards using screw fixation for those players, just because they trash their ankles. And then people that are doing sports, I've had a few, I work in an area that's quite bayside, and we've had a few sailors come in with syndesmotic injuries. And I tend to use something that's more flexible, like a tightrope, for people that come in for sports that are less of impact and more twisting, but there's absolutely no science behind that. So I'd appreciate Ian Mark's comments on whether the sports that athletes changes their fixation.
Definitely. Well, I think first of all, you need to grade the injury, and that is definitely a grade 3 with rupture of the anterior and posterior plus medial ligament. So it's quite a severe injury for a sports person. And so in that situation, you would probably need to use a more stable and stronger fixation, so probably a screw. And whether or not you add a tightrope as well for perhaps fixation beyond the normal period, given the stress they're going to put their body under, that would be probably the minimal for me, and whatever else is required. Sometimes you might even open the medial ligament and see what's going on. The majority of the sporting syndesmosis injuries that we would see would be slightly less severe than that. And while there was initially conservative treatment, the trend now is for more internal fixation for grade 1 and 2 injuries to provide certainty of time back to sport. So we're probably operating on a bit more. And on the milder ones, I've moved from doing an arthroscope and possibly fixation with a screw and to based on the MRI, just doing 1 or 2 tightrope anchors without an arthroscopy and making them tight, and that provides a fairly low impact intervention that provides a bit more certainty for the player, who can then return at a far more quicker pace.
Yeah, I think I'd echo everything Mark said. I think it's about the type of injury and the grade of the injury. Then it doesn't really change my treatment because I'm going to fix it. And I personally probably would fix all of the grade 1, 2, and even 3s with a tightrope. But it helps me plan the patient's expectations and return to play. And so whether that's like, as you said, put it in as a kind of a safety stop to say now you can just go for it when they're very minor injuries, or if it's a more major one like this, the thing is how much you trust the player to hold back, and can you hold them back? And if you put a screw in, then it's like, well, you can't play till the screw's out. So I'm going to take it out at this time, and that kind of gives you a nice hard stop. And you might have a flexible fixation in, so you might take it out at 6 weeks, and then the flexible fixation's still working while they start to rehab and get going. So they're the things I would consider in a semi-professional athlete.
I have a question. Do you always open, reduce, and then you open the syndesmosis, look at it, and then put a screw, or do you do it percutaneously? This is for both Dr. Andrew and Dr. Mark.
Always arthroscopic. If you're going to do a reduction, it's probably better to do it arthroscopically, so you can directly visualize the syndesmosis. You can use a clamp, or sometimes even just tightening the screw can provide an element of reduction as well. And then you can supplement with flexible fixation if necessary. But I don't think you need to physically open it all the time unless you're going to repair it with an internal brace or something like that.
Saraswati, I think it comes down to obviously what you have available and what your experience and techniques are for all the people who are out there around Asia Pacific. Because as Mark said, I think the key to it is to make sure the reduction is correct. Doesn't matter if you're fixing it with a screw or a tightrope, or even if it's a K-wire, whatever it is you've got available, the key is the reduction. So if you need to visualize it, if you've got arthroscopic skills, that's fantastic. If you don't, an open reduction is the next best option, and get the reduction right. And once it's right, then fix it with whatever you have available.
I have one more question, sorry, related to the same thing. So when there are times, when you remove the syndesmotic screw, you may still feel a little bit of, opening up between the distal tibiofibular area. So how do you deal with that? It's not unstable, but then do you go again, or what do you do?
I would ask you to go and check the other side.
Okay.
Because quite often for them and this is why we always, for those of us who do use arthroscopy, you go in and you kind of, this one's definitely going to be okay and normal. And we scope the joint and you're like, oh my gosh, that's opening up a little bit. Well, we don't have the ability to go and scope the other ankle and check it. So maybe a stress II, or here in Australia, we have available, for example, bilateral weight-bearing CTs. So you're actually comparing the both ankles. So all those sort of things need to be taken into account when assessing, even at that delayed stage.
I think we've all experienced delayed separation of syndesmosis, so it's wise to be cautious and maybe maintain fixation for longer if you are concerned, would be my comment.
And yeah, look, sorry if I'm hopping on, but so the sports that people play doesn't influence your fixation. No. Okay.
It influences my
no,
return to play and my plan and my rehab. It's not the same for every patient, but it doesn't influence my fixation techniques.
Maybe I need to stop thinking about it.
All right. Am I all right to proceed?
Yeah.
Yep. Okay. So what the surgeon did was actually use screws, no? So he used a semitubular plate secured in the distal and the proximal aspect of the plate with a unicortical screw, and then used a 4.5 millimeter three cortices penetrated with a syndesmotic screw. So again, you already mentioned that if you use this fixation, you might need to remove the screws, and removing the screws the screw holes will become a stress riser and might be complement that suture button with a plate to keep that fibula also stable, and there are biomechanical studies comparing two tight ropes compared to a one tight rope with a plate used as a buttress, and they found that they are both have equal stability, that stability conferred to the syndesmosis. So I think and right now there are a lot of clear advantages of using a dynamic fixation, the tightrope fixation. So I will just say the advantages of the suture button fixation, the accuracy of the syndesmotic reduction. There's no need for another surgery to remove the fixation, and I've mentioned that it confers equivalent stability to the syndesmotic screw. It's actually more cost-effective than the syndesmotic screw, and you get less implant failure. You have quicker return to work and faster weight bearing. Studies have shown that if you use a screw in rugby players, the return of the athlete would be around 180 days compared to just around 64 days if you use a tightrope. And there's, meta-analysis have shown recently that the screw and the tightrope would have equivalent clinical functional outcomes. So what do the other studies say? Again, the syndesmosis reduction, it's more accurate if you use the tightrope. You get 50% less malreduction, and the theory behind this is that you are not really clamping this is a dynamic fixation, and when you're tightening the suture fixation, the fibula will just sit in the incisura, and then this will help with the anatomic reduction of the syndesmosis. Equivalent stabilities with screws, less implant failure as shown in this study, 0% in the tightrope, but 36% in the screw group. and there's a trend to higher clinical functional outcomes, but still not significantly different, and less cost. This is a study done by Neri et al. In 2016, and it showed that it is actually more cost effective because you don't need to do another surgery to remove the screw, and you limit the complications of another surgery. And because in the Philippines, we mainly use the screws, I tried to limit the cost of the secondary surgery and tried removing all the screws just in the clinic. But the first two became a disaster, and I can't really, I had a hard time removing it locally. So I guess you need to really bring these patients again to the operating room, and that will incur additional costs. So, and again, and this is a biomechanical study in 2019, that you are more able to restore the anatomic kinematics and pressure distributions in the ankle if you use a dynamic fixation device. Okay, now I'm in my last case. This a young male again, motorcycle crash, because he drove his motorcycle while drunk, and he suffered an very comminuted femoral shaft fracture, a patella fracture, and a fracture dislocation of the ankle, all in the right lower extremity. This guy had multiple surgeries done, and then eventually I was able to fix the patella, the femur, and did STSG on the medial sided wound. And these were my intraoperative reduction of the syndesmosis. And at this stage of the surgery, I was a bit tired already. So I said, I was a bit cocky and said, oh, this is anatomically reduced already. And I did not check the lateral view of this ankle. And lo and behold, post-operatively, the fibula is slightly anteriorly displaced. And at that time, I said that maybe it's better to get a post-operative CT scan, but the patient has no funds for it. And then I said, maybe eventually I will remove the screws anyway, and the fibula will move back naturally into into the incisura. So I removed the screws, and these were his x-rays 6 months after. And then on the lateral view, you see that the fibula did move a bit back, but in this lateral view, it's still slightly more anterior compared to his normal side. And then again, I said, maybe it's time to get a CT scan, but the patient is quite happy. He's moving well, and has no complaints with the ankle. His problem is actually in the knee because of the prominence of the cerclage wire, but he still doesn't want to get them out. So this patient was then lost to follow-up, but he became my friend. I got his number. And for the purposes of this presentation, I called him up. And last week, I was able to bring him in the hospital, and we did finally the CT scan. And it actually showed it is indeed a bit anteriorly displaced with 2.1 millimeter difference from the posterior tibiofibular side. And you can actually see that the track of my screw was not in the centroid axis of the syndesmosis. It's a bit anterior. I think that contributed to the malreduction. And you can see that there's also a 7-degree external rotation deformity of the syndesmosis. But again, the patient is really happy. No problems here. He's able to walk on his toes, on his heels. And this is actually already 1.5 years post-injury. I got this last week. So he's happy. And now my question, and I don't know actually the answer. I've searched for this even before this talk, and I still don't know which malreduction is clinically relevant. So studies have shown that if you have more than 2 millimeter displacement and you have more than 10 degrees of malrotation, you'll end up with a bad result. But I don't know with everyone, the experience of everyone with the malreduction of the syndesmosis. So I need your expertise on this.
I do think that that magical number is 2 millimeters, but again, I'm not 100% sure where it's come from. Oppie's published on Liz Frank injuries and the acceptable reduction parameters for Liz Franks. And again, we never really decided exactly what and how we decided what an acceptable reduction actually was. Obviously, the one on the bottom left needs to come back. But I do think, particularly in women of childbearing age, there is a real degree of ligamentous laxity that we can accept. And I've sent a few off for weight-bearing CTs, women who have had really bad ankle sprains, say 3 or 6 months post having a baby. And their syndesmosis is what you would call subluxated at any stage of the week, but you compare it to the other side and it's actually exactly the same. And it's the ligamentous laxity associated with a postpartum period compared to, you know, a severe ligament injury. So I guess you treat the patient, you know, and instead of treating a CT scan or treating an X-ray, you actually look at the patient and see if they are symptomatic with that 2 millimeter displacement. Because as far as I know, we don't have the 25, 30-year studies to show what this even means for patients in 30 years.
I completely agree. That's why. Any inputs from Dr. Mark or Dr. Andrew regarding their experience with malreduction?
What we don't see, apart from if it ends up becoming stable, well, we don't really see too much problem if it is slightly malreduced. But what we see now with, you know, sort of some lateral column or lateral talar arthritis is probably some chronic old syndesmosis injuries, but we don't have the data from that period 20 years ago or 30 years ago. So I think on principle, we would agree that an anatomical reduction and stability is successful. Whether it's 2-3 millimeters out makes a difference in 20 years is what we don't know. So I think that the step that we have taken in the last few years is that fixation is important. And then the next step will be what type of fixation, I think, and we'll probably all end up doing flexible fixation eventually, and it won't be a problem.
But Bernard, you're right that as you've all said, the difficulty is and we don't know the answer, as Mark was saying, is what to accept as a malreduction. And the interesting thing, you've obviously, because of social reasons, got that delayed scan. The interesting thing is sometimes when I do have an index of suspicion, I will get a post-op CT scan straight away. And that's the perfect time to obviously intervene and fix it. But then the question is, well, when do you intervene? And we don't know that answer. Or what is acceptable? And as Amy said clearly, that, you know, the one on the left, well, there's no way any of us would leave that. But the one on the right, that's sort of a few mils out, like, is that going to drop back in? We don't know. And it's so hard. And hopefully with time, if we're able to keep the data, which is what we should try to be doing for all of each other, we might get some sort of an answer.
All right. So I actually, okay. Dr. Saraswati, do you have a question?
No, I don't have a question. I thought you were just winding up your...
Yeah.
I've got a question if you don't mind me asking.
Okay.
So we're talking about flexible fixation and how one of the advantages is that you don't have to go back to take the screw out. I don't know about anyone else, but I've actually had to go out and take the medial button out several times because it irritates the patient. Does anyone else have that experience?
Yeah, I can share that with you too, Alison. It's great to hear that other people have had it. And I think, I don't know if you're doing anything differently since you've had to do it. I've tried really hard to focus on making it so it's a little bit higher. Definitely have always not put it on the prominence of the medial malleolus, but even trying to sit it a little bit higher. So even if you might, against what you'd normally do with a screw, be perfectly parallel with the joint, but with the syndesmotic tightrope, a little bit sort of higher medially, So it's a little bit off there. And that seems to have helped a bit, but still some people just do get quite significant irritation from it. It's not uncommon, but yeah, is that what you have had the experience with?
Yeah, sometimes I find putting a bit more posterior helps as well, but then again, you come into the tiger country there as well. With the new fixation, they don't have the sharp needles anymore, so that's less of a problem.
All right. So
I've had just really, I had a couple of gymnasts and ballet dancers that they felt it was just too tight with a tightrope fixation, and I've come back and I've taken 2 out for people that really need that dorsiflexion of their ankle. So I used the tightrope initially as part of their initial fracture fixation, and then I came back and took it out about 12 months later. Because they just couldn't get their dorsiflexion, and then once it was out, they were really happy.
There's also a controversy regarding that, Dr. Ami, that said that it doesn't matter if you over tighten a really reduced syndesmosis, but there's actually a trend, though not significant in other studies, that say that after they remove the fixation, the patients actually had better dorsiflexion. So it's still up in the air. All right. So the earlier studies actually say that if you have a mal-reduced syndesmosis, it's correlated with poor clinical outcomes. But these are all cohort studies, non-randomized and retrospective studies. But the newer, more powered studies and the systematic reviews and meta-analysis actually show that the syndesmotic malreduction is still unclear in terms of the clinical importance. And the quality of syndesmotic reduction did not really influence the clinical outcomes. And from the meta-analysis, when they compared the tightrope from the syndesmotic screw, obviously there were more malreduced syndesmosis in the screw group, but at the end, they all said that there were no clinically significant differences in functional outcomes. But at the end of the day, like what Dr. Andrew said, we need more high-quality studies regarding this. And the 2 millimeter cutoff of malreduction mentioned in most studies in the syndesmosis remains unclear. So what do we need to do? So like what you've said, we aim for a perfect reduction in the syndesmosis, but if it's not perfect, do not beat ourselves up. It might just be a small deviation from normal, and this would still lead to a good clinical result. I believe the syndesmosis is a dynamic and forgiving joint, and I think the key still is the anatomic reduction of the tibiotalar joint. And if you suspect a grossly mal-reduced syndesmosis, then please get a CT scan post-operatively and check if it's really grossly mal-reduced, because I think this will greatly affect the tibiotalar articulation and will affect the functional outcome of the patient. And like what I mentioned, we need more long-term clinical studies regarding this matter, because what I've seen, we only have around 2 to 3 years of follow-up with the published studies. So this is actually my end slide. My take-home points regarding the syndesmosis. Syndesmosis reduction is still a challenge. The number one key, I think, first off, you need to anatomically reduce a fibular fracture to regain that length. For the syndesmosis, you have to scrutinize your intraoperative reduction with the normal radiographic parameters. And like what Dr. Andrew said, you can get away with just do an immediate open reduction of the syndesmosis. And if in doubt, get CT scans post-operatively. There is now actually a clear advantage with using a dynamic syndesmosis fixation. I'm not really promoting the tightrope brand, but it's the most used system in the world. So, and the studies are all based on the tightrope. So I've been mentioning tightrope a lot in this presentation. And like I've mentioned, the minimal malreduction in the syndesmosis may be acceptable, but we still need more follow-ups regarding this. And before I end my talk, I'd just like to give special thanks to these following doctors, especially Dr. J.P. Leung, Dr. Mike Gonzalez, Dr. Nando Acance, and Dr. Zarluis Gaston, and of course the Philippine Foot and Ankle Society for really helping me with this presentation. So thank you for listening. Stay safe and mabuhay kayong lahat from the Philippines.
Thank you, Bernardino.
Thank you. Thank you, Dr. Bernardino. I think we're right on time for the last and most interesting talk. We have been discussing about lack of, in developing countries, lack of implants and lack of proper environment to do these surgeries. And we have with us our last speaker, Dr. Annette Follian. I think captain is the better word to, address her. And she has worked in trauma, dealing with war zone situations. So I think we'll get an idea about how to manage things when the environment around us is not very congenial. Dr. Annette, to you.
Annette, we can't hear you.
Annette, I think you're on mute.
Well, she's not on mute. The audio.
Oh.
Can you hear me now?
Oh, that's much better, Annette.
Yes.
Yeah.
Yes.
Oh no, you've dropped out again.
How about now?
Yep, can hear you now.
Yes.
Yeah. that's
Okay, I won't touch another thing. Yes, so I've had an interesting career and I've done a lot of service overseas in difficult circumstances. So Maureen has asked me to share some of those experiences with you. And I will say there's not been there's rarely been a CT available to help work out what's going to happen. I've been to two tsunamis, the one in Papua New Guinea and the Boxing Day tsunami in Indonesia, and another earthquake that followed soon after that in Indonesia. Two was in Afghanistan, and in 2013 I was in the Philippines when Typhoon Yolandi took out Tacloban, and I've been involved with developing some capacity for Australia after that. David Helford wrote a really interesting paper after he went from New York to the Haiti earthquake in 2010. And he really outlined a lot of the assumptions that he had in place when their team left New York to go down and help. The situation on the ground in the middle of a disaster is nothing like you would expect from your home environment. You may not even be working out of a hospital. You may be resorted to working out of a tent and potentially working by penlight torch, which I am down in this picture at the bottom with someone with a necrotizing fasciitis. When you're planning to go, you really have to address, first of all, the living conditions for the team. It's a little bit like Maslow's needs that need to be satisfied. You have to have your own tentage and food and water. You can't expect to rely upon the recipient country to provide those for you when they've just been devastated. There may be ongoing threats, either from security with people wanting your equipment. There may be some civil unrest going on, or it might be the environment with ongoing earthquakes. And certainly that's a most unpleasant experience when the building keeps shaking around you while you're trying to operate. Working out how you're going to work, whether there's power, water, drugs, imaging's available, how you can move people with particular injuries onto further referral pathways need to be worked out, and how you're going to operate if you don't have some of those things. And after that, then I try and work out what instruments and consumables we have, and that will generally be what you take, because you won't get resupplied in the time that you're there. Even if you see lots of planes flying in, it's all going to go into a storage, and it may not be available for at least certainly 2 weeks, and probably even 6 weeks before that equipment makes its way to a hospital. So whatever you carried in, that's what you've got, and you better keep a tally and ration its use in the time that you're on the ground. And after that point, then I do get a handover and round on the people who are in need of care to find out what conditions we're going to have to deal with, and try and work out what the interventions and priorities are that we'll be providing. The team will be under threat if there's ongoing violence. if there's been an earthquake, it's likely that sewage lines and water lines are disrupted. And just because water comes out of a tap, which may not happen, but if it does, it may be contaminated by sewage. So it's inappropriate to be washing your hands in it for surgery. I think one of my lowest points was washing my hands over a toilet bowl, or somebody tipped saline on my hands to give them a clean. Shortly after that, we reverted to using alcohol beforehand and a good wash down afterwards. And how you can operate when you don't have a sterilizer and there is no lighting and there is no diathermy or suction and no reliable waste disposal really does challenge you and make you realise all the things that you normally take for granted in our hospitals at home. This is just a couple of pictures to show you. This one on the bottom left is an earthquake that was in Banda Aceh after we'd arrived. We were working at a police hospital and the building kept shaking. There's the people who had been through that first major earthquake and tsunami were just terrified. And perhaps if we'd been there, we would have been more alert to the risks that we were facing. Sleep is really important, and it's almost impossible in places where there isn't any air conditioning. You've flown straight out of a pleasant, cool Melbourne to go and work in the tropics. And the top right picture is the dizzy heights of the showering facilities at the airport at Banda Aceh, where there was a 44-gallon drum split that you had to scoop with water to wash yourself down. And no, there was no separate men's and women's bathing facilities. And in an Islamic country, coming out of a Christian country, I had to work out how to navigate those difficult issues. So in Australia, we developed a surgical team, or there's an all-over medical response team, but there's specifically a surgical team training that's now available within Australia. And we do, whilst we do some teaching for orthopedics, it's more about how to work on your own when you normally have an assistant, how to reduce a tibial shaft fracture when you haven't got x-ray and there's no other skilled person to hold the reduction for you while you apply plaster. But it's also about how to put up and take down tents and how to survive through checkpoints and negotiation skills. Quite challenging, but that does give us we did get verified with the World Health Organization as an EMT, and that will come back. That's how people will need to manage to deploy in the future. So just a few topics I wanted to briefly touch on, and as I go through, we'll become a little bit more interactive, I hope. But I thought I'd run briefly through open and closed fractures, compartment syndrome, amputation of wounds. So it's in no depth at all. So this is one of my first cases. It's a little boy who was about 8, who was in hospital in the Philippines, and it was about day 7 after his injury. And it's hard to appreciate from here, but his foot's in extreme external rotation compared to his knee, and seemingly had a closed fracture of the mid shaft of his tibia. The local hospital was treating him with a bandage on his leg, which I'm really not quite sure what that was doing, apart from not let the mosquitoes bite him. But the local hospital, without power and water, was trying to do the emergency obstetric cases. And although we only had a tent, it seemed like the very sort of case that we'd be very easily able to look after for them. So from the team, the simple approach to a closed fracture, particularly in a child, to keep it closed. And that's exactly what we do. It gets more complicated as I go through. You need to find out what the local standards are, and it's almost universal that children with closed mid-shaft fractures are going to be treated by closed means. And I think one of the difficulties when you're in a place where there's chaos is communicating that onto the next team about what's done and what's underneath. So having some ways, either drawing on the cast or drawing on the patient or drawing on bandages, really needs to be directed at your handover and working out how you can get that information onto the next team, whoever that may be, that will continue his care. And I think working out who will take over from your team or where you can send people to is really important. And I think it's even more important when it comes to periarticular and intra-articular fractures. You must have someone that's going to look after these people in an ongoing way. So more on closed fractures. Again, this is in Papua New Guinea. The hospital there on the far north coast of New Guinea also suffered a tsunami, and there were many children with injuries. And probably about 10 or 15 who were left here at the end of our period who had closed fractures of the femur and needed set up in traction. The beauty of that situation was that those medical staff knew how to manage people in traction. They were more familiar with just straight longitudinal traction without rotational control, but we were able to set the children up and have them looked after in their home city with the management with skin traction for a period. This little boy, yes, he has not got a normal femur. I'd met this young man before, in fact, in Melbourne. He was my reason for getting involved in Papua New Guinea. He had osteogenesis imperfecta and multiple fractures in the past. We just happened to have a femur fracture while I was up there. Sorry, just go back again. It may not come across in the projection, but he's covered in beads of perspiration. One of the things that we very rarely see in Australia is malaria, and certainly in tropical countries where malaria is endemic, all that's fever is not our septic wounds, and it can be malaria, it could be dengue, there are a multitude of other illnesses, so you really need to know what the local endemic conditions are that could also be playing out for your patients. So it comes to adults with closed fractures. We tried to keep these closed as well while we could. This hospital normally managed their adults with femur fractures in traction. I'm not sure if the person who normally managed them is the one who set this traction up, but they had some of the right ideas. I think they'd put the skeletal pins in, but they didn't know that if there was a rope in the pulley and the end of the bed wasn't elevated, then the patient's really actually not in traction. They've just got a pin in their leg and a rope attached to it. So we were able to convert them, and this is one of the ladies we managed to manage with brawn frames. We got the local mission carpenters to help construct many brawn frame for us, so we could elevate the limb as well as set up longitudinal traction, and had some control over the limb by having the rice bags that we used to line the brawn frames with, helped control the traction by setting it in a gutter. Any questions or comments about closed fractures then? I think I guess the main principle is really that try to keep them closed. I've got one that I ended up opening that I'm just about to come up, but in the early days when things are really a disaster and chaos and you don't even know if you've got clean water coming out of your taps, it's best not to venture into any sort of internal fixation. So do as much as you can by closed means.
What about a role for an X-fix, Annette?
My very next case is coming up, did end up with an X-fix. So I'll flick onto that as we talk about that. This one's actually in a military environment where we did have external fixation. The previous cases in remote and rural areas I've been to didn't have their own external fixators, and we had a very limited supply, and we'd made a decision that we would use them to evacuate people who had to leave the country. So it would likely be an expat that we were trying to fly out somewhere if we did use them, like we had 3. But in the contrary, this is in a forward operating base in the Middle East. It's a hardened shelter, a tin shed with about 1.5 meters of rocks on the roof to protect you from incoming rockets. And it was in the middle of a multi-CAS event. And it was just in the time where I was about to leave, I'd handed over to the next surgeon. And I was then tasked to put a back slab on this man. He'd been a passenger in a vehicle, and the IED had gone off under a flat bottom vehicle and hit the bottom of it. And he had this very distorted looking ankle. That's a large swelling sticking out the medial side of his ankle. Would anybody have supported just putting a back slab on that and then having him flown out to who knows where, probably 4 hours, 8 hours flight away?
The ankle clearly looks subluxated or probably dislocated on the lateral side. So you would need to reduce it and probably get a better anatomy before you put the slab. Or as you said, you had X-fix available in this case. So probably, stabilize the joint better.
Yeah, I was very concerned about the skin and the potential loss of skin on the medial side of this ankle. So I did plan to put it back. I don't seem to have the X-ray now, but we did only have plain X-ray available to us, and he had a dislocated talus. It had spat out of its rightful place out the medial side and appeared to be basically intact. So the distal tibia was articulating with the calcaneus, and his talus is sitting out medially. And I did try to do it closed and push it back. That was absolutely impossible. And it is an injury I later saw at the Roll 3 hospital in Kandahar as well. So I did open this and had to use a half pin into the talus to help use it like a toggle stick to help get it back into its place. But I needed to distract to get it there. So I ended up constructing a frame around it and was able to transport him like this. So I didn't have to use any back slab in the end, which is much better for his transport. Long bone fractures in the vibration in aircraft, particularly military aircraft, is really quite significant and is a very potent source of pain if you're trying to fly people around. So we always worry about compartment syndrome developing in people with blast injury. Where this was so distal, that was less of a worry, but maybe looking back now, I would have had a lower threshold to do fasciotomies before he left, but he came through well. Is that, have people seen, apart from blast injury, a dislocation of the talus completely off the tibia and subtalar joint? You see that, Amy? I don't spend a lot of time with
I've seen a couple.
Yeah.
Yeah, I've seen a couple with motor car accidents.
Yeah, they come in with the talus in a bucket.
Yeah.
You know, you're in
maybe that was. Yes. Well, I would have left it in the field if we were away. So then coming to open fractures, this one's in Indonesia, near Banda Aceh, but a couple of hours away at a hospital we went to. And this was on I had a few instruments at this hospital, but there was no surgeon there. There had been one, and then that surgeon had left. And so there's about 200 patients, of which this was one, who all needed follow-up care. So there was a fixed building, there was running water. MSF had taken me there. We had no orthopedic instruments. I have to say my challenge with things like this is what's under that bandage. You have no idea what is going on underneath there. So getting consent for theatre is a bit of a challenge. Yes, of course you need to take the bandages down and see what's there, but I really thought this was heading for amputation. So I raised that with him while we were getting consent. And it's not very straightforward in a lot of countries. If this was Australia, it would be a very straightforward discussion and either a yes or no. Well, it was pretty straightforward with him, and it was going to be no. He would rather die with his leg on and be intact than have an amputation and survive. And people need to be aware as well, it's not, women often can't give their own consent. They would need a male partner or guardian to give the consent for them. And sometimes there's really big social issues. If you amputate the limb of a man, he may never work again. If you amputate the limb of a woman, she may never be able to marry. It's quite a challenge. So when we did take him to theatre, actually his fracture wasn't that bad and his tissues were pretty good. So I did a lot of cleaning up and using plaster slabs and dressings, got him back to the ward. But the person on the right is, I don't think it's the same man, but it's the same condition. My patient was missing sort of 24 hours later, and I was asking where he'd gone to, and they said, oh, he died. He had tetanus. And we do a lot of prophylaxis for tetanus in our country, and we hardly ever see anyone with tetanus. And it was very confronting to have a lot of patients who did die of tetanus because there was no not much in the way of an effective vaccination program going on there. And we had very little tox and tetanus immunoglobulin with us. And it's still, I'm sure that the delay in our time of reaching these patients probably would have made no difference to the outcome for these people. And there was no ventilation option. There was the tetanus outbreak was written up. I think there were 250 deaths from tetanus following in that northern part of Indonesia after the Boxing Day tsunami. If you don't have an X-fix, you can construct an X-fix. This man who looked so excited and was actually walking on this leg with a very soggy plaster bandage on before I had a colleague arrive with some fiberglass. He was very excited because he had one of his mini children had survived, and that's his daughter sitting beside him waiting to be evacuated. But he had a segmental fracture of his tibia, but we had no X-fix at this point. We're in a very rural area. But they did have the traction pins, so we managed to use traction pins, housing braces, and fiberglass to fashion a sort of X-fix to help control him. And I did manage to get follow-up in him, and it went on to heal one fracture, and then the second one I took out the pins and we put him in a walking cast, went on to unite. The blast injury. So my blast injuries are experiences from the Middle East, where it's usually dismounted. In Kandahar, it was largely dismounted troops, people who were walking along, and then the road exploded underneath them. And that usually meant there were multiple injuries concurrently. It was very often at least one limb that had already been traumatically amputated. Another looked like was well on the way to needing amputation. Very often, because the soldiers walk along holding their weapon, one hand will be down low, and that will have been severely damaged, and the other arm quite peppered. Very commonly had chest or abdominal injuries, and very often perineal injuries at the same time, along with facial and sometimes head injuries. So it was a very complex and difficult thing to provide the right care in a timely way. We would often have easily 10 surgeons in the room operating concurrently to try and get these patients off the table. I heard Zolt saying yesterday about damage control surgery, and that concept, well, this was damage control surgery. These patients would never have survived with a type of sequential surgical care we provide in this country. So with the knowledge that there's a lot else going on at the same time, we often have this question of, are we going to amputate, or are we going for limb salvage? When they've already lost the other leg, and may have lost a hand and might lose the other one, I find it really challenging to consider triple and quadruple amputees, particularly if they've had perineal injuries, they've got a colostomy, heading for really great difficulties in their ongoing management. So where we could start to do some sort of limb preservation, we did. And it's one of the principles I think it's really good to follow, and perhaps this will come up when I'm talking about the wounds, is that if something is, if it's already dead, then you need to debride it. But if it's not dead yet, you can keep it until it becomes clearer. So it's really important to get this distal circulation restored if you can, and stop the bleeding if it's ongoing, which certainly can be from the veins in the calf. The damage control part of the orthopedics is reducing contamination, stabilizing the bones, and then closing the joints. I just flick forward. This is a boy who had a gunshot wound to his thigh. One of the things we often forget about with arterial injuries is needing to have a fasciotomy. And while the surgeon was, whether you do a shunt or frame or which order you do it, it often relates to the warm ischemic time. And this boy, we didn't know how long it was since he'd been shot, but he was still bleeding quite badly and quite shocked. So we put it within a matter of hours. But we elected to do was shunt long to get some circulation going again. The general surgeon did that while I did the fasciotomies, and then I stabilized the bone. The really challenging things to try and work out what to do for local people when you're immersed in their country. And compartment syndrome, I see my time is ticking away. I think what I really want to point out with compartment syndrome is usually decision to operate is a clinical one, but particularly don't attempt fasciotomy if it's more than 24 hours. And as responders coming from outside the country, it will always be more than 24 hours for us before we arrive somewhere. We've got to wait till a country invites us to come. We've got to pack, get ready and go. So it's only if you're in the city where it happened that you've got any chance of doing decompressive fasciotomies for compartment syndrome in a disaster, which you might very typically be required to do in an earthquake. And with amputations, yes, debride what is dead. Sometimes if the dead part is the foot, then yes, that's an amputation. And if that's the situation, then you do it as distal as possible. Not like this young man who's had a guillotine amputation quite high in his tibia. That's a poor way to present, because that's not salvageable really as it is. And some things like that cause you emotional challenges when you're away. But once we got to know this family, because we did get him to take him to theatre quite a few times, this was a piece of tin that took this boy's leg off, not a surgeon. And he had no medical care for 4 days after that happened. Probably just as challenging to the emotions if we'd known that at the time. And if you are doing an amputation, never close it primarily. This man was on death's door at the time that we met him. And really it was a question of, do we take him to theatre, take out the stitches and see if we can do anything, or does he die as he is? And since taking the stitches out and some further debridement didn't seem too much of an insult, we elected to do that. But it was very ineffective and he did die a short time afterwards. But his leg was just it was dead muscle inside. Just never close things primarily. And with wounds,
just a couple of minutes in it.
Yep. And with wounds, small holes can hide very big things. Never close up wounds like this with sutures. You can see suture marks there and a slight swelling behind the thigh. I lifted behind the thigh. There was terrible grey pus that poured out, and this needed to be laid open. It passed the joint, easily spreading down the leg and up the thigh. It's like a degloving injury with pus just eating away at the subcutaneous tissue. And then this little poppet. This is a little 4-year-old who'd had, I think, that sort of degloved sort of skin with infection under it. And the surgeon before me had managed that by cutting all the skin away. But that leaves a really poor outcome. Skin often has got a good chance of survival. So although it controlled the infection, I'm really worried this little one would have ended up with an amputation. But it's not dead yet, and I didn't amputate it because you never know who's coming behind you. If there's a plastics reconstructive team that might be able to give him a more functional limb than I would with an amputation. Okay, so that was my summary. But if there's anything you wanted to ask me about it, since we're right on the knocker of time.
I think it's been really interesting cases to see the environment that you were working in. Amazing, as you said, it's more important that when you have very limited resources, to see what can be the best outcome with the existing resources. Mm-hmm. And the cases that you have shown are actually quite, severe ones towards the end. Just hope that I just hope that even in these small places, the medical facility per se should improve, so that when you hand over these cases, there is still a good care taken care of after the primary management. Yes, I think trying to help other people, more people have surgical skills is really important. And doing the general surgeons doing good orthopedic care of wounds, doing it well. I think there's a real tendency to just amputate, and that was a real problem in Haiti, and it was the start of the great movement towards a humanitarian surgery developing, because an amputation might be easy on the day, but it's can be a terrible disability for the patient and the family if there's no rehabilitation opportunities and no prosthetic opportunities. A useless limb, what we would consider a useless limb that they'd do better with a prosthesis, might not be an option for them.
Okay, ladies and gentlemen,
thank you.
I will have to thank the previous panel because of time. I'm Christian Fang, so I will be one panelist for the Established panel. So it was a great one just now. Thanks all. Thanks everyone.
Thank you. Thank you.
Thank you very much.
Thanks.
So I would introduce the next panel for pelvic and acetabulum. So the panelists are Vivek Trika, myself, Abe Al-Hassans from India, Sudeep from India, moderators. And the first talk will be given by Professor Casey Park from Korea.
Sudeep from Nepal.
Oh, Sudeep from Nepal, I'm sorry, yes.
Nepal, and Abe lands from India.
Yes, okay, so I'll give it to Casey.
Yes. Okay. I will start. Okay. Good evening. I'm Kichol Park from South Korea. I work at Hanyang University Hospital. I'm trauma surgeon. So my talk is, I'm very happy to be here and thank you for invitation. My talk is periprosthetic fractures around total hip arthroplasty. It's learning outcomes. To know the appropriate method for evaluation and treatment of Vancouver type B fractures to identify the obstacles and pitfalls in the operative treatment of periprosthetic fracture. Okay. Treatment of periprosthetic fracture can be complex and challenging as they require the experience of both trauma surgery and revision arthroplasty. Vancouver classification is useful and reliable guide for surgical planning of periprosthetic fracture. This recommended plating for stable processes and revision for unstable processes, bone graft for poor bone stock. But the differentiation of unstable processes from stable processes is very difficult. I have 3 cases. First case is a relatively simple one. This is a female 84 years old patient had a periprosthetic fracture due to the slip down. Okay, I'd like to ask to panelists about the interpretation of X-ray.
Can we start from Vivek, please?
How is it, the X-ray?
Vivek, you are on mute. Maybe you can unmute first.
Sure. So it's involving the distal tip of the stem and the proximal. Actually, the thing is that you will have to prepare for both the things in all these cases when it is there. That you can do a plating or you have to do a revision arthroplasty. But it appears to be comparing with the previous films, if there are any. We will like to see the previous films. Involving the distal tip and the spiral fracture is going down below with a good fixation, which appears at least on these x-rays in the proximal part. So for me, it will be more of a fixation of this thing with a long plate going right up to the lower part into the total knee so that we do not leave any part which is free or which is not there on the plate. The plate has to be long. It has to be treated like a pathological fracture for me, going right from the top till the bottom till the total knee is there.
So this is stable B1, right?
Yeah, looks like that. It's very difficult to say it on here. That's why you always have to have a backup of the other plan as well. Yeah. But just looking at the thing, it looks like that.
Yeah.
But I think is you have to look at the proximal fragment. There's a crack at the very distal part of the proximal spike. So, and then if we look at the lateral view, there is some overlapping. So it looks suspicious. There may be an additional wedge fragment that, if that is the case, the stem is slightly loose and it's a B2. So it's difficult to tell. That's the first thing. Second thing, the stem is in a little bit of varus. So I would go back to the previous x-rays before the fracture. Was there something special going on before this kind of injury that have led to a varus? Because that might change my decision making. If it's a problem already happening before the fracture, then revising the stem is a reasonable thing to do.
Okay, good point. And this is pre-injury X-ray, the left side. So you usually compare the pre-injury X-ray. Now, how about this? Is this stable or unstable?
So it also comes to what kind of patient is she, how old, what's the general health status? Because if it's a low demand, we can just fix this and it will be fine for a low demand patient. If it's a very high demand one, we might need to do more.
For me, if I can add, it also depends on the character of the surgeon. He's more of a trauma surgeon or he's more of a revision arthroplasty surgeon. Or there are two different surgeons who are combining together and doing the same thing at the same time. A person who is more into trauma might like to fix this and get away with a plate, which is a long one. And a person who is more into an arthroplasty. That's what I have seen in my experience with me and with my colleagues who are the revision arthroplasty surgeons. We both combine together for such cases. And I would say it is a fixable one and they'll say it's a replaceable one. So it's always a dilemma, especially in this sort of a case. I'll again say that I'll go with this, with the plating and fixing it.
In fact, how do you confirm the stem stability? Do you confirm stability at the OR room or?
Yeah, mostly intraoperative will be the thing which will help us to understand whether it is by rotations as well as by going up and trying to see what's the fixation pattern of it and then looking at that. That's how we'll look.
Okay.
So if I may add before you go ahead into the discussion, the other thing that also needs to be kept in mind is that there is another classification system which says that if your periprosthetic fracture extends to more than 25% of the length of the stem, then you're probably looking at a loose stem than a well-fixed one. And the other thing is that if you look at the lateral X-ray, there is a slight, probably a lucency at the level of the lesser trochanter. So one has to be open that this probably might be a loose stem rather than a well-fixed one. But as Vivek said, definitely one needs to go in with both the plans and the decision has to get done on the table. The patient needs to be consented towards both.
So you decide the revision ORNF at the OR room after surgical dislocation. How do you manage this fracture if it is your cases?
So would be ready with both, but would keep a distal diphyseal fixing stem on the table as probably a primary choice. And looking at the implant that is present might have to change the cup because it's a bipolar, so might have to convert into a total with a long diphyseal fixing stem as well. But if it's a well-fixed stem and doesn't appear to be loose, then would just need a fixation which is extending right up to the distal metaphysis.
Okay. It is very difficult to differentiate B1, B2, but this is she's 84 years old, a very elderly patient, and compared to pre-injury X-ray, there is no change of stem, and so I thought it is B1 stable stem. So
may I comment?
Okay.
I think we have to think of the patient's activity and life expectancy. This is a very old patient, and also the pre-injury symptoms. If there is some loosening, patient may have complained some pain before injury. So also, if the patient demand is low, even in B2, we can just fix it because revision will be much invasive for this kind of patient. But patient's activity is high, and B2, I definitely choose revision. So we have to think not only the X-ray, but also the patient's activity, life expectancy, and symptom.
Yes, good point. Yes. So let's talk about the discussion about fixation. You can get, you can do the MIPO. Also, you can do the RNF with this fracture, and talk about the reduction technique and implant option.
So the reduction is straightforward. Usually this one, a lateral position, open, subvastus, a long plate, as long as possible. That's the general principle. For the top part, it's cerclage. Some may prefer the plate attachment device. Distal screws nearly touching the knee prosthesis. So I think that will be standard for most people.
So you prefer the MIPO?
No, actually open. It's very difficult to do a MIPO, especially the reduction step. I will use a cerclage. And once you have a cerclage, even if you call it a mini, it's still an open.
Yeah, right. But I mean the biological fixation. So you just approximate the reduction using the cerclage wire, and then the next step is same as MIPO.
Yeah, I think the point about biological is important. We don't really differentiate MIPO from open so much like before. Just keep the periosteum intact. I think that's the key point.
Okay. Implant, what kind of implant do you use?
So I'll use a long distal femur type of plate. It tends to go as high as the greater trochanter. So the key is to have the plate overlap majority part of the stem. So that will give you a stable construct proximally.
You can also use if you want, you can use an anatomical plate, which is there for the femur, the sort of a banana-shaped plate, 4.5, and you just need to open up the fracture site and the proximal area because you want to see the mobility of the stem along with your reduction of the spiral fracture, which is most of these are spirals in nature. And the lower part you are going to do just like small incisions going right up to the total knee incision and near the total knee prosthesis and fixing that. It's just to make it as long as possible, and as Christian has said, you can use the attachment device if you want to have a multiplanar fixation if you require in the proximal area.
Good.
What will be the use of plates, the locking plate or the simple DCP? Which plate will be preferable?
In a 84, sorry.
I'll use the locking always for the distal. For the proximal, the locking doesn't really work, so it will be still cables.
Yeah.
So any technical issues about putting screws in the proximal segment?
Yeah. So this structure is relatively mid-shaft, so there is enough space for fixation. And also the stem is not wide, so there is a space for insertion of screw. But we can also use the locking attachment plate. I prefer the curved broad HB plate. This is a post-op X-ray using the percutaneous cerclage wire. Reduction was done, and then using the two leg screw, the fracture was reduced anatomically, and neutralization plate was applied. I usually insert more screw, usually 10 cortex each segment, but this case the fracture was reduced using the leg screw and two additional wire. I just fixed the 4 cortex proximal part, but it would be better to insert proximal part. Okay. Any comment?
May I ask the panelists if they are happy with the length of the plate that they would use for this particular fixation?
Yes, right. the length of plate.
Proximally, you have your fixation is almost ending to where the fracture was, the proximal circli. So,
as we said, that it's a pathological fracture. It's a treatment for me. It's like for any periprosthetic, it's like a pathological fracture for me. I used to extend it right up to the entire limb segment if possible. Otherwise, we are just shifting the fracture line from one place to another. And so we tend to put in as splint the entire limb if possible with whichever long plate which we can have. And regarding the cortical screw in the proximal fragment, if we see the lateral view, you can see that it's an uncemented stem sort of a thing where the posterior part you can get a good cortex. So if you put in your cortical screws, you have that leeway of going beyond and next to your stem into the posterior one or the anterior one, depending on the place where you are. And also near the trochanter region, if you just bend the plate, you can put in one screw going towards the trochanter, holding that as well. So you can splint the entire right up to the trochanteric flare, going up to the tibia, digging to the distal femur. And I said the banana plate, which is contouring with the femur shaft, many a times is quite helpful for us, with the cortical screws going adjacent to the stems.
Casey, I had the chance to peek at your slides. You had more difficult case to come, so maybe we can look at those.
Okay. So the length of plate a little bit short, but fortunately the fracture healed without complication. Let's move on to the next case, case 2. Female 81-year-old. She had a bipolar hemiarthroplasty due to the femur neck fracture. She got the periprosthetic fracture. Usually I check the CT. This is a coronal image of CT. And this is sagittal. And this is a 3D imaging. Looks like this. So this is a making for the stability is very difficult. So we already discussed about that. So evaluation of stem stability lacks objectivity and largely depends on the surgeon's subjective judgment. The main reason for failure of periprosthetic is misinterpretation of stability. Many fractures classified as B1 were in reality B2, but the processes should be considered as loose until the proven otherwise. But the surgical exploration and the stability test are a little bit invasive for this old patient. The sign, the high energy trauma with combination fracture shows the high chance of stem loosening. So another tip is the main, if the fracture is the main fracture region involves primary fixation area, it should be unstable. But if main fracture region is outside the area of primary fixation, it may be stable fracture. Another grid blasted tapered wedge stem, it shows the high instance of loosening due to the loss of 3-point fixation. So it most of the times fracture around the periprosthetic fracture, the stem will be loose. Here is the recent classification. This article presents the algorithm approach to identify the loose stem, taking patient history and the stem design and plain radiograph. So if the fracture is comminuted around the stem and a cementless stem, if it is intraoperative fracture, there is subsidence, major osteolysis, fracture at the level of fixation, and intraoperative loose stem will be loose stem. So this case is the fracture at the level of fixation and comminuted around the stem. So the stem should be loose B2 type fracture, right? So I'd like to ask the option for the fixation, fracture fixation or revision arthroplasty. How would you do, Chris?
This is a loose stem. So if she is a walker, I'll get the arthroplasty guy to help me. And removing this slightly loose, actually it's not all loose because the proximal part is well fixed. It's very difficult. So there's a chance I might just cerclage the wedge and just fix it. If the proximal part is not loose intraoperatively, I have to test it. And it's a very high chance by using just cerclage, a very long plate. I'll use a hook kind of plate that hooks over the greater trochanter for this fixation. So 82 years old, it's really very old. We don't want to do too much. So I would say 80% chance is a fixation, only 20% chance is a revision. But I will get the joint guy standby to help me.
Mm-hmm. Okay. So usually B2 prefer the revision arthroplasty, but it's more demanding to this old patient. Two important factor, patient physiology and certain experience is not reflected by Vancouver classification. Patient with multiple medical comorbidity may not tolerate the prolonged complex revision arthroplasty procedure. So the open reduction for RNF for can be proven to provide adequate fracture healing and avoid stem migration. And it shows a reduced surgical time and less complex procedure, reduced surgical cost, and avoiding the long stemmed implant could be benefit for younger patient. So I'm trauma guy, so I prepared fracture fixation. So we already discuss about that. I'll quickly show my procedure using the circulator wire. One is enough, so I add another circulator wire and using the broad LCP plate. And this is I add another circulator wire and the locking attachment plate. This is post-op X-ray and a 4-month X-ray, and 1 year X-ray shows the good healing without the stem loosening. So any comment? Comment?
It's great. That's what I would say, that as I said in the beginning only, the trauma surgeon and there is an arthroplasty surgeon, it's a conflict many of times to whom it goes. If it comes to me, in most of 50% of cases, we have done the same thing because the patient factors also play a major role out here. The same thing, the arthroplasty is going to have a different say to that.
We have short time left, so I'll quickly move to the last case. This is a 69 female patient. 3 years ago, she had a bipolar MER arthroplasty. The stem is polished taper stem, a cemented stem. So this is CT imaging. This is 3D imaging, just like this. So, how would you do? How would you treat this patient? I'd like to ask.
I request Dr. Fang to give a quick opinion on this.
Yes,
we are just 4 minutes into time.
This is still not the most difficult type to me. So the most difficult type is the simple transverse fracture just at the distal tip of the stem, because there's a biological component to those type. But this is nearing that type. This one is still more oblique, but there's a loosening of the stem. You see the crack in the cement. So the stem has to go. If you fix this, the stem is still loose. You fix the fracture perfectly. So it depends on the age of the patient. If it's an old age, low demand, we can fix the fracture, remove the stem, do a more simple cement in cement kind of fixation with a smaller stem. If it's a younger, more fit, I think she's 60 something. So tendency is to go for removal of all the cement, convert to a long stem,
plus something to augment the fracture. So a long stem plus a plate for me, a hook kind of plate.
Okay. This is a bit too, but many of you prefer the division arthroplasty. But polished taper stem are always loose since there is by design no cement process bonding and are thereby definition B2 fracture. Periprosthetic fracture involving cement mantle often result in an unstable stem, but the cement mantle is likely to be well fixed and may not need revision. ORNF with a plate for patient with periprosthetic fracture around tip of cemented tapered polished stem is a suitable treatment provided there is no bone loss. Fracture can be precisely anatomically reduced and adequately fixed. So I'm trauma guy, I prefer the fracture fixation. So this is my technique. First, I try to reduce the fracture using the circular wire, but it didn't work. So I need more reduction tool. I use a collinear clamp and add another wire was inserted. This is post-op X-ray. How is it?
Can I request
nice.
Vivek for a quick comment before we move on to the next talk?
Yeah, there is that fracture of the cement which is going to be causing a problem regarding the fixation part in most of the cases, but you still will have 20-30% cases which I have also done the same way, which have gone into union. But yes, it's a precarious thing, but depending upon the patient profile, we need to look at it and then proceed further with our experience and expertise. That's what I feel in these cases.
Yes.
Is this a polished taper stem or composite bead stem?
This is polished.
Polished taper. Then if it's fractured, the cement is fractured, you never can have a union of the bone because it's already loose. So if you want to fix it, at least you have to re-cement between the fracture of the cement. Otherwise, it will continue, the fracture will continue. And there's always a separation of the cement. And the stem going into the cement and the fracture never heals.
That's a great point. So may I request Professor Park to just summarize because we need to go on to the next talk.
Yeah, we start 3 minutes later.
Into a longer cemented stem. Otherwise, you will never get a union of the bone.
Okay, I missed this fragmented cement. So there is the defect due to the fragmented cement. And 3 months later, the subsidence stem, due to the defect of cement, here 1 year, more subsidence and the distal tip contact with the distal part. So, but patients want to remove implant due to irritation. So I remove the cement, the plate, and then the stem is the subsidence is stopped due to contraction. About the 5 millimeter subsidence. Here you can see the subsidence due to the defect of cement. So, and then after removal, she complained the pain again. Okay, look at this. This is insufficiency fracture occurred due to the stress concentration. And here you can see the insufficiency fracture. So how did you do? So then revised the revision and then healed, but 6 months later fracture again and another plate was applied. So this is polished taper stem. Cement, if the cement mantle fragmented deficient, the stem loose, recommend the revision. This is the list systemic review. The ORNF, if the bone stock is adequate around on cement, tapered polished stem with intact cement mantle and fracture geometry allowed stable anatomic reconstruction, then ORNF is preferred. Summary. Here, backward classification is useful and reliable guide, but ORI can be a valid treatment option for type 2B by B2. The key to a successful outcome is anatomically fracture reduction and to ensure the stem stability and avoid secondary migration processes. Thank you.
Great cases, Professor Park. Great cases, great discussion. So may I, for paucity of time, request you to unshare and Ismail to share his presentation on complex pelvic ring injuries. Thank you, Professor Park.
Okay. Thank you. So I would like to share my screen. Thank you, Mr. Chairman. I would like to share the case number 1, male boy, 11 years old, with the chief complaint pain on the left hips in fell from the moving trucks 7 days before admission, and no history of the lost consciousness. No, I mean 7 hours. This one 7 hours. Sorry, and no other injuries. And this the patient came in the hemodynamically unstable. So this we can see the blood pressure is 36/50. The heart rate is 133. The pictures of clinical pictures. So this is the X-ray. So we can see there is a pelvic fractures, unstable, I believe. So I would like to comment about what you done initially, because I think the different centers or different setting is different, maybe slightly different management.
May I request Vivek to take the question, and may I request Ismail to go back one slide, please?
Okay.
Panelists,
yes.
yeah.
So you want me to say regarding what happens in my hospital, or
yeah.
So
I mean on this case.
Okay.
Or for the initial treatment.
So if he is there on the right at the time of his injury and he comes to us, he is going to have his hemodynamic resuscitation done. It's going to be on a pelvic binder. We'll have all the classical ATLS protocol followed for him. He's going to have blood and blood products. I can see that his hemoglobin, and right now after 7 days, it's gone down. But the initial stages, look for blood losses at all the 5 places, put on a pelvic binder from our side right now, and assess for other blood losses from the various zones or the hollow viscus where it can happen. Once we are able to control that, then we go further and we are able to stabilize his hemodynamically, then we go further for stabilizing the definitive treatment for his pelvis injuries. That's how we go about it.
Okay.
And if you look at right now, at 7 days later, we see that he has got a lot of problems.
Yeah, I mean, sorry, Vivek, this actually 7 hours. I
okay.
Mistyped.
Okay.
Because the patient after there is a traffic accident, right?
Okay.
And then the patient bring to our hospital.
So as per the X-ray also, we can see that the left side is opened up. Both at the posterior side, there appears to be a crescent sort of a fracture, along with combination at his triradiate part as well as at the lower pubic rami. So he is going to have a compression injury on the left side, for which he is going to require some fixations. But still, based on this injury pattern, I like to rule out all the other bleeding sources which can be there, which needs to be taken care of first. From the pelvis, a binder will suffice in my hospital.
Okay.
If not, then we go further with the further procedures, which will be based on FAST and fixators if required. That's all.
Okay, thank you. And so this is the algorithm that mostly approach for initial treatment for the polytrauma and pelvic fractures. So this is the ultrasonography. The result is the minimal collection on the free fluid on the hepatorenal, like mentioned by Vivek, that we should search the other source of the bleeding. and then we do the transfusion, PRC, FFP, and thrombocyte. And then, like mentioned, we do with the C-clamp, yeah, for this case. We put the C-clamps. This the C-clamp insertion before and after the C-clamp, and this the CT scan that done after the C-clamp insertion. So this the 2D CT, and I think before we talk about the definitive treatment, I think we should identify the problem in this patient for this boy. Yeah? This boy, 11 years old. Maybe I would like to comment, yeah, from the panelists or moderators.
Can we go back to Ismail? Sorry to interrupt. To a projection of X-rays or CT where it can
2D
be
or 3D?
Maybe a 3D. Yeah.
This one, maybe
picture specific one. Help
yeah,
the panelists to decide.
So can I comment for acute? So this boy is lucky. 7 hours, he's past the golden hour. The first hour is the most dangerous, but he passed that, fortunately. So the three big source of bleeders are the chest, the abdomen, the pelvis. So he is lucky not to have a chest and an abdomen problem, only a pelvis problem. And then for the pelvis, the speed is actually all the thing. It's not about the bone. So the binder is the first thing you can immediately do. Giving blood products transfusion, including fresh frozen plasma, packed cells, and also platelets. Three things at the same time if the hemodynamics are crashing. But he's a boy, he's got better reserve, so that might not be needed if his BP is stable. So do all the immediate things first, and also we'll give transamine. Transamine is rather cheap, cost effective. And then consider the second things. The second line things are things that can be done in hours. So C-clamp, the angioembolization, and also the external fixator. This can be done within 1 or 2 hours after arriving. But all these things are complementary, should be done together. And all of these things should not block the way of other things happening. So if he's got a bad chest or abdominal bleeding, those things will take priority over the second lines of treatment.
Great point, Christian. I think the patient is now stable with the C-clamp on, and I think, would you like to attempt to try to diagnose and classify this injury now?
Yeah.
Would either of Christian or Vivek volunteer classification of this one?
This is a ring injury. I think it's the APC kind of fracture. You can see on the X-ray already that the pelvis is open up, externally rotated both sides. So it's an open book kind of fracture. So closing the book is very important. I think Ismail did a great choice to use a C-clamp because most of the opening up is from the back. So the C-clamp gives you very excellent control of that. And the binder probably is not put in tightly because a well-placed binder will give you a very good compression effect. Actually, the binder is nearly as good as C-clamp in most of the situation.
Hi, good afternoon. This is Adele. May I ask a question?
Yes.
Please. Dr. Ismail,
yes.
Your patient is quite blessed because you have a C-clamp in your hospital. In the entire Philippines, there's no C-clamp. So if you don't have a C-clamp, what would you do instead?
Oh, okay. So yeah. So we should this depositorization, right? Like the crescent fractures, yeah. So the crescent fractures, so fracture dislocation of the SI on the left. So it means LC type 2. So there is posturulation. We should we should closing, yeah, the posture relation. So that's why if we did not, after we resuscitate, give the platelet, and then hemoglobin, I mean the PRC, and also the FFP, yeah, I think we can do it look like the C-clamp is we can do the screwing, yeah, ilosacral screw. Ilosacral screw also the one of the advantage to do the closing that one. But we have done before the C-clamp, we have done the pelvic binders. So we can see with the pelvic binder, it did not really work, right? So the heart rate and also the blood pressure is decreased, the heart rate is increased. So that's why before we definitive treatment, we do the C-clamp for the damage control, yeah, in.
May I take a very quick yes and no kind of answer from the two panelists, Vivek and Kristen? What would you do in your setting? Would you do a C-clamp or would you do something else? Just a very quick reply so that we can move on.
Yes, I will do a C-clamp.
Great. Vivek?
We do 100 cases per year, all with pelvic binders, period.
That's fantastic. So it depends upon probably on the kind of setting that you're working in and the kind of patient profile that we have in the hospital armamentarium. And the other thing which I would like the panelists to quickly comment on is your diagnosis. Do you think it's an LC2 or does anyone think that there is a contralateral pelvic injury as well? There's an SI joint opening on the previous X-ray. This might just be an LC3.
I don't really use the LC or APC or whatever. The only thing important to me is whether the pelvis is external rotated or internal rotated. For this case, it's external rotated. So it's an APC to me. You have to close the external rotation. If it's an LC, it goes into internal rotation. It's not hemodynamically that dangerous if they fall on the side. Okay. So that's the differentiating factor.
It's as I said in the beginning, it's an LC fracture. It's a crescent fracture we could see, and because the fracture of the crescent is quite back on the PSIS region and it is involving most of your SI joint, that's why we can see that the entire hemipelvis has gone into external rotation because of the sacroiliac dislocation.
Yeah. Ismail, can you put the pre and post reduction films post your C-clamp? The one, yeah.
This one.
Yeah.
Okay.
For the benefit of all of us, just explain what Vivek is saying. No, the other one that you just showed. Yeah.
So if you can see the posterior part, you can see a small flake of the posterior PSIS, which is separate from the hemipelvis at the SI joint region. So that's the crescent which you can classically see here, even in the AP view because of the external rotation of the hemipelvis. So yes, there is an external rotation of the hemipelvis, as Christian has said, but it is because of the sacroiliac dislocation partially with the crescent. And the fracture at the high pubic rami or the superior pubic rami is also a slight oblique fracture, which also signifies that there is a lateral compression injury. And that's why I would say that this patient is stable after 7 hours also when he was shifted from one side to another, because he did not lose that much amount of blood in the initial 1 hour. And he's been able to survive the initial 1 hour of his injury pattern.
Absolutely, agree totally with both of you. Got a point. And anybody would like to quickly comment on the contralateral SI joint? If you see the one X-ray on the left and the one on the right, there seems to be a closing post the C-clamp on the X-ray on the right, as well as if you see the symphysis, it seems to be much better aligned post C-clamp. So, does it make a case for the contralateral SI joint opening as well? So making it a bilateral pelvic injury, maybe in LC3. So just a quick comment from Vivek and Kristen on that.
I would say it's an 11-year-old child. So many a times the 11-year-old pelvises look like this. What I will do is that when I'm taking him inside the OR, I'll do the fixation of the lateral side of the left side, and then maybe do a stress view to see how much opening is happening at that time. And if required, I'll put in and fire in a screw. Else I'll leave it, because in an 11-year, many a times we get this feeling that that's an opening up.
Absolutely. Kristen, would you like to add something?
One thing is the pelvis is displaced to the back, so it's not really LC. So you see the left side, the hemipelvis, the ilium went to the back. So you can't use LC or APC to classify that kind of thing.
Great, true.
And the reduction, you have to reduce that posterior
Yeah.
displacement.
Yeah. So maybe go ahead, Ismail, on this.
Okay, thank you. So in there is crescent fractures and also SI joint disruption and pubic, pubic rami, superior inferior of the left pubic. So we can see not only there is fragment of the crescent, but also we can see the ilium is going backward, going backward. So like iliac wing fracture, the crescent fracture consists of the first one is the ligament disruption of the inferior part of the SI joint, and also there is posterior SI ligament still attached to the crest fragment, and fracture of the posterior ilium, and the combination with the anterior pelvic ring injury. This type 1, the joint involvement is less than 1/3. So the fracture line is enter the joint close the S2, and but type 2 is the 2/3, and the fracture line enter joint between S1 and S2. And for the type 3, joint involvement is more than 2/3. So the fracture line enter joint to the posterior and superior to the S1 foramen. So this is the picture of the type 1, type 2, and type 3. So before we strategy to do the fixation, how about is there any difference between pediatric pelvic fracture and adult in the management, or in the doing more conservative or operative or whatever?
May I request Christian to take this, please?
I will honestly answer you, not enough experience to tell you. There are too few bad pediatric fractures in my place.
Yeah, that's true for any trauma center. I would say that pediatric pelvic fractures are quite rare, or the bony injuries in them is quite not appreciated so much because of the profile of the bone morphology in a pediatric patient. Normally, most of them will be fixed or managed by as minimal surgery as possible. So you can get away with the K-wire or with one screw and putting in a binder or a fixator. Getting in and fixing them, as we do for a pelvic injury in an adult, may not be so functionally helpful for us in a pediatric patient.
The best guideline we can follow are the adult ones, so still the same.
Yeah. So this is the unstable, and also this one is I believe all of you agree that this one unstable pelvic fracture, right?
Yeah.
Yes.
So we have to discuss how should we fix the crescent fracture and SI disruption. What is the position, surgical approach, and internal fixation that we should use for this patient?
Ismail, if I could just barge in between, sorry. Can we just go to what you did and take a comment from the faculty, because we're just 10 minutes. And
okay, this one. So we can see because of the risk of the ilium is going backwards. So we do it in the prone position, and this the type 2 of the crescent fracture. So the first thing to do, we do the open reduction and then screwing of the fragment, crescent fragment, and then follow with the iliosacral screw from the prone, and then we go to the supine, and then we do the pubic screw, retrograde pubic screw without violating the epiphyseal plates. So this that we have done. So we try as minimal as possible, and because the patient still have the epiphyseal plates, epiphyseal groove plates. This we have done.
Great job. May I request Christian to comment on what you would do in your setup in this case?
Is great. One thing is very difficult is reducing the SI joint step. So there's always a step that the sacrum is overriding, and you want to bring the sacrum down to the level of the ileum. So one thing that helps is putting a plate on top of the sacroala and trying to compress it down to adjust the level before putting in the SI screw. I find that a very reliable way. Even in the old cases, like 6 weeks old, you can break the SI joint, and then whatever unlevel you have, use a reduction plate. I usually use a 3.5 DCP for that, just a 2-hole or a 3-hole.
Okay, Vivek?
Yeah, same, it's a nicely fixed thing. You can go as Ismail has gone prone and then supine, or as Christian is saying, you can even go anterior first, or with a shank spin, you can just lift up the pelvis and correct the SI joint dislocation part, which will be right in front of you with a plates, and fix the pubic rami. In children, the remodeling still happens, and you will find that if you just follow up these cases, because some of them in our setup do go conservative, and when the pubic remis and the things go conservative, we have seen over the next 3 years or 2 years follow-up, you will find that most of them have very nicely remodeled as per their children's age and the pattern and the growth spurts which are remaining.
How about the implant? To reduce. Implants is fine. It's very important to reduce, because once you have reduction, you have a good channel for the SI screw. If you don't have reduction,
so that's a very important point to make here, that reduction is the key. You can use joysticks and actually, as Kristen said, put in a plate to reduce the SI joint and then do your definitive fixation.
Yeah, so
I think we're just 6 minutes to time. So if we can wrap up this one first and take a very quick second case, if you have one, or we can finish this.
Okay, thank you. So this, the key point is we have the type 1, type 2, or type 3. So because this one is type 2, so it should be on the prones and fix the fragment. And this the tachyphylaxis for the crescent fractures. This approaching based on the type 1, type 2. Type 1 and type 2 usually type 1 and type 3 is the supine usually, and then for type 1 using the plating, sacroiliac plating. But mostly 60% we can do ilosacral screw for the crescent fractures. So for the type 3, we treat it like SI joint dislocation. Whether is there any sacral dysmorphism or not? If no, so we can do it the ilosacral screw. But if there is, so we can do with the anterior sacroiliac plating, or in the special ilosacral screw in the mid segment. And this the removal should be after 3 or 6 months after the surgery to prevent growth arrest. This is the case number 2, male, 43 years old, with pain on the pelvic and left hip region, 2 days. The hit by car while riding a bike, struck, and his left is struck on the, and his left hip is go to the pedestrian road. Afterward, patient feel pain on the pelvic. Patient could not urinate after accident. From the previous hospital, diagnosis pelvic and left proximal femur, and also the bladder ruptures. So done laparotomy and repair of the intraperitoneal bladder ruptures. So this one, the leg length discrepancy is 1 centimeter. This is the pictures. The picture epi inlet outlet. So there is sacral ally fractures, and also the pubic rami right and left. This one, the CT scan, we can see the sacral fragment is displaced, and there is vertical displacement. We can see from the leg length discrepancy, there is 1 centimeter vertical displacement, and some comminution in the ilium and the sacral. So again, so on this case, I like to comment for the fixation. How about what do you choose for plating or iliacal screw?
You need to put a picture for the panelists to kind of refer to.
Okay.
And I think you'll have to move with what you did and then ask the questions, because we're just 3 minutes to time. I don't think we have time to finish this.
Okay, I will.
Just the final X-ray will be great.
Yeah.
Yeah.
So this one, because the patient previously done for the laparotomy for the bladder repairs, so I using the STOPA approach that used by previous surgery, and with the lateral window. So for the right side is I little bit open up little bit distally, and the first thing to do is we do with the plating of the ilium, ilium of anterior sacral, and then follow with the iliosacral screw in the flat fashion transiliac, S1 and S2, and for the pubic rami right and left, so we do it with plating, anterior plating. This is the picture.
Ismail, can I just request a quick comment, 1 minute each from Christian and Vivek?
Okay, I will done almost the same. For the front, I will use plating. You see the front has a comminution, so bringing that fragment up will help you reduce. But from the back, it's very difficult to reduce the back from the front, because there is this step, unequal level of the SI joint. This is like a vertical shear kind in the back. So I would flip the patient prone, go to the back, and see the reduction, do an open reduction from the back. Whether there is neurological injury or not, it's not my concern, because based on statistics, 50 of them will recover 50%, no matter what you do. So the backside, you can either use a bridging kind of plate, or my preference is to use the pedicle screws, the very long pedicle screws. Use the S2AI approach from the sacrum through the SI joint to the ilium. Usually you can put 1 or 2 90mm screw and then bridge them with a rod from left to right side, plus or minus another SI screw. So that's my preference for the back.
Great. Vivek, any finishing comments?
No, it's nicely done. As I said, as Christian has also said, there are various ways by which we can do for a SI joint or a fracture which is involving the sacrum part of it. I prefer to go prone, reduce it, because I have more options with me of putting in, as he said, the pedicular screws. If say the vertical shear, which I cannot control with the spinopelvic, with the transiliac plating and the iliosacrals. So options increase for me. So I tend to go prone first and then fix the anterior part, which is also essential in this sort of an unstable injury, where just posterior may not help alone. You need to fix the anterior part as well to give an adequate stability to the pelvis entire.
Great point, Vivek. Very important point, because anteriorly you have a tilt fracture, you had a bladder injury as well. So it's important to go anterior as well. So fantastic case, Ismail, but I'll request you to, I think we'll need to close this and go on to the next talk.
Yeah, there's another, this one.
No, I don't think we have time for another one, Ismail. Yeah. I think we'll have to go forward.
Okay.
Thank you. Great case.
No, I mean, yeah.
Yeah, so I think we need to unshare.
Okay, thank you.
Yeah, I think we've discussed this, and it's a beautiful job, very complex case, and I would request Abdul to share a presentation on acetabular fracture.
We'll request APOA to give us another day for pelvic.
Absolutely. Sure. 30 minutes is not enough time.
Moderators can send that feedback.
We have a program completely on the acetabulum and pelvis.
Oh.
In I think Marinus, is it in Jan or Feb? Well, he's not there, but it's either Jan or Feb, the whole 3 hours.
Okay. I didn't know that the in charge was here also.
The people stay in the background.
Right. Sure.
Hi, good afternoon. Can everyone hear me and see my slides?
Yes, absolutely. Please go ahead.
Okay, hi, good morning, good afternoon, or good evening, wherever our participants are. And thank you very much to organizing committee of APOA and Asia Pacific Trauma Society for the kind invitation. Thank you, Christian and Marinis, for believing in the work that we do. So I have nothing to disclose, no conflict of interest. And I would like to acknowledge the following people who have contributed to the cases that are going to be shown today. So my objectives for today is to present cases and indications for surgical treatment of acetabular fractures. I was asked to give the more complex cases as if acetabulum fractures is not complex in the first place. So, and to understand the choice of surgical approach for acetabular fracture. A few slides to discuss some parameters. So who needs surgery? Most displaced fractures will do better with operative treatment, but also it's important to identify some fractures which may be amenable to non-operative surgery following some recommendations. So factors for the patient and for the fracture itself. So we analyze the location, the degree of displacement, how big is the fracture fragment size, and the stability and congruence of the hip. More than classifying what type of fracture based on classification, it's more important to analyze which of this is needed to be addressed to provide a stable and congruent hip. Basically, classification, when the young colleague calls me, I don't ask them for classification. It's always an, oh my goodness type of fracture. So fracture evaluation, you need a complete set of radiographs and computed tomography to be able to identify the injury pattern and the fragments so that you can plan the surgery. First case, a 74-year-old male, very active, no medical comorbidities, crashed his motorcycle on the national highway, immediately brought to a local hospital, which is 400 kilometers south of Manila. No other no neurologic injuries, stable vital signs. He was just observed in the previous hospital and then eventually made arrangements to be transferred to our institution at day 5 for further management. So he had to travel by land for 400 kilometers for the definitive treatment. Inguinal area, this is how it looks like, just a lot of hematoma. However, we saw deep laceration at the level just above the knee, and then abrasions on the elbow, and then abrasions on the hand, and he also has an injury of the 4th metacarpal neck. So this was what was sent to us and what was done upon arrival. So like I said, it's an oh my goodness type of fracture. So what can you say, guys?
OMG.
Perfect. Actually, there's nothing else which you could do. Yeah, so can we start with Vivek, please?
Yeah, so that's a really, really complex fracture to have. And I would say that it involves all the various factors which can lead to a bad prognosis for such a fracture pattern. You have the acetabulum, which is broken into 2 or 3 parts, mostly on the interior and the quadrilateral plate region. Along with that, you have the neck fracture and the trochanter, which is separate. So you really need to think with the patient evaluation, how and what you are going and what you are going in for. Is it a salvage of the femur head or the hip joint, or you are making a ground for the next stage surgery, which might be there also. So that is here. We have to be knowing that this may not be the best of the treatments, and we have to explain to the patient because he has 2 major factors on either side of the hip joint. As regards the acetabular fracture, we can see that it is the posterior side appears to be relatively ilioischial looks to be okay, not that much displaced, but the quadrilateral plate and the anterior part are broken into segmental. So the quadrilateral plate is gone inside. Along with that, the anterior dome of the acetabulum has also gone there. You need to go in. I don't think the reduction is going to happen just like that because the neck is fractured. So you will have to go in. It's already 5 days. So it's a tough job. And you might have to go posteriorly first to reduce the neck and then see further. With investigations, obviously, we can plan it out further with the CT scans and then decide.
Christian, any initial thoughts?
It's an elderly 70-something, so replace, definitely. We are not going to salvage this for me. It's not possible under my hands. So the question is replace now, replace how much? I actually want to ask the other experts like Casey, Takashi, and how would you replace it also?
Thinking of this patient age and this combination, I prefer primary total using the femoral head as a bone graft to reconstruct the acetabulum.
Great point. Would you like to do it as an acute total hip, or would you like to wait and do a delayed total hip after reconstruction of the columns?
Do it acute phase in a few days. Not an emergency, but in a few days. Primary total hip. I don't wait because this is a geriatric patient. If I wait, then he will not be able to return to work. So this is not an emergency, but in some days after arrival of this patient.
May I request a very quick comment from our other very eminent speakers, Professor Dr. Sen and Professor Park, please? A very quick comments, please.
I'm the same opinion with Professor Sawaguchi. Yeah, this old patient, the replacement is better options. It's not an emergency.
Yeah, yeah, my perception is that eventually we know the outcome is not likely to be good. So I think the first thing will be to get this head out of the area and to have the stability of the anterior column. So I might place it in 2 stages. The first stage, I'll just stabilize, go inside and stabilize the anterior column. Posterior column seems to be okay and will settle down. And at the second stage, probably I'll have a good ground to have a replacement done, as Takeshi said it.
So more or less, all the eminent speakers agree that this essentially is going into a replacement. It's just a matter of planning it as to when the second stage would be needed, very acute or slightly later.
Yeah, posterior column plating is most important also.
I have a query. In some situation, can it be treated when the facilities are not there? Can it be treated like a girdle stone?
May I request Christian to take that and Vivek to take that?
Yes.
I think it's a socioeconomic statement as well.
Yes, I think a lot of this depend on your hospital support, how much. For me, I can bleed a lot and not kill the patient. I'm a very bad surgeon because the anesthetist will support me, the ICUs will support me. But doing this kind of surgery is not possible in every region. So what if it's a 20-year-old gentleman having a very same injury? So maybe it's done very differently in different regions. But to me, even if he's 20 years old, this is far too bad. I will still be going for a total hip. So it all depends on how big surgery the patient can tolerate. So either 1 stage or 2 stage, these are all fine. If it's old, then girdle stone, yes, that's a very good option, I think.
Vivek?
Same. It can be done if we have the options and the facility where we are working.
Absolutely great point. May I request Abdul to please go on now?
I think
thank you very much.
The Girdlestons is not a great selection for a mobile 76-year-old, because unless the medical comorbidities are too complicated, once you get the infection under control, then providing some length and stability is an appropriate sort of way forward, I think.
Great point. Excellent point. Yeah.
Okay, so moving on. So Marinis was right. We needed to take care of the infection first. So the patient underwent debridement arthrotomy for the knee because it was infected, and we had to control the infection. This is the CT scan, 3D, and all the opinions of our expert panel were discussed by the team and with the patient. They were all considered, and then on day 19, because after the clearances and the infection was controlled, this was our plan: one sitting approach through the anterior intrapelvic or modified stapa, and replace the hip in one sitting, because to get the one who will replace the hip will be a colleague, not me. I know which battles to fight. I'm a trauma surgeon, not an arthroplasty surgeon. So we did it as a multidisciplinary team. And then we have the support of anesthesia and even vascular surgeons, because we had, we call them if we run into problems intra-op. So these are the problems of the patient enumerated. We did the anterior intrapelvic approach, planned to do additional lateral window if needed, but it wasn't. But this was what I highlighted: reduction, because when I saw it inside, after controlling the bleeding from, because the anterior column fragment was right, very adherent to the iliac vessels, and the quadrilateral fragments was very adherent to the bladder. So we cannot do a good reduction by just pushing on the fragments to push the femoral head out of protrusion, no matter how much we tried. So we had to resort to plan B, and had to start with arthroplasty to remove the head, because we tried to put a shank spin in through the lateral to get to the neck and head, but it couldn't be done. And then, so we proceeded with the arthroplasty. We also used the femoral head and another femoral head from the bone bank to mill the bone. And then using cage and cup, we were able to put it back and repair the greater trochanter. So it was one sitting. And then with stabilization, testing for the stability, everything was okay. We tested inside through the anterior intrapelvic approach. It didn't need any fixation from there. And like I said, in our situation, the patients pay for the implant, and you need to choose which one will give the patient the maximum benefit for what he needs. And then this was deemed stable. And this was at 2 months post-op. It was the surgery happened during the time of the start of the lockdown in March. So we were communicating with the patient through online messaging. And then this was 8 months. We were, if you look at this, we were quite concerned with this. But the patient is not, is walking quite well, not feeling any pain. So we just discussed with him. We'll just continue to observe. He's not working anymore. He's retired already at 74, but is just very active. And he still plans to ride his motorcycle, I think.
So may I request to just go back to your post-op X-rays? Yeah. So may I request both Vivek, Christian, and our eminent faculty to just a quick comment as to their take on this particular X-rays and their concerns, and what would they do anything differently? So may I start with Vivek, please?
As she has already said that they could not put in the quadrilateral plate and the fixation was not there. So regarding the cup part, I would say that it has been done in her situation. It is okay. And trochanter, maybe the trochanter is one area which I feel I could have had a encerclage or a small fixation specifically for the trochanter, which would have held it. That's the thing. Did with the good allograft and the autogenous graft which has been there, the body and the bed, because the good part out here was that the posterior column was intact, and the entire posterior column with going up to right up to the iliopectineal eminence or around it was intact. So you had a good chunk of the entire posterior column where you could stabilize your head. You could have used cementless also, but economic constraints do matter. And using an autogenous graft continuum or some sort of a cup with 70% uptake on the cup on the acetabulum will suffice for this. Trochanter is one area where I would have got an additional fixation.
Okay, Christian, any additional comments on this?
It's excellent. So excited to see this case. And actually, the cup cage construct is a very beautiful thing. It's just a big plate. If we trauma surgeons see that, it's just common sense to put big screws. So for me, the flanges will impinge on the outer wall of the superior acetabulum region. That's very stable. But then what I'll do differently is to put one big screw down the ilium, another big screw down to the ischium. So that gives you a good fixation to the free parts of the pelvis that prevents sinking in of the cup. So everything holds from outside. So that also gives you the chance to not require a stopper approach to go to inside. So just one single approach from outside would do. This is because I observed the joint guys doing the revision arthroplasty for pelvic discontinuity. So that's how they do it.
Exactly.
Okay, Professor Park.
Can I give
Dr.
comment?
Sen? Yeah,
Can I
sure.
comment?
Please.
Yeah. So if I will do a little bit differently. So I agree with acute primary total hip replacement, but first thing to do is posterior column plating, because we can see there is the displacement of the posterior column fractures, and then also bone graft, and the follow with the total hip replacement. I okay with the kids, it's okay, but we can also with the also graft with the hemisphere components, with the cementless cups. And
Okay, so
the most important thing is the greater trochanter. We should do the tension and band wiring, and the stem should be distal fixation, not standard stem. I will do different like that scenario in my approach.
Okay, so you want to fix the trochanter and you want to add first fixation to the posterior column. Professor Park, one very quick comment. We are running short of time. So 1 minute for a comment, and then we'll take a comment from Professor Sen and then move on.
Yes, to differently, I applied the hook plate on the greater trochanter area, and I also I'm not a joint replace surgeon, so I'm not familiar with the total arthroplasty, but to the hook cement.
Sure. So you'll add
yes. Okay.
fixation to the greater trochanter.
Yeah. Hook plate.
Dr. Sen, sir?
Yeah, my perspective here is this is a young patient, and in younger patient, a cage lying in that area is likely to give a problem after 5 to 6 years.
Absolutely.
And that is my perception will be that I have to put a uncemented cup here. And for putting uncemented cup, I have to reconstruct the anterior column also. And that is my perspective that in the first stage, I'll construct that, posterior being okay. And when the patient's little settled, I'll go for arthroplasty with an uncemented stability, because posterior is settled, anterior I have settled it out. I can settle down on that side of it. So I'll try to avoid a cage in a younger patients in this kind of a situation where I can do very well with the uncemented cup. That's my rest of the comments are already given.
And any particular choice of implant, considering that you have a greater trochanter fracture as well?
For the hook plate, I'll try to use a hook plate on that side, or I can use that kind of a fixation along with the trochanter as such.
So the important take home that all of you are saying is that one, we need some stabilization of the columns before we decide to put in a hip so as to prevent migration of the hip later on down the line. And the second thing is that to give adequate stability to the abductors, you want to be stabilizing the greater trochanter so that you don't have run the risks of dislocation and other things later on. So may I request Abdul to just go on to the
Distal
next.
time also. Distal fixation
so-
also very
okay.
important.
No, just the next slide, please. So we see some amount of migration into this particular hip. Your next, the X-rays where you said it's a matter of concern. Yeah.
Yeah.
So, any quick comment, Kristen, from what your take is before we finish the case?
For the acetabular reconstruction, you have to fix the autograft for the anterior column reconstruction. And also for the reconstruction, it's better to use the Kilbrew type plate that has a hook in the fovea and the large plate on the superior side, and that supports the cup. And all the reconstruction should be autograft. Otherwise, union you cannot expect. But if you use the autograft from the head, they will unite within 3 months, and the cup will be very stable. And
Any comment on this particular X-ray, Dr. Savaguchi?
I think we need to use a hook plate.
All right. So may I request Abdul to go on with this case because we just have time for a quick another one.
Yeah, thank you for your comments. The hook plate was contemplated, but it wasn't readily available in the Philippines. So this was for pelvic discontinuity. This was a primary pelvis discontinuity. So normally we get good radiologic union with discontinuity, and the patient is quite satisfied with what we have done. So the second case, we'll just do this fast. The patient is 39 years old. He's a heavy equipment operator, had an accident at the site of work. So a metal sheet allegedly fell over the patient. No head trauma, no loss of consciousness. Patient was stable, rushed to a local hospital, probably 40 kilometers south of Manila, and eventually transferred within 24 hours to a government facility. So this is what we initially saw. There's a 4-centimeter laceration over the right buttock area, no active bleeding, no signs of infection because it was still early. So this is what the X-ray looks like. Can you guys see?
Not very clear,
Yeah,
but maybe you can just go on and.
Yep, I will. So this is how the CT scan looks like. Some of the choice cuts, some of the transverse and sagittal cut and coronal cut. So this is how the 3D looks like. Anterior wall and column, and going into the posterior wall. However, the posterior column is undisplaced. And we were having a discussion if it were complete or an incomplete fracture, but at least it wasn't displaced. So he was admitted to the surgical ICU under general surgery for 5 days, fast positive, but not needing any intervention. And then when it was resolved, the patient was transferred to orthotrauma service. So the challenge in the Philippine hospital setting, because it was a less complex fracture, but a different challenge to us because implant costs in a government hospital, patient has to apply for a special grant from the government charity services, and the waiting time average is 2 to 4 weeks. We're trying to work it out to make it faster, but it's bureaucracy. So meanwhile,
what you did, Abdel, there are just 4 minutes left. Now we can take the House's comments.
Okay. So this is what was done. So after the 6 weeks was the waiting time. I had to call another trauma colleague to help with the case. So we attempted a reduction of the anterior column, and this was what we saw we used the anterior intrapelvic approach, and on testing it was stable, and this is what we did.
May I just request Christian and Vivek to comment on this?
So one comment is very nice, I think, but difficult. I know it's really difficult. For me, I 3D print every single acetabulum fracture I do. I wait for 1 week sometimes, or 2 days, because I have the printer in my hospital. So printing it out really helps you judge where is the fracture line to fix it a lot. And these 3D printers are not expensive. You can send the files to printing shop and they will send it over. The desktop printer works. You don't need a medical grade one, and they can be sterilized by various ways. So that's my only comment.
Vivek?
Yeah, it's a nicely done thing. It's a high anterior column. You can say a fracture line going up to the SI joint. So if you use the 2 windows of ilioinguinal also, the lateral 2 windows, you can see the entire fracture line of the sciatic buttress, and you can fix that. Maybe 1 or 2 screws going up to the SI joint, you can put in your plate towards the SI joint as well, because that's where the hold you will get in the sciatic buttress region. And if you have used the STOPA or intrapelvic approach, the posterior wall fragment which you were feeling, or whether undisplaced or fully fractured or not, your screws from your internal pelvis can also hold that fracture, because it's not a much displaced one or a mildly or a complete fracture. So your one of the screws could have gone holding that also if you are using an intrapelvic approach. So that's one thing which we could have done.
So
Very nicely done.
Anything you would do for the posterior wall fragment, Christian?
Sorry, the posterior wall is a big trap. Yes. So many of the fractures, you see all the anterior displacements, but you leave behind a posterior wall, which leads to posterior dislocation of the hip. So it's a trap. Have to look at the CT very clearly. Posterior column is fine to fix from anteriorly with a screw, but posterior wall, if it's displaced, always require additional posterior approach. This one is not a posterior wall, so I think fixing from anterior or just leaving it like that is fine.
Yes, a lot of the wall fragments associated with these complex and high anterior column fractures, they are basically not very displaced. So you can put in a C-clamp, and from the front you can target and put in a fixation into these columns. They reduce well and they fix well. But if you leave them unfixed, they will leave a step in the dome area, which might predispose to hypertrophic arthritis. Yeah. So Abdul, may I request you to please carry on and finish your presentation now? I think we're almost cross time.
Okay, so we did this anterior intrapelvic approach with the lateral, or the first window of ilioinguinal. We were, if it was done acutely, the posterior wall would have been addressed, but it was 6 weeks after. We just tested intraoperatively and it was quite stable. So I will just, there's one more case, but I will just jump to my conclusion due to the lack of time. So what we do in the operating room, I always bring, I don't have the 3D printer, I bring the pelvis model, wrap it in sterile plastic, and it serves as my guide in the preparation of the plate with minor modifications. So as a take-home message, most displaced acetabular fractures will require reduction and fixation. Hip stability is the main indication for internal fixation. So the location and the displacement must be considered. The approach will depend on the associated, pattern of injury, and associated injuries may have to modify the approach. And most especially for us, we need to adapt to the local situation and what the patient needs while still following the principles of management for acetabular fractures. Thank you. Thank you very much for the opportunity.
Great case, excellent job. And may I request you to unshare now so that we can go on. And I would request Professor Dr. Sen sir for his talk on Pipkin's fractures.
So good afternoon and good evening. And before is visible?
Very clearly visible, sir.
Okay. So I'm to present the cases of femur head fracture, and before that I wish to be excused from both Marinis and Kashi, as well as for my Indian friends, because in my series there are some cases which as always make you to feel about it, to think about it. So they have seen, and Takeshi, because he just saw last month in Argentinian meeting also all my cases. So these are one of them. So out of those 140 cases, there are some cases which really are interesting enough. So I'm showing cases basically which relate to the articulation of the femur head as such. So there are 3 cases. I'll go with the simple. First, I'm focusing, bringing everybody to this 4A or 4B basically. I'm coming to 4B, but 4A and 4B just means impaction fracture and a sleeve fracture of the femur head as per the Brumback classification. As far as indentation is concerned, we have seen the recent literature does say that we need to disimpact it or put some graft kind of a thing. But in our the experience with this 4 years, 5 years, 8 years experience, there may be changes coming up, but these are the 2 cases which I can show. But right now my emphasis is on a sleeve fracture, where one case I am showing a 7 years follow-up, and you can see in that X-ray also down there a small sleeve which initially was not visible but was not really taking a lot of the load, and it is at its own place. My present case is this one, where you can see on the X-ray a fragment which has come down, a fragment which has come out of probably this place as per the X-ray is concerned. And this is the situation. The CT scan says, you can come down to the side, a total loss of the articular surface in this. You can see it anteriorly also going, and when you have got this reconstruction, you see the fragment coming down here also, and probably a loss from this area. So that is the concept, that it is primarily a kind of an injury in the osteochondral area, and that's a weight-bearing area, and that is the issue. And this was the operative finding. Now here we can think of it, because you can see the whole fragment is in my hand, which came out of down. I did this thing dislocated, say surgically. I had seen this treatment being given, in which this was a paper where they have taken the graft from the femoral condyle to put into this kind of a defect. And that is what is probably supposed to be a standard kind of a management in area. So my question, the question could be for the panel, what should be done in this kind of a situation when you have got this kind of a defect primarily in the superior area?
Question?
Primary, so fix it. The patient is 24 years old. I'll fix it with free headless screw, like what you did. Or if it's just a cartilage flap, I would use PDS suture lines arranged in a triangular pattern, pull through. So it depends. If there is some bone, use screw. If there's no bone, it's just a cartilage flap, use PDS sutures.
Okay. So because in one of the earlier cases where that fragment was totally crushed out, I took a part of the inferior part of the femur head and brought as a graft and put in the superior part. But in this case, this was reasonably okay, and I could get it back to the place. And that way I could get into the area, and this was the fixation. I actually lost one of the K-wire inside while I was holding this thin fragment over there, so that I did not really bother about it. Rest, you can see the headless screws which are going over there. And this was the kind of a situation. So I was doubtful about how this is likely to behave when it is likely to be loaded. So I delayed the loading also to about 2 months. I did not permit any loading of this hip. This was the MRI which I took about after 6 weeks. This is after 3 months. I was a little doubtful about when you see a little kind of a eccentricity and the loss of sphericity over that area. But at this stage, I had already started partial weight bearing to this patient. This is 6 months. And at 6 months again, he was not really fully weight bearing, but he had a difficulty in walking around because we had delayed it for a sufficient time. But you can see that there was a situation which was okay. And then this is his 8 months follow-up. If you look at it, the abductors are definitely weak because we have not been able to put it in. This was the X-ray, which is not very bad. And if you look at his gait as such, he has come up to this level. So maybe we are still clear. He doesn't have any pain. He doesn't have any symptomatology. This is the last follow-up just at the time of the lockdown when he had come. He has not come subsequently. So now this is the situation right now. I don't know what is likely to happen with this thing. So he can sit, he can squat. We have asked him specifically to make this kind of a sitting so that he doesn't have any restriction in the range of meeting and in the range of these things. So my perception was that an osteochondral flap, as Christian has already said about it, these flaps can probably settle back. I don't know what will happen to the cartilage over that, whether it will get back, especially delayed loading could be one of the ways to prevent till it is relatively settled down. And probably we still have to monitor how it subsequently behaves when it is loaded. That is what I perceive about. Any comments?
Dr. Vivek?
Yeah, I think that it's a nicely done case, and the options which are available to us are this. We have seen some of the European people putting in a fresh allograft, which is fresh frozen to them straight away. But those facilities are not so available in our places. We have taken allografts, cartilage, and fixed them, but it depends. It's better if we can have, as Christian has said, if the bone is there, the best part is to put in the same thing with screws. And what is required, as you have rightly said, sir, is that how long do they, and what is their functional outcome after 2 years to 5 years? Because that will define whether this fixation is going to be helpful, because otherwise we are, when we take out a trochanteric flip and then go in for a revision surgery, we see that a lot of fibrosis and things are there. So that's the thing which we have to critically analyze.
Yeah, that is what I say, regular monitoring.
Yes.
It will take time for it to come. So I come to the second case. And second case is, again, it is a very, very old case. And I might have, some of you have already seen this case. This is a 21-year female with a 4-month-old neglected injury. I have no CT, but radiology is very clear. There is no fragment which can be seen in 4 months. That fragment is almost lost. And that is the big question. In a 21-year female, let the other people who have not seen this can comment about it. What will be our options at this stage? It is a 21-year female.
Kristen, may I start with you, please?
Young age lady, yes, by all means, open reduction internal fixation requires a surgical dislocation because the front part of the head is gone. So seeing it from the back is not possible. So you need a Cochlear-Langenbach to repair the wall, and additionally a trochanteric flip in the front to repair the front part of the head. So, but luckily everything can be done in a lateral position.
My point is there is no other fragment left in the hip. It is absorbed.
Oh, it is absorbed.
4-month-old injury, nothing left. You have no fragment there.
This is
then
the only
total hip replacement. As for me, because total hip, we know it's a very good surgery. Even in 21 years old, you can put in a ceramic head. They will survive for 30, 50 years, no problem.
May I request Professor Park and Dr. Sawaguchi to opine on this, please? Would you do anything different?
It depends on the deficiency of the posterior wall. And if there is some posterior wall remnant and they can stabilize the head, I will reduce it. And to put the head into the acetabulum, I will add varus osteotomy.
Okay.
Professor Park?
21-year-old female, is very young. I tried to avoid the arthroplasty and preserve the joint. We can do a total hip anytime later.
Yeah, I'd support Takeshi as well. I think a 21-year-old's very young, and people are excited by ceramics, but young people still, their hips, they fail earlier than older people. So I think an attempt at reconstruction may be a better option with the salvage as a hip down the track if it doesn't unite.
Would you think of anything specific, Marinus, to salvage the head with a resolved head fragment?
You'd find the fragment, wouldn't you? I mean, so in America, in North America, they're using little allografts and matching them now and putting screws into them in order to provide a round surface. That's what some of the, Steve Sims and the guys over there are doing. But
the fresh frozen allograft.
The fresh frozen allograft, correct. That would be the only salvage if you couldn't reconstruct it on your own. Otherwise, you're left with a very malfitting head. But sometimes you're genuinely surprised when you put it back and you try and reconstruct it, that it's a little better than what you think. But I suspect, Ramesh, I've seen this case before, so I don't want to say too much before you surprise everyone.
So this is exactly what Marin is told about. I use a fresh frozen graft, matched to the size, and put it over there and fixed it up. So this is the only operative photograph, because the rest I somehow lost those photographs, but this was the only one which I did. And with this is the fixation after the surgery, and this is after a month. We made her to sit up as such. This is after 3 months, where the fixation is still holding. Incidentally, we had reasonably good matching of rest of the things. She had a reason, but she has relative stiffness. You can notice it up over there. She's able to bear weight on the affected side because part of the head was okay. Then we got her MRI also. And incidentally, the MRI picture did not differentiate between a normal bone and the allografted bone at that stage. So this MRI, you can see it out on the either side of it. It seems to be similar, so it may be very difficult to comment about. And then this is after 2 years when she came to us. Now, she had again reasonable, a little amount of a stiffness on the side, but you can notice a kind of a, I don't know, the protrusion which is happening in the joint, which was not there initially. So I don't know, because she had no other systemic thing, nothing of that kind. And this is after 4 years. Now, let me show her ability to walk around. She had relative stiffness in the joint, but then she is able to manage her sitting, standing, walking. And now, now it's about 8 years over, we try to contact this lady. Now she is married, she doesn't want to divulge. So she says it's okay. She doesn't say anything about, she did not get any more surgeries right now. And that is what we could find it out, that she is now, it's 12 years old surgery. So she's still okay. She's still managing all her activities. She doesn't have any symptoms right now. But that is the kind of the situation what Marinis was taking. It is the same thing which we have done in this situation. And probably this patient, we have been able to avoid arthroplasty, at least for the time being. So there is a possibility, as Marini said, is of using allograft femur head even in a weight bearing area. And basically our aim was to keep the joint movements so that she doesn't get extra loaded on that area. So she has been able to maintain it. So any comments right now at the end of this case?
It is beautiful. How do you size the graph correctly and
so
shape it?
Yeah, incidentally, we had various graphs. So we tried to match with the size on the table and with the given graph. So whatever matched a bit, we put it over there.
It's very difficult to cut the graph to match it to the fracture.
So, but I've shown you the X-rays. I've shown you it could match.
It makes for a lot of common sense, because you use a lot of fresh frozen allografts for revision arthroplasty scenarios, and they do incorporate, and you land into situations where your revisions post allograft reconstructions are more simpler and easier to do. So it's absolutely logical to think of something like this, and it works. So 12 years is a very long period, and it's a fantastic result set.
So Christian, Dr. Sain is also an arthroplasty surgeon, and he has very good eyeballing skills. So that gives him the advantage of matching sizes.
Thank you, Jamal. Anyway, I go to the next case, which is actually not a part of this standard classification, and I have shown it number of times. It's a young girl, again 23 years, very young female, who was driving a scooty, got an injury, and after 2 days was shifted to the hospital where I was working at that time. And if you see it out, what is very important to perceive is that lower part of femur head is intact. It is the upper weight bearing area. In a standard Pipkin fracture, in a standard Brumback 1 and 2 fracture, it is the anterior-inferior area which is fractured around. But here in this typically cases, the upper area is involved. This weight bearing axis, this is involved. And that is what is seen on the X-rays also. You can see it out that it is the upper part, and that is not classified. We had seen all other classification. Brumback is one of the most exhaustive classification, but we have few cases of this type which are not there in that kind of a group of those things. So one thing is about getting into a classification, because we use children classification, we saw AO classification, we saw the old Pipkin, we saw the Brumback. This case does not fit into any of those things. Now our question, this thing was what to do. Obviously there is no doubt, I am not putting that in a question, what is to be done, it is obviously to be reconstructed. And these were the fragments which were in my hand, not one fragment. The whole of the superior part was there, separately lying, and whole of the medial side was there, separately lying. So these two gross major fragment. Now there can be opinion, how should we go for when the whole of the superior weight bearing dome is out with you.
I request Vivek to take this.
I know what has been done, but
Yeah.
But the thing is that yes, these fractures, they are the difficult fracture. You can fix them on table. I have had around 2 or 3 cases where Pipkin's 3 sort of a fracture were there, which I can say involve the superior part as well as the neck part or a partial, again, any other part of the femoral head. And the longest I have been able to make them survive is 3 years. And the smallest is around 4 months. So this is a case where I'll still try to salvage it, but with a very, very high chance that it might require an arthroplasty, because ultimately out of the 4 cases like this, which I have done, 3 have gone into an arthroplasty within 3 years of their fixation. So my opinion is slightly shifting towards arthroplasty now.
So can I proceed?
Does anyone have an alternative opinion? Who would salvage this hip? I just put the question to the entire house. Professor Savaguchi, Professor Park, Marinus, Sudeep, Christian, Abdel. Would somebody salvage this hip and or do a primary arthroplasty? Is the house divided on the issue, or is it a straightforward thing?
May I speak?
Yeah, please.
I will try to fix the head, and from this X-ray, inferior part of the femoral head is attached to the femoral neck. And if it develops a vascular necrosis, it will not be a total vascular necrosis. Then the avascular necrosis develop, then I can do a rotational femoral head osteotomy and save the joint. It's possible.
Okay.
Me too, I'll fix it. If the patient is young, there's something left to fix, I'll fix it.
All right.
So I proceed?
Yes, sir, please.
So this is what I did. I also tried fixing all the fragments together, got into that. So this was the plan, and these are the cases. But you know, this is 2 months later. And if you look at the X-rays, the sclerotic fragment, the upper fragment is totally kind of a sclerotic. So at that stage, definitely you know it, that now we are definitely learning for it. I got this MRI also, which also confirmed that we have got a dead articular area of this area. This is 3 months later. You can see those things are there. There is a kind of a fixation which we are just holding. I avoided weight bearing on the side. This is 5 months and it's still going on. But you see classically that fragment, the weight bearing fragment is becoming avascular on the radiology itself. 6 months later, you see all our fixation hopes are dashing down. And if you see this girl walking, this was the weight bearing she was doing after 6 months, which probably was too much for a young girl of 6 months as such. And this is 7 months later. Again, if you notice again, this was the, now her weight bearing is little better. But if you look at the X-rays, they look reasonably bad at that stage. And this is 9 months. Now at this stage, what we said that we will be fixing and things will get started going bad to worse. If you can see the amount of a restriction which she has got, you can see the kind of effort she has to make to movement, and now it is reasonably restricted. And if you look at the movement, now weight bearing on the affected side had become much better. Now she's comfortably walking around. But if you look at the X-ray picture, this looks like it could have been arthroplasty rather than forcing her to be in 11 months of that kind of a instability. One screw was troubling her. Definitely, we saw on the X-ray also. So we went in, took that screw out. It was after a year. We took that screw out. You can see the screw was bent also. And now, at this stage, after taking that screw out, we lost contact with the patient after that removal. She came 3 years later. And now she can sit, she can squat, and she was able to bear full weight. You can see there is no Rendlenberg, this thing also. Then we called her 7 years later. We could trace her from the telephones. And now you can again see at that time she had given birth to a baby. So she sent, these are all WhatsApp X-rays, what you are seeing. And this was the picture. Then this is now in the lockdown period, we again contacted her. This is 10th year now after the surgery. You see, she can sit, she can stand, she can walk. And you can see the head also. As Takeshi has told about it, inferior part took every care of the superior, whatever was left out. And the same head. Then we asked her how you are walking. I want to see her walking. And then she sent a video of her walking ability. So this was the outcome at a 10 years follow-up of this case. There is a literature, as Vivek has also told, about some cases of type 4 where we could have some kind of a outcome at some time. But as Takeshi is I'm very happy that he is fond of saving femur head, doing osteotomy. We have not done osteotomy, but we are still surprised that if the pain, she was never painful. That's one very important thing which was there. She had a stiffness of the hip. All problems were there, but she was pain-free. And once she was pain-free, she accepted that kind of a gradual loading. Today, she's very much upright. I told her, I am likely to show her this video to people. She says, I am so happy. You can show anywhere. I want it to be seen by everybody. That has been done to it. So now your comments, please.
I have a question. So what approach did you use? There is no trochanteric osteotomy in the...
Yes, this I have done, now you can say 11, 12 years back. At that time, it was a classically posteriorly accessed because that main fragment posteriorly, it was a standard KL approach.
Amazing result. So
Something should be left to nature.
is there a science to which fragments will revascularize and which fragments won't?
I personally feel we should equate it with kind of a Perthes disease, because avian is kind of a Perthes disease where the head looks to be bad. But if it's not painful, if it is getting loaded, there is a big space around that area. Only one screw was troubling her, rest of the screws were not troubling her. So I took that advantage that she's probably pain-free due to that cartilage giving her a kind of a shielding over that area. And eventually, there was a collapse, no doubt about it. But as Perthes, what happens? It becomes reasonably subsequently a calcified, ossified, whatever happens. The same thing has happened here also. And if she has been able to get back to her abilities to that level, I think that should be one of the ways to take care of these injuries. Even the X-ray picture might be so bad.
Can I ask one question, please?
Please.
Yeah. So the same thing. When I was talking of, let's say that I have experience of Pipkin's 3, not this sort of a rare fracture. In a Pipkin's 3, we are having a neck femur as well along with superior part which is there. So do you feel that the same thing will be happening, or because it's the inferior part which is giving the vascular supply and that's why it is acting as Perthes, that it is giving this? And in a Pipkin's 3, we still will be having those issues of failures, very.
I had 11 of these Pipkin 3 injuries. One case has survived to now, you can say about 9 years.
So,
rest all cases, as you said it, they had eventually gone for arthroplasty. I personally feel it is the lower part which kept on giving that support and viability to that upper fragments, and probably kind of a space which was the key in this case. And as I said it, the upper part acted as a good scaffold into that area. Because I had done, I think, 3 of these cases of the same type, and we are not unhappy with any of them. So this type of a fracture pattern, which is not described as a different outcome as compared to the classical Pipkin 3.
We have 3 minutes for discussion. May I just ask our esteemed faculty for any comments or questions if they have any before we move on to the last talk of the session?
Yes, the faculty here. Anyone use some biological augmentations? I don't have enough knowledge. Like things like platelet-rich plasma, even stem cells or drugs that can help the revascularization. Anything works.
Use in my hospital, we developed the metabolite, so the conditioning medium or secretome to enhance the or improvement to treat the avascular necrosis. So usually combine it with the derotation osteotomy and cord decompression. We usually put the secretome or MSC conditioning medium. That, and also the one thing for the case of the Pipkins, the one of the also the good experience is if our patient can reduce the weight. So the body weight is very important. If the patient can reduce the weight, that's also one of the important successful salvage. That's the one of the experience in our patient. The thing on that case is the weight of your patient performance. I believe your patient is the weight is little bit decreased. So that's why no wonder he can succeed until up to 10 years. I have the patient like he can decrease the weight until 20 kg. 20 kg, and then the patient can squatting and also jumping and etc.
So may I ask you and Professor Sawaguchi, what are these cases where you will choose to do an osteotomy, and which particular osteotomy would you do?
First, we have to understand that necrotic bone never collapses. It only collapses when the revascularization occurs and the granulation tissue try to reabsorb the necrotic tissue, necrotic bone. Then the head collapses. If it's not under the pressure, for instance, it is rotated to the non-weight bearing area, it will not collapse and it will heal. That's the concept of osteotomy. So in this case, there is a good bone in the inferior side of the head that's vascularized. And at 3 months, if you check with MRI or SPECT bone scan, then you can find that a vascular area in the superior part. Then you can decide to rotate the femoral head. At that time, there is no collapse. And if this area is brought into the non-weight bearing area, they will heal. And intact inferior part will come up to the superior side, and you can preserve the joint.
Takeshi, it's Marini here, but when you're thinking about that, it makes you nervous to think about doing a Sugioka type osteotomy when you've already had a significant Pipkin fracture that's taken off the top of the femoral head. I mean, it just creates a nervousness because you're interfering with the blood supply to the inferior segment, which was you were so dependent on for structural stability.
No, this rotational femoral osteotomy, you have to keep the posterior column artery. As long as you keep the posterior column artery, the inferior side of the femoral head is well vascularized. But if you damage the artery, the surgery is totally finished.
Right.
So you have to be very careful to protect the posterior column artery. But if you protect and bring that intact area to the weight-bearing zone, then it will work.
A question to Marini. I once heard a lecture of Mark Esser when he showed a series of using hemicaps in the femoral head. Is he the only Australian who does that, or there are other people doing that?
No, we do them sometimes, Jamal, but very few, very off-label, with special application to the Therapeutic Goods Administration, because they're we don't think they do well. They're really an attempt at salvage.
Yeah, because I've never seen those being presented anywhere besides by the Australians.
Yeah, there were quite a few that went in, and then there were quite a few that were revised down the track. So,
okay.
Great discussion, great cases, and certainly 12 years is a long time for great results. So may I just request our last speaker, Professor Sawaguchi, for his talk on combined ring and acetabular fractures.
Can you see?
Yeah.
Yes. I will discuss about a combined ring and acetabular fracture. This is my disclosure. And the combined ring and acetabular fractures principles, and this is a not rare fractures. The reported percentage is 15.7 to 16.1%. But frequently, either one of them is insignificant. So we can focus mostly on one fracture. And sometimes this is a polytrauma patient and resuscitation first. And pelvic ring needs stability, and acetabular fracture needs anatomical reduction. This is the case, first case. 50-year-old male, pedestrian hit by a car, and general start intact, and this patient was referred to us 1 week later. So please look at the X-ray carefully. Any comments?
May I request Christian for you to go first?
It's a open book kind of injury, but I don't see any as obvious acetabulum fracture. Even the talk is titled acetabulum. So of course we'll get a CT scan here later.
It's
like
on the left hip, there is a left hip. It appears as a posterior column or evolved sort of a fracture.
Absolutely.
On the left hip side.
Yeah.
Yeah.
So besides the symphyseal as well as the right side SI joint, which Christian has already said, that we can see on the left side, there appears to be a transverse with posterior wall or something which is there, which is where you can see the break in iliopectineal and ilioischial, which are undisplaced.
Good point. Good point. Yeah. So the diagnosis can be open book, right SI, and the symphysis, and maybe left hip acetabular fracture. Posterior wall is some part is missing here, and also something in here is a part of the femoral head. Outlet and inlet. Now we can see the fracture here.
Yeah.
And right SI is open a little bit, and symphysis disruption. Oblique view. Posterior wall fracture. And some fracture here. This is CD. Right SI opening. And left side, wall fracture. And fracture going from anterior to posterior. So the diagnosis can be?
Seems to be something happening in the head as well.
Femoral head also interiorly, there appears to be some fragment.
Convoluted posterior wall. The fragment that we can see in the AP view, the small fragment inferior to the head.
Okay.
So the diagnosis is pelvic ring, right SI, symphysis disruption, the left acetabular transverse plus posterior wall fracture, and femoral head 51. Is it correct?
Yeah.
Okay. So surgical planning, which side first? Acetabulum SI symphysis.
I request
So
Christian to take. Sorry.
Yeah, thank you. So I think the most displaced part has to be fixed first. That's in general. The most displaced part in this patient is the symphysis. So I will go for the symphysis first. And then at the same time, I can also do the SI joint. Just a screw will do. Well, I can also flip the patient lateral or prone and do the posterior wall together with the SI joint screw. That actually gives me better chance to reduce the SI joint better. For the Pipkin one, I would just leave it alone. The anterior column or the anterior hemi-transverse kind screw from P to A. So an anterior column screw would be okay. And posterior wall, typical plating fixation.
Okay. Any other comments?
Same.
Or agree?
Yeah.
Okay. So approach and which first we have discussed, and SI percutaneous and fundus steel and posterior approach. Is it correct? This was done. Percutaneous SI screw and then symphysis plating, and put the patient in a prone and head fragment removed, and the posterior fixation of the column and wall.
Very nice session.
Takeshi, you did the SI screws first. Can you just share with the participants why you did the SI screws first?
Yes, it's basically the reconstruction is the rule is reconstruct from the posterior side. If you cannot reconstruct the posterior side well, then their displacement is magnified on the anterior side. That's the reason we start from posterior side.
Was it right open at the back? Because there are some that may argue in the participants that you could just plate the front and you may be able to avoid the sacroiliac screws at the back.
Yeah, it's possible. Which do you think is beneficial for the patient?
I think it's more stable with the screws. I agree.
Yeah, so the other thing is that if you plate the front, it allows you to do an anatomical reduction of the ring from the front, and it's just a percutaneous screw. Whereas there is always a chance of leaving behind some degree of opening if you do the posterior fixation first, unless you do an open reduction. So that's one argument in favor of going front and plating the ring first. So it's a very well done job. So can't argue with success.
Professor Gucci, do you have some way to make sure you have good reduction of the SI joint when you fix it from the back, like a 3D C-arm or anything?
3D C-arm. This is other X-rays. It seems the posterior reduction is almost good. You see, it's not perfect. As you can see, there's some opening compared to the left side.
Yeah.
Yeah. But can you close it?
So have you got any tips, Takeshi, for closing it, like bigger screws with more compression force, or why do you think some of them stay open? Is it because of the position, prone versus supine, or?
I find using a C-clamp as a reduction tool for the SI very good, but it's kind of a massive tool to use. But it's very useful, especially when you have the vertical shear. Putting a C-clamp, holding onto the clamp and doing this can help the shear in some of the cases. But of course, the compression will also be useful in the C-clamp.
So that's the point I completely satisfied with this case. But the displacement of the transverse component of the acetabular fracture is minimal, so I can fix it. Mostly, I can concentrate mostly the posterior wall fracture.
Yeah, we can go ahead. I think Professor Savaguchi.
So, this is from this case is always think of the possibility of concomitant pelvic injury and acetabular fracture, because initial X-ray it looks like a simple lateral SI and symphysis disruption, but actually this patient had the hip dislocation and spontaneously reduced. And evaluate the image carefully, and pelvic ring needs restoration of stability, and acetabular fracture needs anatomical reduction. Plan approach, fixation, and its order. As a general rule, start from the posterior side, and frequently needs turn the patient. This is the first case. In the next case, 60-year-old male, fall from 10 meters, admitted to another hospital, and he had the right hemothorax, left distal radius fracture, and left sciatic nerve partial, but this patient was in shock. What do you think?
Christian, I request you to start.
Yes. Okay, so it's a typical acute injury, polytrauma. The hemothorax is most likely the most significant cause causing the low blood pressure. If the pelvic ring is not that badly displaced, but we will still follow the protocol, do everything. C-clamp or external fixator, this of course pelvic binder, and then angioembolization if necessary. Angioembolization if necessary means that if everything else doesn't work and the chest is already stabilized, we'll call in the radiologist to do that as well. Find some bleeding vessel and embolize. So that's the acute management. For later stage, I think we have the CT, then we can discuss more on that.
The resuscitation was done in another hospital, and this patient was put on an external fixator, and this patient needed a lot of blood transfusion. And they did angiogram, and they found out the rupture of a superior gluteal artery, and they did an embolization.
Do you have a contrast CT when the patient come in with a low blood pressure?
The patient was referred after resuscitation 2 weeks later. So the patient general condition is recovered. And this is the, how about the ring fracture? This is inlet outlet.
Vivek, your take on this?
Looks like that the high anterior column fracture or a high posterior wall which is going right up to the ilium on the back side, that is the first involving the dome of your hemipelvis or the false pelvis which has come out. The second thing is the quadrilateral plate region which has gone inside, and that was the reason which has caused that superior gluteal artery to get ruptured and cause the embolization part. And there are pubic rami fractures. So it might be sort of a T-type fracture going down with a quadrilateral plate and the high column going up to the ilium posteriorly into the PSIS. It requires mostly an anterior approach, and you can go in through an ilioinguinal or through the lateral and the stopa window and fix the quadrilateral plate, as well as put in screws from the sciatic buttress which are holding the anterior column. The external rotated hemipelvis can be derotated at the same time and fixed.
And this patient, the CT, you can see that the crescent type of fracture.
Crescent is also. That's right.
And
That's
also
right. Sorry.
some comminution of the compression fracture of the sacral ara.
Yeah. So there also you can put, this is a day type 1 as was shown by Ismail. So you can go anteriorly in the same anterior approach and fix your plate towards till the sacrum ila and get the fixation.
But can you fix the plate for this comminuted ara?
That is a problem, I agree. But many a times if it is slightly combination, I'll see the exact in the CT scan and my plate might go in deeper inside with the screws. or we can use a edge sort of a plate which will hold there. That's it.
Okay. Then the acetabular fracture can be which type?
Christian, may I request you to take this one?
This is a really good exercise. I do this for the trainees, but it gets difficult. So you look at this, there is a big chunk of the dome still intact, but that part, if you trace it up, it's not connected to the spine. So definitely the anterior column is gone. So we can cross out number 1, cross out number 2, cross out number 3, cross out number 5, 6, 7 is not, 8 not, 9 still possible, 10 still possible. So we get number 4, anterior column here, number 9, anterior posterior hemitransverse there, both column still there. So, and then we will ask ourselves another question: is the posterior part intact? If not, how is it broken? So just by looking at this, can you see any posterior? Yeah, there is definitely something traveling posterior. So we cross out number 3. So the 2 things remaining are number 9 and number 10, anterior posterior hemitransverse, or both column. So we ask the third question: in the posterior column, is it a transverse kind of fracture, or is it a column kind of fracture? So it might be a little bit difficult here, but you can trace the line going back. I will have to bet on this. It's more like a transverse kind in the back, but I'm not very sure. I need other views or either the CT scan to tell me that.
Any other opinion? Because we saw that there is a crescent type of fracture. The whole acetabulum is not connected to the spine.
Yeah.
So more of
by definition, it should be
both columns.
ABC sort of a fracture.
If the posterior side is intact, I mean the crescent fracture is there is no crescent type fracture, it can be anterior plus posterior hemitransverse. This is iliac oblique view. CT. Of course, there is a transverse component and anterior, but it's not connected to the sacrum. And so, as you can see, the diagnosis is pelvic ring, bilateral pubic fracture, left crescent fracture, and left sacral ala fracture, and acetabular both column fracture. So it's the sacral ala is comminuted. It's not a small comminution. So how about your surgical planning?
Vivek, may I request you to take this one?
Approach and which first?
It will be difficult to say because the crescent fracture is one which is causing the issues out there. The sacrum appears to be broken, but I still might try to put in my plates going into the sacral ala because that helps me to get my entire reduction done through anterior supine position. Otherwise, for that crescent fracture, I need to go back and fix it first, and then come anteriorly and fix my quadrilateral plate and this part. So I might try to reduce it with a shank spin, the externally rotated hemipelvis or the part of that anterior part. Reduce it. Try if iliosacral can go, which I doubt. So I will put in a H type sort of a plate holding onto the anterior sacral ala going into the, and put one screw from there going into the PSIS, which is holding my crescent right in that plane, top to bottom from anterior to posterior sacral, and then fix the anterior column with intrapelvic approach from the quadrilateral plate region.
Okay. Any other opinion? These are the approach and fixation I can think of. Proximal SSI screw, ORF reunion, posterior approach, ilium posterior plate, ORF Coca-Langenberg, posterior approach, ilium posterior plate, ORF reunion, and posterior bridging plate plus ORF through Kokarang in back, and posterior bridging plate ORF through ilioinguinal approach, and ilioinguinal approach anterior side plating and ORF faster. And Vivek mentioned the number 6, right?
Yeah, you can do it, or you'll have to see, because if I go from anterior side, I might fix the pelvis also with the pubic ramise from that intrapelvic approach. So that's my single approach.
So can we just have an opinion of these so many faculty members we have here on what they would do? So Christian, Vivek has expressed number 6. Christian, what would you do?
It's still complex to me. I want to go back to the X-ray, just at the 3D. I mean the 3D reconstruction. Yes, this one. This one. So it seems to me that most of the displacement is in the crescenteric fracture. So that is the first thing to reduce for me. I always go for the most displaced part first. To reduce that, it's easy from the back, not so easy from the front. So I will go from the back first, everything from the back, including the Coqueling back from the back, and then finally complete with the front.
Okay.
Okay. Ismail, Professor Rak, and Dr. Sensor.
For me, in my opinion, I will do start from the pelvic. So from the peripheral strategy to the central. So I start with fixing and reduce the iliac wing fractures. That's the vertical, that one, with the screw and then plating. And then follow with
front or back?
From the front, supine. From the supine, and then plating of the anterior column plating and screwing. Yeah, if the reduction is good, usually if we do the good reduction of the pelvic fractures, the iliac wing fractures, if we can reduce well, so it will follow the indirect reduction of the acetabular. So if everything is good, we check under image intensifiers. I will do the posterior column screw from the front, from the supine, from one incision. That's my strategy. If not, so I will go to the back and do the plating.
So all anterior SI joint and pelvis first, periphery to center, and then reduce the acetabulum from the front itself and fix it.
Yes, that's from the peripheral to the central. That's my strategy.
So I can just one thing which I'd like to add out here, that this is a difficult combined pelviacetabular injury. The previous ones which we were having were hemipelvis of the other side which were fractured, and here you can see that the crescent and the acetabulum are on the same side. So that iliac part, if we are not able to reduce either on the back or on the front, we are going to have a bad prognosis of the acetabulum. So that fracture is the iliac anterior column is the crucial one. So whichever way the surgeon feels he can get an accurate reduction of posterior crescent as well as the anterior column superior dome, because that is one fragment. Minute malreduction on one side is going to hamper acetabular. So that is the critical way, whichever way we are able to do that.
Okay, let's proceed.
Would any of the faculty have any different opinion what they would do here other than what has been expressed?
My perception is that in this situation, this posterior column, it has separated from the sacroiliac joint, and that is one of the most difficult fragment to get back. And for me, because I tend to use iliofemoral and in a floppy lateral position, so that could be my option because I might have to go front and back. And for me, that very fragment of posterior column is one of the most difficult fragment to get back into position. So along with the alignment of the iliac wing, that fragment has to get back into that part of the sacroiliac joint. Only then the rest of the things will fall back.
And you would use an eccentric clamp to do that with an iliofemoral approach, sir?
Yes, yes.
Yeah.
Okay. Let's proceed. This patient had Moravera region. And a lot of fluctuation under the skin, and you can see. And I debrided. Does this change your plan? It's difficult to choose a posterior approach.
Yes, it does.
Yeah, yes.
So now the more sexy thing, I don't think it really works in our case, to do is the percutaneous, or everything for the pelvis, sometimes in this bed soft tissue. But you really need to be an expert in external fixator. Use the external fixator to reduce, send the patient back to CT, and a navigation, come back for a screw. That's very useful for the crysenteric fracture, I think, and whatever column fractures. But for acetabulum joint, I still have some reservation.
Okay. So do you fix the right pubis?
Yes. Screwing, pubic screw.
If I am finished with everything else, then I'll go there and fix it.
Can you have a good reduction of the right pubis? Because the reason why I'm saying that the sacrum is the compression fracture, and you can't reduce perfectly. And there will be some displacement in the suprapubic, right suprapubis. So I wonder if you can have a good anatomical reduction of the right pubis. So this is again 3D CD. You see that the sacral ara is comminuted. But as the Vivek said, that inferior part of the sacral ara may be intact, and you can utilize it for fixation. This part is comminuted, but you can utilize the good bone lateral to the foramen. So I decided, as the same as Vivek, anterior approach and fix the SI and crescent fracture and the acetabular fracture. And intraoperatively, I could see the superior gluteal artery rupture. I could really see the foramen and the lumen of the superior gluteal artery. This is the first time for me, and the last time maybe. And this is the fixation of the crescent fracture and the acetabular fracture. And I didn't fix the superior pubic lamps because I think that anatomical reduction was not possible. So the fixation of the SI plate is I developed 20 years ago, and I've been using for SI fixation. It works, and it gives a good stability, and it can help to reduce some type of the SI displacement.
That's a nice place to. That's a nice plate, Takeshi. It's just hard to find because you don't have to go so medial. It's actually a lot safer for the nerve as well, but very difficult to find that plate. I was looking for it the other day.
I can use the 6.5 screw for sacral ara, and it gives a good stability.
Yeah.
And this is an oblique view and good anatomical reduction. Inlet, outlet, and CT, the good reduction of the crescent fracture and SI, and also that stubborn. And this is the 3D post-op. 1 year and 2 months, but you can see that some overlapping of the pubic fracture, but the patient complains nothing. So I didn't care about this. But maybe you could put some plate or screw. This is too oblique. So the message from this case is read AP X-ray carefully and pelvis check symmetry and sequential reading, and acetabular check landmarks as the Chris has showed to us. And if the information is not enough, check additional images, especially CT, and careful preoperative planning is mandatory. And selection of the approach is determined by the fracture types. And softest condition should always be considered. Thank you for attention.
Great cases, Mr. Sawaguchi.
The time is out.
Excellent cases. We are bang on time. Thank you very much for to Vivek, to Christian, to all the faculty for some fantastic cases. And over to you, Marinus and Dr. Jamal, for your closing remarks.
It's been a terrific day. I've been impressed with everyone's energy and their cases and their honesty. And I think the nice thing about the APOA is we get to see a group of cases from all across the region with different approaches, but everyone is trying to give the patients the best outcomes. I'd like to thank all the faculty, all the moderators, all the panel, and all the executive and the officers of the Asia Pacific Trauma Society. I think it's been a great weekend. It's a nice proof of concept that we can use this modality, or that we can use hybrid modalities in the future, where we can deliver educational content in a relatively user-friendly, relatively comfortable modality, where you can do it from home or from the office without the need for travel and accommodation. And somehow we have to combine a little bit of this and a little bit of the in-person connection, so that we can have a healthy society moving forward. So thank you very much. We are pleased, for those of you that are not members of the Trauma Society, please think about joining, because it'll help us deliver even more programs to you. And if you're in any of the countries where we have chapters, please look up your chapter representative on the Asia Pacific Orthopedic Association site and make contact with them and ask them how you can get involved. So thank you very much. And I'll hand over to Jamal, our General Secretary of the APOA, a hard worker, legend, very quiet and humble, for the final words.
See, the last thing that Marini, you said, I saw the smile on Dr. Ramesh Sen's face and Dr. Trika's face, which meant, hey, Marini, that's all crap. Anyway, thank you.
It's all true, Jamal. Don't listen to them. It's all very true.
Thank you, everyone. Thank you, Christian, and especially the invited faculty. You've been a great help, Professor Sawaguchi, Dr. Ramesh Sen, Adele, everybody else. Thanks a lot. And yes, we do hope that in the future we will be doing these events on a yearly basis. But the only thing, when hopefully we are in a better state of the world, we would invite you to come to a particular place and then do an online congress from there. So the faculty goes for a nice vacation for 3 days and the audience is online. So that's the hybrid thing that I have in my mind. Okay, so because if we go into complete online congresses in the future, then maybe there's no point in being in an organization. What do you say, Dr. Trika?
Event, it really helps us to take out the time, because the timing for transport and shifting and going to a hotel is taken out. But yes, it has to be a mixture of it, because the camaraderie which we share, the spirit of the organization, it develops with the personal and physical get together as well. That also plays a major part. But this can definitely be a part of online training and education. And this format was excellent, of case discussions with which we can listen to various views from all the persons. I congratulate everyone, especially the organizers of APOA, Trauma Society, and Dr. Anup for this.
We were keeping a tab on all the 6 sessions to see the audience on the APO platform, the Facebook platform, and the Ortho TV platform. And incidentally, this session, the 6th session, had the highest audience of all the 6. Maybe it was because of Sunday, or maybe it was because of the 5-star speakers we had in this session. Thank you, everyone. Thank you very much. Have a great.
Thanks for having us. Thank you very much.
Thank you.
Stay safe, and we'll catch you soon sometime.
Thank you.
Hi, Marini, want to add one more thing, no? Marini, can I say something?
Absolutely. Anup, as the Vice President, you're very free to say something. Thank you.
So let me take this opportunity to thank especially Marinis, Christian, and Jamal Ashraf. So they were the force behind organizing this everything, putting up everything right, finalizing the faculty, the talk, the format, and everything. So they need a big round of applause from all of our panelists and all faculties. So thank you again, everybody.
Okay,
Thank
bye-bye.
you, Nat.
Thank you very
It was
much.
really
Bye-bye.
wonderful. Bye-bye.
Bye-bye.